One check, okay? Check this one. One check. Check. Check this one. One check, okay? Check. Check this one. Check. Check this one. One check, okay? Hello, hello, hello. One check, okay? Check. Check this one.
जैसे थोड़ा कॉलर माइक और वो प्रॉपर अरेंजमेंट है ना,
कल से बेटर है।
बेटर ओम ना काट
नहीं आ रहा है। रवि आया क्या? आया आया बोले। अभी जो केबल दिया ऑफिस में गया, अभी जो केबल दिया तो इधर डाला इसमें।
हाँ उसको पूछ 9 नंबर पे डाला बोल रहा था ये वाला
9 में क्यों डाला?
ये वाला देख इधर ये डाला देखो कपड़ा का मेरे को मालूम पड़ता है कितना भर के डाला इधर किधर देखो
One check. Check this one. One check. Check this one.
बात करो Hey, check 1, 2, 2. Hey, check. Hey, आया? Hey, check 1, 2, 2. Check, hey. Check. Hey. 500 रुपये लगेगा. हो गया ना? नॉइस नहीं आ रहा है ना अभी? Hey, check 1, 2, 2. Hey, check 1, 2, 2. Hey, check 1, 2. तुमको आ रहा है? क्लियर है ना? पर इनको ये चाहिए ना भाई, ऑक्स चाहिए ना इनको. पर इतना लेट क्यों आ रहा है? डिले तो आएगा यार, ऑनलाइन जा रहा है ना वो, डिले तो आएगा. मैं एक्सेलरी दे सकता है, पर वो उधर ऑक्स लगते हैं, 3.5 का जैक लगते हैं. चाचा Hey, hey, hey. Hey. Hey, hey, hey. Hey, hey, hey. Hey, hey, hey. Check 1, 2, 2. 1, 2, 2. Hey, 2, 1. Check. Hey, hey. Check 1. Sound check 1, 2. Hey, hey, hey. Check 1. 1, 2, 2, 1, 2, 2. Hey, check 1, 2, 2. Hey, check 1, 2, 2. Check 1, 2, 2. Check. Hey. Check 1, 2, 2, 2. 2. Hey, hey, hey. Check 1. Check. आया Hey, check 1, 2, 2. आ रहे रवि आ रहे होल्डर नहीं है उसका ला रहे हैं आ रहे हे 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 check हे 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 check
Good morning, everyone.
चलेगा
Good morning, everyone.
great pleasure to welcome all of you to this AAOS 10th Trauma Conclave 2024. Trauma Conclave has been one of the most successful program, and orthopedic surgeons across India have attended this event in a big way. This is our 10th edition. Our association with AAOS started with this event in 2014, and since then this program has happened every year except the COVID year, that is 2020. This annual orthopedic program has consistently delivered top-notch trauma education, and we are excited to continue this tradition. We invite you to take most of this opportunity to interact with esteemed AAOS and Indian faculties, share your valuable experience. I would like to express my sincere gratitude to ALKEM, our program sponsor, for their unwavering support over the years. Their commitment to deliver knowledge-enhancing educational programs for a medical fraternity is commendable. To begin our program, I would like to invite Mr. Sunil Pathak, President of Semi-Chronic Business at ALKEM, our Program Director, Professor Mandip Dhillon, our esteemed AAOS faculty, Dr. John Wickstead, Dr. Paul Toogood, Dr. Christina L. Bolton, Dr. Robert David Golden, as well as I would also like to invite Dr. Nilesh Talwalkar, President of IMA Tiswadi, to come on the stage and start this program with lamp lighting ceremony. I invite all of you on the stage.
वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्। या कुन्देन्दुतुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती।
I would now like to welcome our Program Director, Professor Mandip Dhillon. We all know him very well, but it is my privilege and honor to introduce him. He is currently a professor and head of Department of Orthopedic Surgery at PGI, Chandigarh. He is also the head of Department of Physical Medicine and Rehabilitation and consultant in charge of Sports Medicine Clinic of PGI. His focused interest on sports injury medicine. I would hand over the mic to Dr. Mandip Dhillon to say a few words, and then we proceed ahead.
I don't want him to tell you how old I am. So let's skip all that. Thank you everybody for being here. And I'll have to start in a certain order. Firstly, I'm going to start the American Academy of Orthopedic Surgeons, who's been associated with this program for 10 years. And I've been associated with many of you over the last 10 years, made long-lasting friendships. And as Tarun was telling you, this is the 10th trauma conclave. And we seem to be getting a better and better feedback every time we do this. And this time we've also got some CME credits thanks to the Goa Medical Association. And we're going to take it forward. My job today is to thank the contributors. From India, the academic contributors being Dr. Jayashankar, P.V. Jayashankar, Dr. Rajesh Malhotra, Dr. Vivek Trikha, Dr. Sameer Agarwal, Dr. Ajit Kumar, and of course, if I have not mistaken, who have I left out? I don't think. Sameer Agarwal, Rajesh, and the senior faculty who come and help us every time, ranging from Dr. Ram Prabhu, Dr. Dilip Shah, Dr. Sangeet Gawale, Dr. Chetan Pradhan, and Dr. Sandeep Patel. It would also be my pleasure to personally thank Dr. Nilesh Talwarkar, the IMA president here, who has coordinated with us to get the CME points. And of course, the audience, who is always here. I don't mean the beachcombers who are not here, but the guys who are here in the first lecture to sort of be with us for the rest of the day. I know by 10 o'clock the whole hall will fill up, because I know for a fact I'm going to shut down the breakfast. So they're going to be here. And I cannot leave the stage without thanking ALKEM. Their team and the Insignia team who does the things have been excellent. Over the last 10 years, I have learned so much that you just have to give a suggestion, and both these teams coordinate things so well that it's so nice of them. Thank you so much. The American faculty will be introduced by
Thanks. Thanks for your kind words, sir. You have always been a pillar of strength for us. I would now like to invite our AOS colleague, Dr. John Wickstead, on the stage to say a few words regarding AOS.
Thank you. Thank you so much. I think I had a few slides. So my name is Jack Wickstead from Boston, Massachusetts. I serve on the International Committee of the American Academy of Orthopedic Surgeons, and it's my true pleasure to thank the sponsors of the conference, ALKEM, and to be part of the 10th annual Trauma Conclave. The American Academy of Orthopedic Surgeons has had a long-standing relationship with India, and for many years we've been fortunate to foster professional relationships through the Trauma Conclave. I had the great good fortune to be part of this program several years ago, and really and truly, it's a tremendous faculty that you have assembled here. The Indian surgeons that I was able to meet and develop relationships with at the last time I was here have stayed with me over the years, and you know, such a tremendously talented group of surgeons that we have from India. So thank you for inviting our American surgeons. We clearly have far more to learn here than we have to teach. The American Academy of Orthopedic Surgeons was initially founded in 1933 with some 500 members. It's grown to almost 40,000 members. We currently have about 3,000 international members. For those of you who are organized enough to plan your calendars ahead of time, on behalf of the Academy, I would invite all of you to join us in San Diego. I'm not sure San Diego's as lovely a place as Goa, but it's close. I think the beaches here at Goa are probably better. But we'll be in San Diego on March 10 to 14th in 2005, and feel free to join us. The flight's not that bad, I can tell you that. I would also encourage you to consider submitting any of your research publications to the AAOS Global Research and Reviews. This is an indexed journal. It has a pretty good impact factor. The journal preferentially chooses international submissions. And for those who are submitting from overseas, it's a great way to get your work out there. The online learning platform is also available for members of the AAOS, and for anybody who's interested in membership, you can see this on the website. We have a pretty good online learning system with self-assessment exams and plenty of content. Lastly, again, my thanks to ALKEM for sponsoring our relationship here. The American Academy of Orthopedic Surgeons is so pleased to be part of this. It's been an ongoing relationship, and really those kinds of relationships are the ones that work the best. You know, year after year, we have more surgeons who are able to attend, and I appreciate the opportunity to be here today. Our faculty from the United States, I'm sure you'll get a chance to meet them. I would encourage you to speak to us at the break and get a chance to you know, meet us a little bit. Dr. Bolton comes to us from the University of Arizona. She currently works in Tucson, has come via shock trauma. Dr. Toogood is currently an associate professor at the University of California in San Francisco, so no doubt we'll be seeing him at San Diego next year. Dr. Golden is the chief of orthopedic trauma in Washington, D.C., and myself, I work at Beth Israel Deaconess Medical Center in Boston. So again, I'm really looking forward to today's program, and hopefully it'll be very interactive. Thank you very much.
Thanks, Dr. John. We move in with our video by AAOS. Can we play the video? And then we move to our sessions. Okay. Are we able to play the video or? So now I would like to invite Mr. Sunil Pathak, Vice President ALKEM, to say a few words, and then we move on to our sessions.
Thank you, Dr. Tarun, and as I speak between the AAOS video and me, I welcome each and everybody present here. And as we say in our Indian tradition, Atithi Devo Bhava. So it's time to welcome our course director from US AAOS, Dr. John, Dr. Paul, Christina, and Robert. And also the last 10 years and more than that, in fact, in between we have a 1 year which we could not do it because of the COVID. Dr. Mandip Dhillon, from the bottom of our heart, from the behalf of the management, the way you have supported us. And Dr. Rajesh Malhotra also continued to do that from his rich experience, personal level also. So my request to each one of you that whatever we can do it, you know that last September we could not fix the program. We have to extend. Apologies for that, but which was beyond our control. But yes, when we are all here, almost 600 plus orthopedicians, we request you to please play your role so that we can do it something better next time. When it comes to the ALKEM, from the management point of view, we are focused on this bone health solution. Our dedicated solutions, which is coming from the engine biosciences, is now the next level. We are working. Our 4 maps are already in the market now, along with the teriparatide, adalimumab, and also denosumab. We are happy to announce that almost 70% of the Indian denosumab which is going in the market comes from our plant, Indian Biosciences. And this was only a commitment because when we started working 10, 11 years back, so beyond the PAN and the PAND or the GEMCAL, we understood that the solutions will be different when we move forward. So thank you so much being with us. We will do our best to make you comfortable here. And over to Dr. Tarun.
Thanks, Mr. Sunil, for your kind words. Yeah, we'll now start with the AOS video and then move to sessions.
Chair of the CME Courses Committee at the American Academy of Orthopedic Surgeons. I want to welcome each of you today to our educational program. It's my incredible privilege to represent and speak on behalf of the AAOS. The Academy is the preeminent provider of musculoskeletal education to orthopedic surgeons and others around the world. As an organization, the Academy has more than 38,000 members worldwide, including more than 2,800 members from outside the United States. The AAOS has produced thousands of hours of innovative education and believes in lifelong learning. Our continuing medical education activities include a world-renowned annual meeting, multiple continuing medical education or CME courses held around the country and at the Orthopedic Learning Center, and various medical and scientific publications and electronic media materials. Since 2017, we've been working closely with our partners in India to bring forward-thinking programs and clinical medical education to help surgeons develop new skills and enhance knowledge related to day-to-day practice. We're also pleased to have worked closely with those in India to build skills for the future of Indian orthopedic medicine. The Academy is pleased to be with you every step of the way, focused on helping you to deliver the best possible care to your patients. Once again, I welcome you all to today's program and wish you all the best in your educational journey. I look forward to seeing all of you in person at our next annual meeting or at one of our OLC courses. Please visit aaos.org to learn more.
Now we begin with our sessions. The first session is on foot and ankle, for which I would request Dr. Dilip Shah to chair this session. We all know Dr. Dilip Shah is a senior consultant orthopedic surgeon from Mumbai. He has more than 4 decades of experience. He is the winner of the highest fellowship of SICOT, an instructor AO course since 1985, awardee of AO International Fellowship to Germany, and a winner of National Fellowship in 1989. He is a recognized professor at the University of Mumbai, an examiner for postgrad exams, and also a recognized inspector for recognition of hospitals for postgraduate teaching. He is the editor-in-chief of the international journal ASOR and editor for the Journal of Orthopedics. He is the main coordinator for more than 48 cities in India and moderator of Saturday night webinar CMEs with AOS Rosemont, Chicago. He has many publications and paper to his name, which has been published in reputed journals across the world. Thank you. Over to you, Dr. Dilip Shah.
Check. Good morning, everyone. And I thank Dr. Tarun Jain and ALKEM to introduce the wonderful faculty with us today. And our association with ALKEM and AAOS has been more than 10 years, and I'm sure the deficit of last year, which was not there, will be compensated by more than double the knowledge we'll acquire. About Dr. Mandip Dhillon, in fact, Dr. Tarun Jain started with 2 lines, so I'll start with the 3rd line of that. He has focused interest on sports injury management, arthroscopic procedures, joint replacement, sports medicine, and foot and ankle surgery. He has more than 550 major publications to the credit and has presented at international meetings more than 500 times. He has authored 5 books, including the AO Manual of Foot and Ankle Fractures. He is the editor of the Journal of Foot and Ankle Surgery, Asia Pacific and...
Dr. Dilip, let's not bore the people.
Are you sure? Because I've been assigned to do it. Anyway, we go ahead with this topic, and over to you, Dr. Mandip Dhillon.
Thank you, guys. Being the program director, I can take some liberties. In India, we have a disease also, in addition to foot and ankle surgery, which is known as addicted to telephone disease. Those of us have got a phone in their pocket, please put it on silent mode, number one. I know the cops in Goa, so I've got some plainclothes guys sitting over here to confiscate phones which ring. You'll get that back tomorrow evening. Okay, so, you know, I'm going to be talking about something which some people think is complex and some people think is not so complex, which is an ankle fracture. Everybody, whether you're a foot surgeon or a general surgeon or what, is going to treat them. And I bring you greetings from Chandigarh, which is up there in the north, in Punjab, in the foothills of the Himalayas. Now, if you look at outcome studies, do all ankle fractures do well? All of us have treated it. All of us know the answer, but I'm going to give you the literature. Despite good operative treatment, 36% will get some osteoarthritis. That's not good. We don't want that incidence in the hips or the knee, but in the ankle, this happens. I'll show you a few case examples. This one was something which we did in 2019. And within 4 years at the time of implant removal, he was degenerating. So the question now is, are we doing something wrong or are we not understanding the problem? So if we want to answer this, we have to remember two things. Some things are in our control and some things are not in our control. So what is not in our control is the amount of cartilage damage which the patient gets at the time of injury. What is the fracture pattern he or she presents with? What is the comorbidity? That's not in your control. But what's in the surgeon's control is firstly understanding the injury. Secondly, making sure that the reduction is accurate, especially focusing on the fibula, and giving a stable fixation so that you could get early range of motion, which helps the cartilage to regenerate. So now we come to the question, how do we manage a complex ankle fracture? I put the cat amongst the pigeons. So first thing, as I said, we need to evaluate the complexity in an ankle fracture. All ankle fractures are ankle fractures. How do we make them, or how do we understand which ones are complex? So the first complexity is in what we classify as a Weber A, which is a sort of considered to be a simple fracture. The complexity is on the medial side. Because of this vertical medial malleolar fracture, there is a possibility of marginal impaction, which is often overlooked, which is the precursor for early degenerative arthritis. So in this particular case, a 22-year male who fell down from a ladder, if you look at the CT scan, it shows you that the fracture is more complex than what was seen on the X-rays. And this will be shown like this, because you'll see there's a gap, there's a depression, there's a vertical split. And that's why this gentleman needs to be taken up from the medial side. The whole medial malleolus has to be opened up like a book to see inside. And when you see inside, you can see the depression. I'm not so sure it's coming across very nicely on the screens over there. But then you need to elevate that articular piece. And after elevating that articular piece, you need to graft it. It has to stay in place. And after you put in your graft, now your joint is reconstructed. You can see that the talus and the distal tibia have the same curvature. This may not be enough. So here you have to understand that you have to use the principle of a supporting screw. Everybody uses a raft screw in the proximal tibia to support the tibia from, so the same principle applies here. You need a support till this bone incorporate and the fracture unites. And this goes on to heal well at 6 months. On the other hand, A similar injury, which is done over here, again, a supination adduction Weber A injury, you need most times to buttress it. So a buttress plate and an oblique raft screw, which again will hold that depressed fragment in place, is what is needed. So in Weber A, which we consider to be perhaps the simplest types of fracture, the medial malleolus is the complex part. This is something we have to understand, and if you're putting in screws, they should be perpendicular to the fracture. You should put in a buttress plate, always graft a defect if it is significant. This is important to minimize complex problems. We move now to Weber B. So the second complexity comes when there is a Taylor shift, and the X-ray shows you no fracture on the medial side, but there is tenderness. So this suggests medial instability. And when I mean medial instability, I'm talking about the deltoid ligament, and there's so much controversy about us. If there's a medial malleolus fracture, everybody puts in a screw or a tension band wire. But if there is no fracture, and you suspect a deltoid ligament, by convention it was thought that it may not be necessary. But now we know better. We now know that if we stabilize the deltoid, sometimes we may be avoiding putting in a screw through the syndesmosis. We will come to that as we go along. So it is more and more of us are thinking of primarily stabilizing the deltoid when we suspect an indication and a Taylor shift. What do I mean? Now this is an SCR injury with pain, trauma, significant Taylor shift. You see the talus has gone with the distal fibula. The foot is hanging from the distal fibula. It's unstable. As you can see from the cops are coming for somebody whose phone is ringing. So this CT scan shows this problem. And of course, when you stress it, it shows the significant instability. So this guy has to be operated, and what we did was, through a posterior lateral approach, the posterior malleolus was stabilized, and a fibular plate was put in over there. And again at this stage, when the stability was checked, the talus is shifting again. So the complexity persists. A syndesmotic screw was put in, and again there is significant Taylor shift. So it means that we are not understanding on the medial side that the deltoid ligament is torn. So what we need to go is, you go in there, you identify the torn deltoid ligament, you scrape up and make up the smooth surfacing over there, and here we put it in with suture anchors and sometimes reinforce it with some fiber tape. And after the deltoid ligament reconstruction, when you've addressed the complexity on the medial side, the talus becomes stable. These guys can be mobilized early. There's a difference between mobilization and weight bearing, but the key point over here is, in these Weber Bs, recognize the deltoid instability, you have to maintain medial stability. And what do I mean by an ankle ring? I'll explain to you. Like the pelvis is a ring, you have to stabilize it from all points. The ankle is also a ring. You have to stabilize it from multiple places. Now the Weber C, everybody knows, is complex. The foot looks disrupted, the ankle is disrupted, everybody is talking syndesmosis is disrupted. I want to put in a screw over there. And this is exactly what the gentleman underwent. Great medial malleolus fixation, a plate of the fibula to length, and a syndesmotic screw. Kudos all around till he came to our OPD, and I think Sandeep Patel saw him when he had this significant pain, loss of ankle dorsiflexion, and prominence of the fibula. So when we got a CT scan, guess what? The screw had actually pushed the syndesmosis posteriorly. And there's this great avulsed Chaput's fragment which is lying there in the front, so we had to be reoperated. The plate had to be taken out, and it is our policy in our group of surgeons that we expose the syndesmosis through an anterior incision to make sure it is accurately reduced. The Chaput fragment was fixed with a screw. This brought the fibula into the right place in the syndesmosis. But since this was a neglected case, we still put in 2 screws in the syndesmosis to sort of hold it in place while everything healed. And this was done during the COVID times, and he sent us this video from his shack when he's doing overweight. Actually speaking, this month, in February, we've just published a new classification of chaput fractures, and to tell you how it contributes to the instability of the overall ankle ring. We'll talk about it later because I've got more complexities to talk about. One of the bigger complexities is fibular comminution. And when there is fibular comminution, getting the length of the fibula right is a problem. Oblique transverse fractures, you can reduce it. And this is usually in a pronation abduction injury where the fibula is pushed away, there is comminution, the talus is shifted, everything is going wrong. So here, one of the tricks, which even Paul Tornetta, I think, published many, many years ago, is you can fix the medial malleolus first. Simple fracture, which then helps you decide the length of the fibula. You can distract the fibula after fixing the medial malleolus, and you can get a correct length and rotation. And unless you do it, you cannot sort of get the syndesmosis in the right place. The fifth complexity comes from the soft tissues. You have lots of swelling, you have lots of polytrauma, and a simple looking ankle fracture can be bad because you can't operate them. So you have to sort of delay the treatment. This guy had polytrauma, and so the treatment, he was delayed for a few weeks when the CT scan shows it. So here, the complexity was the soft tissues, and he was operated from the posterior side. Everything was reduced, and because of this good reduction of the ring, there was no need for putting in a syndesmotic screw. Indirect syndesmotic stability has been achieved. Now, complexity 6 is something which is personal to me and after my own heart, because this is something I've been talking about for 20 years. What are these transitional so-called atypical ankle fractures? Now, this is actually a relative of mine who came from the Himalayas with this problem, overweight, diabetic. And we did a close reduction, waited for the swelling to subside, and we did an open reduction, fixation of the plate. We didn't have too much on the medial side, but the wires were good. All syndesmotic tests were done, stable. No need for syndesmotic screw. Tap on the back. Her husband and me went out for beers. Things were going okay. 9 months later, she had a minor stumble. When she had a minor stumble, she started developing pain. When she started developing pains, I am starting looking at the x-rays with suspicion. There's this double density. There's this posterior malleolar. At that time, in the early 2000s, I was not a routine fixer of the posterior malleolus. And when we did a CT scan at that stage, what we found was a disrupted plafond. It was an ankle fracture with central comminution, and while we were discussing what to do, within a month the implants broke. And she had problems. She was a diabetic. So I tried to do a sort of a simple kind of an ankle fusion, which also failed. And then we had to do this kind of an ankle fusion, and this is her now walking in 2023. A simple fracture made complex because of us not understanding the nature of the injury. So remember, atypical fractures are more complex. And any ankle fracture, the key part is to understand that the ankle, like the pelvis, is a ring, and you have to reconstitute the ring. Yesterday we had this discussion, anterior and posterior pelvis fractures. I don't want to immobilize only the anterior. I don't want to immobilize only the posterior. Same thing is correct for these fractures. Before I go, is that all? Remember, systemic issues can make ankle fractures complex. For example, geriatric populations, osteoporotic ankle fractures. You need biomechanically stronger constructs to fix all the elements. Do not leave anything over here. Because there is a technique which is popularized in the US by people like Vinod Panchbhavi and all, the fibula pro tibia technique. That this is held, the fibula is held next to the tibia by 2 or 3 screws, not for syndesmosis, but for stabilizing an osteoporotic ankle fracture. Neuropathic fractures, they are the worst, because when you fix them, they have very high failure rates and they go out like that. Big, big problems. So in osteoporotic and neuropathic ankle fractures, remember the rule of the thumb. Double everything. Double the fixation. Double the immobilization. Double the time to weight bearing. Get another surgeon also involved to make it twice. And you have to be careful to look after the soft tissues. So ladies and gentlemen, not all ankle fractures are straightforward. We have to recognize where there is a complexity and apply the sound fixation principles. We also have to recognize both the high-risk ankles and the high-risk patients, because both of them could add to the complexity. The key point is getting the fibular length and rotation right, because the syndesmosis will fall into place, and then you can stabilize the syndesmosis anyway, a screw or indirectly by fixing the posterior malleolus, Chaput, medial malleolus. Do not neglect the medial side. Just because you don't see a fracture there doesn't mean there is no complexity over here. We have to restore the trimalleolar anatomy. And thank you so much for your time.
Thank you very much, Dr. Pilla, for a wonderful presentation. Now, there are two choices as a course director. Would you like to have the questions right now?
One question while we are changing, and then later
Sure.
on. While we are changing this, we can have one question.
Somebody who is very eager to ask one question, please.
Yes.
Yeah, in order to save time, by the time somebody takes the microphone to ask the question, we have an excellent, not only excellent, but too good person.
1 second. There's a question there while Dr. Too Good comes up. Yes, sir. Or you
Yeah,
can
please.
hold the questions till the end of the session. Yes. Yes. Sir, size doesn't matter.
Okay.
And there's a lady here, as I have said, it, size doesn't matter. It only matters in PRP and other things. But it depends upon the fracture pattern, the degree of instability, and the degree of displacement which has been seen initially. Sarmiento also said that if you've got a displaced fracture, you can't displace it more, but you've got to get it back and stabilize it. Nowadays, it is our policy to invariably fix the posterior malleolus.
Okay, sir. Thank you, sir.
Thank you very much. If there are more questions at the end of this session, we'll have them. We have Dr. Paul Too Good, who is hailing from North America, and he is orthopedic surgeon who specializes in traumatic injuries and hip and knee replacement. He does adult as well as pediatric cases also. In research, Dr. Too Good studies the case of patients with traumatic injuries or arthritis. He focuses particularly on vulnerable patients, such as those with substance use disorder. Point to be noted. Okay, Dr. Too Good earned his medical degree at Case Western Reserve University School of Medicine, where he also completed his master's degree. He completed his residency in orthopedic surgery at UCSF, a fellowship in orthopedic trauma at Harborview Medical Center, and a fellowship in hip and knee replacement at the Mayo Clinic in Rochester, Minnesota. Dr. Too Good is a member of AAOS and AO North America. So he's going to talk to us about ORIF in calcaneus fracture. Over to you, sir.
All right, well, thank you very much for the introduction. And I guess while I have a second, I'll just thank all of you as well. I got to chat with some of you last night and this morning, and I've found you all universally welcoming to me, so I appreciate it. My first trip to India, and it's been a lovely one so far. So I'm going to talk about everyone's favorite fracture, which is the calcaneus. I think we would all agree on that. I'm going to talk mostly about how to get this thing reduced. I think, like all fractures, the most important part of the operation is the reduction. I think for calcaneus fractures, at least for myself personally, understanding the fragments and understanding what needed to be done took me a bit of time. It wasn't obvious to me when I first got started. So this lecture is primarily on how to get this thing reduced. I don't have any disclosures other than to say that I'm not going to tell you anything new and exciting. I'm going to tell you stuff that hopefully we have all heard before, and I'm just going to reinforce that to keep us all on track as we treat these problems in the future. So this is a gentleman I treated a little while ago. He was 22 and he was doing some things that 22-year-olds do and got in trouble with the police. And he tried to jump out of a window. And he had a couple of problems when he landed. He had a left-sided calcaneus fracture. He had an open right-sided calcaneus fracture with a talonavicular dislocation. And then some other things. But we're going to focus on his feet. And eventually that's interesting. Eventually he ends up getting fixed, I promise. Not sure where that slide went, but these are the things I'm going to focus on today. I'm going to talk very little bit about why bothering to fix this in the first place, and then I'm going to spend a lot of time talking about what needs to get reduced and what the sequence of that should be. So why bother reducing? You know, I think we all know that there are plenty of patients out there that should not be treated operatively for their calcaneus fracture. They are patients with risk factors like age, smoking, substance use, diabetes. There are a lot of people that should probably be treated with benign neglect. However, there are also good candidates for surgery, and those patients I think do benefit from surgery, although we've had a little trouble demonstrating that in the literature. But it's because they develop these problems with non-operative management. So the calcaneus gets short, it gets wide, their heel swings into varus or valgus. They end up getting subtalar arthritis, problems with shoe wear. So this is not a benign problem that should always be treated non-operatively. So let's now talk about what needs to get reduced. And this is basically a series of slides that goes over the pathoanatomy of calcaneus fractures. And I think understanding this is important, otherwise you really can't understand what the CT scan is showing you. These are all the things that occur when you break your calcaneus, and I'm going to walk through this step by step. So the first thing that happens when someone breaks their calcaneus is they get this primary fracture line. And this primary fracture line looks like this. Very rarely you'll actually see someone with only a primary fracture line in their calcaneus. It's not common, but I've had one or two. And this is a fracture line that divides the calcaneus into an anterior medial fragment. I've got AMF, abbreviating that. And then a posterior lateral fragment, or PLF. Okay? And this occurs because the talus drives down into the calcaneus, and it moves these two dominant fragments such that they rotate. And when that happens, you get these problems. So we all know how to measure Bowler's angle and the angle of Gisane. And both these things change and affect outcome when this primary fracture line occurs and moves. So I've got a tongue-type fracture on the left, and I've got a joint depression fracture on the right. And all I've done on these images in the schematics is I've covered everything up that makes them a joint depression or a tongue-type fracture. And when you do that, when you get rid of all the details of these two classic fracture patterns, what you see is they both start out with this primary fracture line. They both have a line that divides the calcaneus into an anterior medial fragment and a posterior lateral fragment. Okay, so we all start out the same. But then the next thing that happens in most calcaneus fractures is there is a secondary fracture line that gets generated, and often multiple additional fracture lines. So let's talk about those. So this is a joint depression calcaneus fracture schematic, and all I've done here is I've uncovered some of the posterior lateral fragment details. So there's still an anterior medial fragment and a posterior lateral fragment that have been divided by this primary fracture line, but now I've added in the secondary fracture line. And the secondary fracture line is just in the posterior lateral fragment. And in a joint depression type calcaneus fracture, that basically separates the posterior facet from the rest of the tuberosity. A tongue-type fracture also has a secondary fracture line. It's just a little bit different. That secondary fracture line divides the posterior lateral fragment into two essential pieces. It's just that fracture line is a little bit more horizontal, and it divides the inferior portion of the tuberosity from a superior fracture fragment that has the insertion of the Achilles and the posterior facet. So they both have a primary fracture line, a secondary fracture line. What differentiates a joint depression from a tongue-type calcaneus fracture is just where that secondary fracture line travels. So there they are, both with a primary and secondary fracture line. Of course, the next thing that happens in most calcaneus fractures is you don't just have two fracture lines, unfortunately. Things keep happening, and you get these additional fracture lines, and they don't typically have names, but they continue to divide up the calcaneus, and probably some of the most important additional fracture lines occur into the posterior facet. So this is, again, a joint depression calcaneus fracture that I've got schematically shown here. I've got a primary fracture line that divides the calcaneus into an anterior medial fragment and a posterior lateral fragment. There's a secondary fracture line that divides the posterior lateral fragment into two pieces, and then additional fracture lines just keep breaking this thing into multiple pieces. And this is where you get Sanders 2, 3, 4s. The same thing can happen to a tongue-type calcaneus fracture. You have a primary line, a secondary line, and then additional lines. So theoretically, when I fix a joint-type calcaneus fracture, one of the major things I'm doing is I'm just getting rid of these fracture lines. So I put the posterior facet together, and that gets rid of the additional fracture line. And then I put the secondary fracture line together, and that reestablishes my posterior lateral fragment. And then I get rid of my primary fracture line, and now suddenly you have a calcaneus again. And then the same thing is true for tongue-type fractures, theoretically. Okay, you have all these additional fracture lines, and so you get rid of those, and now you just have two fracture fragments again. You've got an anterior medial and a posterior lateral fragment. And then you just get rid of those, and eventually you have a calcaneus again. So all this is not really how it works. I'm about to go through how you actually do that. But it's just to say that calcaneus fractures, when you look at them on a CT scan with an untrained eye, they just look like a disaster. They look like a mess that no one could possibly put back together. But as it turns out, they happen in a relatively orderly sequence. You can recognize those patterns, and you can reconstruct them. If I can do it, certainly you guys can as well. A couple other minor things, or less focused on things. There can also be fracture fragments or fracture lines that occur in that anterior medial fragment that I've sort of been ignoring up to this point. So there are fracture lines that can divide that, where you divide up the anterior process away from the constant fragment, and also fracture lines that occur that go into the CC joint. So this is an example of that. So there's a red and a blue piece of bone there, and there's very commonly in the anterior process of the calcaneus going into the CC joint, the calcaneocuboid joint, there's a sagittal split there that divides that into more than one piece. And so if you don't know to look for it, you're not going to see it, you're not going to be able to reduce it and put it back together. And then finally, there's this thing called the lateral wall, which by itself is not maybe a crucial part of the calcaneus, but it serves to contain graft in my OR, and also it serves as a report card. And what I mean by that is at the end of the case, if you put the lateral wall back and it seems to fit everywhere, you maybe have done a good job putting your calcaneus back together. If you're sort of biting pieces off your lateral wall to get it back in there, the case may have not gone as well as you thought. Okay, so now I'm actually going to talk about surgery. So how I actually put these things back together. There are plenty of different ways to do this in terms of open or small incision or closed, but I think in general the principles of open reduction apply, and so that's what I'm going to go through here. So when I'm trying to get a calcaneus back together, there are a couple of principles that I keep in mind as I'm working. The first one is most of the time there's going to be this thing called the constant fragment, the sustentaculum, and that is constant because it's almost always there and it's almost always in place, and we sort of build back to that fragment. The second principle I keep in mind is that in general I'm going to work anterior and medial to posterior and lateral. So I start with anterior process stuff and I move my way back to the posterior facet and the tuberosity. And then the last principle that I keep in mind is you got to make space. So most of the time we're going to fix calcaneus fractures in a delayed fashion, especially if you're going to do an extensile lateral approach. You're going to wait for the swelling to go down. And unless you've applied an external fixture, all this stuff sort of scrunches up and it can be very difficult to move fragments around. basically every calcaneus fracture that I do at 2 weeks is essentially, it's a malunion that's trying to heal already. So you got to take all that stuff down, and you got to make some space. And I make space by removing fragments like the lateral wall and posterior facet pieces, and by putting a pin in the tuberosity so I can move that thing around and open the calcaneus back up. Because the calcaneus, when you get in there, it's actually not that happy to see you. It wants to heal and stay where it's been for the last couple of weeks. So here's the sequence, and I'm going to go through it step by step. So I've done the extensile lateral approach to the calcaneus already, which is a very simple approach. And then step one, actually the first couple of steps here, are all about making space. So I need to see what I'm doing. So the first thing I do is I get rid of the lateral wall. I mean, I don't get rid of it. I put it in a little cup on the back table and I save it for later. So that's the lateral wall coming out. And then sometimes I'll take other things out as well. So very often there's a lateral posterior facet piece, and that's going to fall out at some point anyway. So I just take that out as well and put it on the back table such that the lateral wall and that posterior facet piece can hang out together in a cup while they're waiting to go back in the body. After that, I need to continue to make some space. So the tuberosity is in the wrong place, and it's in a position that's going to make doing surgery difficult. So I'll stick a Schantz pin into the tuberosity of the calcaneus, and I'm going to gain some generic length, some generic height, and I'm going to tip it into some valgus as it's usually tipped into varus. And then I just put a couple wires in place so that it's held somewhat out of the way so I can continue working. Unless a miracle has occurred, the tuberosity is usually not quite in the right spot, but it's out of the way enough that I can continue to do the surgery. After that, now that I've made some space with those first couple of maneuvers, I'm going to start working from anterior and medial and work my way back posterior and lateral. So I typically start on the anterior process. So again, there's often a sagittal split there, and I'll get those two pieces together and wired into place. And then I'm going to start reducing my anterior medial fragment if it needs to the rest of the constant fragment, and also building my posterior facet back up. So I grab that piece that I put on the back table and maybe put that back in place. After I've got all the dominant fragments anterior and medially together, along with the posterior facet, I might put my lateral wall back in place. And then I'm going to re-reduce my tuberosity, now that I have got a little bit more to reduce it to. My lateral wall is back in place. I'm going to put some graft in. And then finally, I'm going to put a plate in place. And for some reason, all of my pictures that have a calcaneus with a plate on are being substituted for something else. But obviously, you need to add some fixation at the end of the case. So that's it. You know, calcaneus fractures, no problem. So just the take-home points are a lot of calcaneus fractures can be managed appropriately without surgery. I think that's definitely true. There are patients where the risk is not worth the benefit. But there are plenty of young people jumping out of windows from the cops who probably would benefit from their calcaneus getting reduced and fixed. I think you have to understand the anatomy and also the pathoanatomy of calcaneus fractures in order to get them fixed. So you need to know that there's a primary fracture line, a secondary fracture line, and additional fracture lines in order to look at a CT scan and understand what you're seeing. And then there's sort of a generic sequence that I just went through, but the principles are to build back to the constant fragment, the sustentaculum tali, work from anterior medial to posterior lateral, and then you got to make some space. And I do that with a Schantz pin. I do that by taking fragments out. Okay? And that's it. Thank you so much for your attention, and I'll turn it over to the next speaker.
Thank you very much. And next speaker is again Dr. Mandip Dillon. And he is going to tell us about Talus complications. We'll have the questions at the end of this session. So be prepared with your questions, and if you want to write it well and summarize it, you can prepare your questions pretty well. Dr. Dillon, about Talus.
Small comment on Paul, Dr. Toogood's talk. Dr. Toogood, do you always have to do a gastroc recession while they're putting on this? Because we find it, we find that we really don't need to do it so many times.
Yeah, and is this mic microphone working? I actually typically do not do a gastroc recession, but I have done it if I thought I was struggling. So I listed it up there as an opportunity for making space, and I will do it, but it's certainly not on every case. The person that trained me to fix these injuries did it every time. And in fact, they did it for every Calcaneus, every Talus, every Lisfranc, they did it for everything basically below the tibial plafond, but I'm a little bit more selective in my own practice.
Okay. Because
Dr. Toogood, can you please come over here on the chairs over here on the stage?
Okay, I'm going to ask by an audience question. There's no pads 1 to 4, just shoulder abduction and elevation. How many of you have seen a talus complication? Yoo-hoo-hoo. How many of you know how to manage it well? Okay, those 3 can go and have a coffee. I'll talk to the rest of them. I see a lot of them. The problem is not because there are just so many, it's because that the talus complications are so many. And whenever you talk about a talus complication, the list starts with avascular necrosis. The difference is, I am not so worried about avascular necrosis. People are, but I am not, and I'll show you as we go along. I'm worried about the other issues which are there in the talus. In India, in Asia, many complications are associated with neglect. Now, this was a potential subtalar dislocation with a large posterior-medial fragment who was working as a crane operator in Vietnam. So he was operated. They did a talonavicular stabilization. They did a subtalar stabilization. But the posterior process was left as such. They didn't do anything to us. But then the guy comes to us at 9 months with pain, a limp, and a big non-union. This contributes to both the ankle and the subtalar joints. You can't leave it alone. So at 9 months, we operated on him. Through a posterior-medial approach, we distracted the joint and put Humpty Dumpty back together again with multiple screws. This goes on to heal, and he goes on to get a good outcome. Now, will the videos work? Unfortunately, this is not my laptop, so the videos don't work, because if videos don't work, I'll have to stop and come back again after fixing it. So he's doing well, and he's gone back to Vietnam. This is a simple complication, a small complication which could have been prevented by fixing it in the first place. But when you have major fractures of the body, of the neck, with displacement, these are difficult issues. And here, the issues to address are multiple. You could have avian, malunion, non-union, or a combination. And on top of that, you could get infection and arthritis. So let's start with, I don't know whether you've seen them, is the non-unions. Most times, they are associated with bad fixations. Now, we are getting 1 a week, 50 a year talus complications. That's a lot because we are a referral surgeon, and it's because many surgeons follow the AO techniques. Like this has been done by so-called AO techniques, which is known as miss a talus technique. You know miss a nail technique? So this guy was fixed through a medial malleolar osteotomy, and I call it miss a talus technique. So this is because of poor understanding of the talus, how it breaks, what happens, etc. So I'm going to talk about how I am going around managing these complications. Yesterday, John was talking about the infected joints coming to him. I'm talking about the bad fractures, calcaneus, and talus coming to me. Many years ago, this is I think in the early 2000s, when I started accepting these cases, this was a policeman. Again, you notice the big issue here is inadequate reduction of the subtalar joint. If you can't get the subtalar joint reduced, you can't get it fixed, you can get a bad problem. This was a policeman. Something or the other was done, and by the time he came to us, the screw had broken, the subtalar joint was still subluxated, and the guy had struggled to sort of reduce it and caused a lot of damage. So when he came to us, This was one of my earlier cases. I reoperated. We did a medial malleolar osteotomy. We fixed it in a better position, struggled with the subtalar joint, could not sort of get it back in position. But we thought that the shape of the talus was fine. We were worried about the avascular necrosis, which went on to heal by 6 months. And over time, there was no collapse. The fracture consolidated. Notice here that the subtalar joint is fusing. And because it fused, the vascularity of the body improved and things went on well. He had no collapse, no AVN, but at 4 years, he had anterior ankle pain. Now, if I had been a wise surgeon, I would have probably addressed it on day 1, but I didn't have things over here and understanding over there. But then at 6 years, we did an arthroscopic excision with a spontaneous subtalar fusion. He's gone back to work. If you noticed, he had bilateral injuries. Other side was a trimalleolar fracture. And when I saw him in 2022, this side is just fine. The talus. The trimalleolar is degenerating. I told you in the last case that the ankle fractures tend to not to do well over a long period of time. So my talus did well. The guy's ankle didn't do so well. Another case, 19-year-old lady, 4 months old, came from the Himalayas. She had what I would call an ununited or a malunited 2B. Again the problem, subtalar joint is not reduced, and there is an element of avascularity which you can see developing over here. But surprisingly, she came in walking with a deformed hind foot. You can see the deformity, and she's walking. So now we've learned that we've got to do something different. So we've modified, we do a dual approach. We've modified the lateral approach to the subtalar joint to minimize our struggle to reduce it. We identify the calcaneofibular ligament over there and take it out. Cut it, retract it up, and then expose the subtalar joint. It reduces the tension at the joint. You are able to reduce it, and you can sort of use a laminar spreader or whatever you want. The joint comes back into place. And then you go medially and fix it, and fix the calcaneofibular ligament back with a suture anchor or some small such thing. And at 4 months, you've got everything looking good. Union is progressing, some partial AVN, but by the time of 13 months, she's normal, and that's her video which she sent from her home. She's got a straight foot and she's walking fine. So that's a little trick I learned in reducing the subtalar joint. But when they come to you with an established talar malunion, they have bad gait, they have pain, and they are not right. So this is a case which I saw, I think maybe 2001 or 2, who came to us, young girl. Now we have a follow-up for a long time. 21-year-old. At that time, most taluses in India were fixed by an anteromedial approach. A compression screw was put in, which converted it into a varus dorsiflexion malunion. And look at her, she's already got a malunion with subtalar arthritis. And if you look at her, how she walks, that's how she walks. So now you're going to need corrective reconstructions. And this is an established fact. When there is no avascular necrosis, you can do corrective reconstruction. And we published in the Foot and Ankle Clinics this year. So I'm going to show you a case, January 2014, 10 years ago, neglected Hawkins 2, put in a plaster, comes to us walking like this. Again, the subtalar joint is the thing which doesn't get reduced. If that doesn't get reduced, the talar neck is going to stay unreduced. And by the time he came to us, it had already malunited. So we thought we'll do an osteotomy and do a correction. They say there is nothing worse than a surgeon who's come back from an AO course. He thinks he can do anything. I came back from an AO course in Davos, talked to Stefan Ramelt, and there's me. We went in, exposed the fracture through a malleolar osteotomy. We identified the malunion site. And remember here, there is an element of rotation also. So I always put in K-wires, which not only act as joysticks, but they also give me an amount of how much rotation I need to correct. So there we went in, oh God damn it. Excuse me, sir, the videos are not working. Can I stop here and come back again when my videos are working? Because rest of my talk is all videos. So I think I'll pause here. We go on to the next talk.
Just a minute, Dr. Dinlaw. In your folder, there must be video. He can straight away open the video if it's possible.
No,
just
sir,
have a look.
I have a Mac, so that's not getting connected. I put it on a pen drive. It seemed to work earlier. It's not working here. So anyway, I'll go on. Forget about it, which is very unfortunate. So I did an osteotomy through the fracture side, and it shows you how we broke it up and how we derotated these things and came out, went into the sinus tarsi approach, did a subtalar reduction, and fixed it all in place. You see these K-wires, and again, these K-wires, actually the video should show you how we got the K-wires parallel to one another, and then we fixed it, and that's the post-op reduced this thing, and a temporary K-wire to hold the subtalar joint till everything heals. And this guy went on to heal well. Again, there's a small ledge in the front, which we have done. So now, when we get these cases, like this guy who came to us, you know, I went to do an MD exam in one of the medical schools. And they had kept this case. They had fixed his femur in December 2022. In 23, they had kept this case to discuss in the... I said, he's got a non-union tailors. What are you talking about discussing it? You send him to us. But our policy now is in neglected cases, we do a primary subtalar fusion. We reduce everything, we do a subtalar fusion by choice. Because when the fracture heals, the vascularity of the body comes back. But guys, India is unique. Here sometimes we have to do things differently. So this is a guy who was referred to me with a type 2 talus fracture. The surgeon, I think it was Rajasthan, had fixed it by a dual approach with a medial malleolar osteotomy. He says, sir, this guy has healed well. And one of the approaches was a dead anterior approach, and he's fixed it under 2 screws, but he seems to have a problem. Can anybody see what the problem is? The problem is that the talus is mal-rotated 60 degrees, and the subtalar joint is dislocated, and this is what his foot looks like. Iatrogenic. And this is how the gentleman walks. So we did some CT scans, and we found it was correct. The talus has healed in a mal-rotated position, and we went to surgery with all options open. Nothing would move. Ankle was great, and there's a huge scar in the front, but we had experience with deformity correction, so we cleared the joints around the talus. I attempted a subtalar reduction, but I was causing more damage than good, so we sort of gave it up. I debrided the subtalar joint laterally to mobilize it. I did the Calcaneus cuboid joint debridement, removed very little bone, and a talonavicular joint debridement through a medial approach. Lo and behold, the foot is fully corrected. It's like we used to do in the deformed, in polio or something like that. So we left the talus malunited, did a triple fusion, and ended up with an excellent correction and good function at, I think, 9 months or more, whatever he's got. What about AVN? I'm keeping the best for the last. Everybody is worried about AVN because it's a significant issue, especially when the type of fracture is 3 or 4, almost 100% chances of AVN. But let me give you a simple message. Allowed to heal, AVNs will resolve over time. This is a type 3 fracture I had done in 2004 or 5, and look at the slide on the other side, there. It's healed when we took out the wires. And after 4 years, you can see the ankle view, nothing wrong with him, completely healed. And how does this heal? Because we give them protected weight bearing. It is my policy that if we've got a good reduction, stable fixation, but AVN, we stabilize them, and offload them for 9 months to a year. This case was operated in Goa. I don't know. He says he had come for a holiday, and he was screwed up from the back and the front. So he came to us, healing, good position, but avian. Fracture was uniting, but the bone was sclerotic. So we braced them. No weight-bearing transmission to the talus, patellar tendon-bearing off-handed brace, and he healed. He had no avascular necrosis. He lives in Kulu, in the Himalayas, and he's doing well. He's got this little bad scar in the front, but otherwise he's again full function. He's an engineering student, and he's walking well. So this works if you look after them well. But remember, avian with collapse is a different kettle of fish. Here, you will have to fuse the joint because you can't save it. And most of the time in Indian scenarios, we do what we call as a Blair fusion. It's an old procedure where Blair would take out the piece of the dead bone and fuse the anterior tibia to the neck of the talus. But now we've modified it. We don't take out that bone. It acts like bone graft, and we actually save it. So this is a 32-year-old male who presented after 5 months with collapse. He was taken up for a Blair fusion, which we do through an anterior incision. You incise it over there, and you take out a long graft, which you can slide down and put it into the talus body, and you put it down there, you slide it down, hammer it into place, and you temporarily stabilize it with K-wires, and then you put some screws and fix it over there. And they do well. This is a 1-year follow-up of a revascularized talus and a fused ankle. And this is his outcome at 2 years. He's a laborer and he's doing well over here. But remember, everything is not hunky-dory. This was a case which we did in 1998. And when I went to Australia for seeing the semi-finals of the Cricket World Cup for the World Congress, there's this guy who was serving beer in the Sydney cricket ground and comes up to me, "Hey, Dr. Dhillon, I recognize you. You did my surgery in 1998. His ankle had fused, but now he's getting trouble in the subtalar joint. It's getting converted into a ball and socket joint. So it's not the answer to all solutions. Ankle arthritis after collapse, many people talk about doing ankle replacements, but it's difficult because the ankle won't set into the avascular talus, so there are modifications, and we don't even have the ankle arthroplasty available, although Mahindra has done one case in Goa 2 weeks ago, but not in avian, if I'm not sure. So if you have avian, this is the simple algorithm to follow. If there is early diagnosis, good position, well fixed, don't do weight bearing. Wait long enough, it may resolve. If it doesn't resolve, you can think of bone grafting, drilling, etc. options. I've got a case which we did a bone grafting. Everything is fine. Or we did a subtalar fusion. If it resolves, it's fine. If there is collapse or no collapse and arthritis, you should be thinking of fusion. And if you want to read this study, this is available in the Indian Journal of Orthopedics. Ladies and gentlemen, the take-home message. Understand that talus fractures are not simple. There is a high potential for complications, and in my experience, malunion is the biggest issue. It is due to poor reduction. Avian is less common, or a complication associated with avian is less common if we understand what we are doing. And the treatment of complication depends upon the combination of the presenting problems. What is there over there? Limited fusion of the hind foot is a good option, but be careful about infection. And I would suggest you can read this book, or better still, you can read the AO manual. Otherwise, if you still don't understand, I've just found a tavern in Cidade de Goa. Buy me a beer, I'll explain it to you. Thank you so much for your time.
Thank you very much, Dr. Dhillon. And you can occupy a chair on the stage so that we'll save time at the end of this session. Now, we have a great person. He's from Goa itself, where we are. But he doesn't stay in Goa when we are around. He came from Dubai today morning. and Dr. Mahendra Kutchadkar. He is the head of the Department of Orthopedic Surgery, Healthway Group of Hospitals in Goa, and he is an alumni of Goa Medical College and was the best medical graduate of the year '89. He current positions are National Faculty Member for Foot and Ankle Surgery, National Instructor at Advanced Trauma Life Support, National AO Table Instructor, President of Indian Foot and Ankle Society, and Rotarian from Panjim. And his special interests include adult reconstruction, foot and ankle surgery, primary and revision, joint replacement surgery. So over to you, Dr. Mahendra Kutchadkar. He is going to talk to us about his favorite topic, and he'll introduce the topic himself.
Thank you, Dilip. I first like to thank Mandeep for keeping the foot and ankle session as the first session and changing the hierarchy of presentation. It's a good move because it shows how foot and ankle is important in our general practice. And being a local, I would like to invite all of you with the Goan way of Tumka Sograng Mogatso Yokar. It means I welcome you all to Goa. It's in the local Konkani language. So Lisfranc fractures is something that has always, before I became a foot and ankle surgeon, I don't know how many of them I missed, because the biggest problem is recognition of a Lisfranc fracture. Next slide. Where do I change it? Here? It doesn't change. Oh, right, okay, yeah, sorry. It's not moving.
Come on, somebody help him. It's on this?
Oh, okay. Right, okay. Right, thank you. So I bring greetings from the Healthway Group of Hospitals. It's a multi-speciality hospital located about 5 kilometers from here. So the burning issues that we have to address in this is, you need to understand the anatomical peculiarity of the midfoot. Because if you don't know the peculiarity, oh, there is a fly. Also, it's one of the most commonly missed injuries. The surgical approach is something that is dependent on what type of fracture that you're dealing with. The order of fixation is an extremely important step, because if you start the wrong way, you're going to end the wrong way. What you have to use, which hardware, whether you're going to use a plate, whether you're going to use a screw, or only K wires. Then the problem is whether you're going to fix or fuse. So these issues have been there running around in publications. Some have got clear answers, some have not. Now, as far as the anatomical peculiarity is concerned, you have to understand that the metatarsal base is recessed between the first and third. So when you reduce your fracture, it has to go back where it belongs. By design, the plantar ligaments are extremely strong, but it's the weak dorsal ligaments that yield easily when there is a deforming force, which is an axial loading force on the foot. Also remember that there is a lack of intermetatarsal ligament between the first and the second. Now this is something that you have to reinforce. Also the foot, you need to restore a rigid medial column and leave the lateral column fixed with K wires. So once you know these principles, that will help you to understand how you're going to fix it. This is usually the mechanism of injury. You can also have a direct and indirect injury, but that is not something that is difficult to understand. I'm not also going to go into the classifications. The point is, when you have a patient in your clinic and if you have an X-ray like this, well, this is obvious. This is not the difficult part. The difficult part is when they are not obvious. As you say, the eyes see what the mind knows. 20% of the injuries are misdiagnosed. 40% receive no treatment in the first week. So midfoot sprain is what the diagnosis is given to most patients who come to you pretty late, because you haven't seen one, you're going to keep missing them. So getting a weight-bearing view and a correct orientation of the X-ray is extremely important. So you have to measure the C1, that is the cuneiform 1 to M2 distance, M1, M2 distance, and C2, M2 alignments. Whenever you look at an X-ray, try to look at these parameters, because if you don't watch these parameters, you're going to miss them every time. So what do you watch for? You look at this M1 and M2 distance. Usually that distance is increased when you have an unstable injury. You also have intercuneiform instability. Remember one thing, the Lisfranc is not just about the first and second metatarsal, because this force can come proximally and separate out your intercuneiforms. Also look at the flex sign, which is an indicator that the Lisfranc ligament has avulsed a piece of bone. Learn to watch these lines, steps, and gaps, because if you don't watch them keenly, you are going, even if you have taken a weight-bearing X-ray, and if you don't see these lines and you don't see those steps, you're going to miss these injuries on the X-ray. Again, if you are worried about the injury, you know that you're suspecting something and you can't see it on the X-ray, you get into a plain CT scan. A weight-bearing CT scan is an absolute luxury. But again, you have to watch those same parameters: C1, C2 area, C1, M2 distance, C1, C2 distance, and the angular alignments at that level. In a systematic review that showed that a CT scan revealed 60% more metatarsal fractures and twice as many tarsal fractures. So doing a CT scan is something that has to come to you naturally. Don't just rely on an X-ray. Any suspicions, you will be able to pick up these injuries much, much more clearly on a CT scan. Now, this is a very simple algorithm that we use. Once you have a suspicion of a clinical Lisfranc injury, you take a normal non-weight-bearing X-ray, and if you don't see anything, don't just leave it there. Get a weight-bearing X-ray. If weight-bearing X-ray is, you're not again satisfied with anything, get a CT scan done. And an MRI only if you are suspecting purely a ligamentous injury. So once you have classified it into stable and unstable, then it's very easy. When we say stable, there should be less than 2 mm displacement. Those are the only ones which you can treat conservatively. If there is any amount of instability, it is better to err on the side of going and fixing it. Either, if you want to fuse it, they are usually for pure ligamentous injury in a young athlete. Otherwise, generally the trend is to fix it. So there are so many variables that the questions will come to you when you see a fracture. Whether you want to fix it, whether you want to fuse it, whether you want to use a breech plate. All these things really don't matter as much as an anatomical reduction. The key to having a good outcome in a Lisfranc fracture is spending some time in doing a perfect anatomical reduction. K-wires really are not good enough. So if any of you are using K-wires only to fix a Lisfranc fracture, that's not a good idea, because it's not a very strong implant, because the amount of forces, deforming forces on this area, needs a strong plate or a transarticular screw. So the consensus on management is flexible fixation does not shorten your non-weight-bearing time. So ligaments need a long time to heal, so K-wires are not good enough. Screws, transarticular screws now have been shown to know that they're causing a lot of transarticular articular damage. So a spanning plate is better. And percutaneous fixation, if you want to do, you have to be absolutely sure that you have done a good anatomical reduction, because that threshold to open has to be very minimal. In favor of ORIF, there are lots of studies and generally good to fair results. But again here, the most important parameter is a good anatomic reduction. ORIF is safer and better to do than a closed reduction, because many a times there is these dorsal ligaments which actually have opened up and have come into the fracture, and you think that you have reduced it, but when you open out, you realize that you have so many structures that are trapped within the fragments. Surgical approach, again, depends on the type of fracture. You can have 1 or 2 incisions. That the medial incision, you can start sort of cheating and try and come more medially. If you have a stable lateral column, you don't have to go laterally, but if you have all columns, then 2 incisions usually are enough. Maintain a good bridge between the two, and you are good enough to do that. Hardware, you can use a screw, 3.5 mm, 4 mm, cortical cannulated screws. You may use a spanning plate if there is a big comminution. But now the trend is more towards using a spanning plate so that you protect the joint and allow and maintain the natural motion at that joint. K-wires are only for the lateral column. Using a tight rope is a new tool, can be used judiciously, especially in the ligamentous injury. This is some of the pictures. Now, this order of fixation, now that is the key. You start from medial and go towards lateral, because the unstable column is the medial column. And you go from the least to the most comminuted area. The first is the first TMT. Do a temporary fixation, do a good reduction, because that is your starting point. Do a temporary fixation, do the intercuneiform fixation, again a temporary one. Then try and get your metatarsal back into that slot. That is your key reduction point. Then you come back, fix your first TMT definitively, do a fixation of your intercuneiform, then move to the third, and then fourth and fifth is easy because that's just a flexible fixation. So if you follow this order, usually you land up with a good reduction. Now the screw trajectory. The Lisfranc screw is the screw which actually gets the medial cuneiform to the second metatarsal unit because that's the way the ligament is directed. Now whether you should put a screw from the medial cuneiform into the second metatarsal or the other way around, I find it easier because Vinod Panchabavi, one of our mentor, he showed very clearly that, it is easier to put a screw from a small area to a bigger area. So chances of you missing it are much lesser. And the second thing is that the second metatarsal base is a very hard surface, so your screw doesn't sink in. The rationale for ORIF basically is you preserve the joints at all costs, do not eliminate a motion segment of the foot. It's hard to make the multiple fractures and fusion heal, and fusion surgery is not an easy surgery to do primarily, and it is more technical challenging. Transarticular screws, again, as I said, can cause significant damage, so it is better to use a spanning plate, which are beautiful, low-profile locking plates available. This is, now, as I said, the central slide shows you only K-wire fixation. Only K-wire fixation is just a temporary fixation. Maybe if you have a bad wound, you want to delay the surgery for a few days, but it cannot be your definitive fixation on the medial column. Only screws fixation is good enough if you have done a good reduction and you find that stability is good. You can use a hybrid way where you can use a plate on one side wherever there is a comminution. If there is no comminution, you can just use transarticular screws or a composite fixation. Now that plate on the medial side, you can actually shift it a little bit medial and even inferior because the stability is much more than putting a dorsal plate on the first column. So it all depends on whether you are happy, but putting a plate medially is also it's a very strong construct. So you can shift the plate medially. Now the rationale for fusion, medial column of the foot, it needs a rigid situation for gait stability. In the non-essential joints, you don't have to fuse. And fusion is a one-time surgery. You don't have to worry about getting the implant out, but it's not technically easy. So in favor of PA, also in primary arthrodesis, you have lots of papers, but again, there is no consensus on which one is better. Now, as far as the post-op protocol is concerned, strictly 3 weeks of non-wet bearing, you just put it on a splint. Again, another 3 weeks or 6 weeks for putting on a cam boot, but again, not full weight bearing. And then progressively at 8 to 10 weeks, you can start weight bearing. And it's a good idea that these patients usually get a small carbon plate in their shoes to protect that deforming forces for at least a year. So now we know that any foot pain with swelling following trauma must evoke a suspicion of a Lisfranc injury. Once you have a suspicion, you use whatever it takes to prove that you have whatever you're suspected. And multiple complex classifications really have that's why I've skipped them from my presentation, because it really doesn't give you much idea about what you're going to do, because you have to address every aspect of the deformed force and correct that fracture. So points to remember, don't miss the intercuneiform instability. You have to fix it, look for it. Non-anatomical reductions are the reasons for bad outcomes. Missed purely ligament injuries in the young are the ones which need fusion. Transarticular screw, as I said, we could use it, but now since there are better implants, try and fix it with a plate, and tightrope also can be used for a purely ligamentous injury. In the final analysis, it is a complex injury with poor outcomes. Each injury and patient is unique, so you have to analyze the patient well using a CT scan or an X-ray that is required. Do not miss the subtle injuries. Your goal of fixation finally is to give the patient a stable, painless plantigrade foot. Fuse versus ORIF is still controversial, so if you can do a good fusion, there's nothing like it. But again, best anatomical reduction is the key to good outcomes. Thank you.
Thank you very much, Dr. Kutcharkar. Kindly come over at the stage. And from the audience or even from the panel, if anybody has any question, it's open. We started around 5 minutes late and we still have around 4 minutes. So please come forward, make sure the mic works, and introduce yourself and from which city you are. Yes, Dr. Chetan Pradhan, come over. Chetan Pradhan is from Pune.
Morning, sir. Question to Dr. Mandeep Dhillon, sir. Any protocol or guideline on when you should go medially and repair that deltoid? Or is it always an intraoperative stress assessment?
Yeah, usually whenever there is a talar shift, tilt, and there is no fracture, the deltoid is gone.
Yes.
Okay, but if you can reduce it by indirect methods, posterior malleolus, syndesmotic screw, well-fixed fibula, and then you have no stress, then this is where the controversy came on. Because so many people did well without an accurate or need for a deltoid reconstruction. So you have to understand, if it is stable and it is not moving, you probably can get away with it. But if it is tilting, you will never get away with it because you need to reconstruct it and stabilize it.
So you, at the end of your fixation, you always
You are
check.
suspicious in the beginning.
Yes.
And if it is unstable, there is a talar shift, invariably you should do it.
Okay. Thank you.
Hello. Good morning, sir. The question for Dr. Dhillon. So what are your tips for managing a comminuted fibular fracture? How to attain a good length in that, in a malleolar fracture?
I think I told you there are three things.
Right.
If there's a lot of comminution and you have a transverse fracture of the medial malleolus, put that back. It will bring the talus into position. To a large extent, it will bring the distal fibula also into position, number one. Number two, always keep a contralateral X-ray of the opposite foot in the OR, because that will give you an idea. You can never be 100% sure, but then you will have to sort of distract it and get the fibular length into right. Other issue is, whenever you have these kind of fracture, the syndesmosis is gone. Right. So what we do is we also approach the syndesmosis from the front and make sure the accuracy of the syndesmosis reduction is there and put in a temporary K-wire. So this gives you an idea of the length and rotation of the fibula. So to 95% of the time you can get it right.
You use a distractor in this?
No, not in acute cases. Why do you need a distractor in an acute case?
Okay.
Over here, sir.
Only in tibial, in ankle malunions, which are totally different things. You can use a syndesmotic compression distraction device, or there are other things we can use. I often use a transverse osteotomy and do a laminar spreader to get it. But that's beyond the scope of this talk.
Thank you. Sir, my question is to Dr. Mahindra. Sir, in ligamentous Lisfranc injuries, sometimes when we suspect it and we get an MRI done, the MRI people do not report that there's a Lisfranc ligament injury. They are not able to specifically, see the Lisfranc ligament. So the MRI almost many times comes normal. So in such cases, when you are clinically suspecting a ligamentous Lisfranc, what is the best modality to go ahead? Because it's very difficult to convince the patient to go for a surgery when the X-ray has a very subtle finding.
So if you are suspecting a ligamentous injury and instability, your first thing is to do a pronation test, hyperpronate the foot and take an X-ray. So many times doing just a simple weight-bearing X-ray will show you that instability. Secondly, if you have the facilities for a weight-bearing CT, which is not available at all places, it will definitely pick it up. But there are no fractures, pure ligamentous. It is going to be unstable. Patient is going to complain. So in that case, you open it up and you are going to find all those ligaments, especially the dorsal ligaments. They are very flimsy. They always give away. So even if you have maybe an intact Lisfranc ligament, but when you open, you find that the entire dorsal capsule is completely torn and it has gone inside. So it is not, it is your clinical suspicion that should force you to open up, and then you will never find a negative finding. And all those injuries that you can absolutely stabilize. So MRI, you're right, MRI may not show, sometimes it will just say a strain. It may just show edema.
Yeah.
But it simply
and the
means...
patient says, I'm okay, why are you operating me? It's very difficult to convince such a patient to go for surgery.
Well, what I'm saying is that if the patient is not complaining about anything, then you have to doubt your decision that whether there is a really strong, because
weight-bearing patient has pain.
Exactly. Yeah.
Sir,
Dr. Dhillon wants to say.
You are not very clear in your answers. Are you telling us day one, Or are you telling us at 6 weeks? Or are you telling us what? And there is definitely no bony injury.
Sir, my question
So
is that...
I'll ask the question and I'll answer it. If the patient comes on day 1, and most of the MRIs are done in the private sector by people who do not have foot coils. They have knee coil or something, and they can't place it. So one issue is there always will be an edema, whether there is an incomplete tear or a complete tear. So that's besides the point. You put them on weight bearing, see what is happening. If there is an obvious opening up compared to the other side, there is a ligament injury. If there is none, put them into a well-fitting cast. Give them 3 to 4 weeks to heal. Many of them will heal. Do a weight-bearing X-ray subsequently. If there is a frank tear which hasn't healed, this will start opening up. If there is no opening up, give it time, avoid surgery. Many of them do well, number one. The other kind, if you are going to operate them at 3 to 6 to 8 to 12 weeks, putting in a screw or a tightrope doesn't help. You will have to add a graft. Because by that time, there is no potential for healing. It's only scar tissue, which is painful scar tissue. So if you, depends on when you see it, what is the occupation, ballet dancer, overweight guy, different things.
Thank you very much. May I ask Dr. Kuchadkar, if you have fixed with the screws, is it mandatory to remove the screws, and when do you remove them?
Especially if the patient is young, he's an athlete, I would tell them at 6 months, I'm going to remove the screws. Because these screws are definitely going to break, especially in a very athlete who is going to overload it. So if the screw breaks and you haven't told the patient that, you know, it needs removal, he feels that it's a failure of treatment. So I do counsel the patients on day 1 about screw removal. Sometimes patients just choose not to do it, which is fine. And then it's like putting a syndesmotic screw and you will allow it to break, because by that time the things have already healed.
Thank you. And this is the last question. Yeah. Is it all right?
Yeah, so it's just a continuation of the ligamentous Lisfranc as to whether we should operate. So again, if we consider the ligamentous Lisfrancs themselves, so they're called athletic sprains of the midfoot. So there's a classification published in the AJSM, which again classifies into 1, 2, 3, where all do not need. Yes. So the weight-bearing X-ray, if it is displayed, yes, they need fixation. And also the MRI, I mean, it depends on what ligaments are gone. Another sign which they talk about is the intercuneiform V sign. Yes. If the injury progresses proximally to that notch, that is an indirect evidence to pick those cases. And as Dillon sir rightly said, there are a lot of those sprains which do get well with cast also. So we need to differentiate that, but we should have high index of suspicion.
Yeah, it's where the forces have stopped. Yeah. It could have progressed into the proximal foot, or it has just stopped at the ligament, so that will decide.
I'm Dr. Mahesh Salunke from Mira Bhainder, Mumbai.
Sorry.
My question is, sir, I am waiting since 5 minutes.
We'll come. We'll come.
So, yeah, regarding the lines, radiology part of the Lisfranc, what are the things weight-bearing X-ray shows which non-weight-bearing X-ray misses?
The answer is, come and sit in the front row. We will talk to you. Come here.
Okay.
Thank you very much for this wonderful session, Dr. Dillon and Dr. Tugud and Dr. Kuchadkar.
Thank you. Thank you, everyone. Before we move to the next session, the tea and coffee is ready. Because of the paucity of time, we are already late. Pick up your cups and we can start the session right now. invited as a guest lecturer at 180 occasions, and he has conducted more than 140 webinars across India. So I request Dr. Sangeet Gawale to come on stage and take it forward from here. Yeah, he's here.
So let's start going. We have this session on fractures around the knee, and we have the first speaker, Dr. John, who has already been introduced. The other speakers are from India, from Chennai, Mangalore, and New Delhi.
So should I begin? So if I'm speaking too quickly, or if you can't hear me in the back of the room because I'm wandered away from the microphone, just, wave your hand at me and there you go. Yeah, you guys in the back. Yes. So if I speak too quickly or you're having difficulty just in the middle of the lecture, just wave your hand at me and I'll try and remember to slow down a little bit. I have to thank Dr. Gawale and the organizers for giving me these two topics, because I can't be wrong, right? These are the two topics I'm speaking about this morning are largely opinion. Do you guys remember this video game from way back in the 1970s? I had one of these when I was a kid. We played it for about 20 minutes and then we lost interest and went back outside to play more basketball because it wasn't a very good game. It was kind of a fad. About every 10 years, somebody comes up with a nail for the collarbone, right? That's sort of a fad in orthopedic surgery. They'll come and go. I remember there was a whole series of papers that came out around 2007, 2008 on percutaneous pinning of the proximal humerus. You guys may remember, some of these older guys may remember these papers. And these techniques come and go, right? People develop a technique, and then we all try it, and it turns out to be garbage, and then we all stop doing it. And so nail and plates, I wonder whether nail plus plate is just going to be a fad, but we'll see. I don't have nothing relevant to disclose on this talk. I'm a course faculty member for some Depew courses. The one thing I can tell you for sure about the distal femur fracture is that, you can use a nail, you can use a plate, you can use some combination of nails and plates, and it looks from the literature as though the non-union rates are going to be roughly the same no matter what you do, which is a little frustrating for us, right? Because, I've been fixing these for a long time now, and I would think that I would get better, and yet the non-unions continue to pop up. And that's about a 10 to 15% non-union rate. There's any number of systemic reviews. There's a nice one here that was published just recently in the Indian Journal of Orthopedics from Dr. Sen's group, and they again showed non-union rates sort of in the 12.5% range. This was a paper on dual plating and whether or not dual plating was helpful. And despite doing dual plating, they still showed no advantage to dual plating versus single plating, continued to have non-union rates in the 10% range. Again, this is sort of a frustrating situation. This is a pretty straightforward case. This was referred to me from another surgeon. I thought it was treated fairly well. I think they went with a plate largely because they had this, segment here that was a little unsupported, and they probably thought they wouldn't get much fixation with the nail. So they went with a plate, and they had a very nice reduction on this. Good reduction on the lateral, good reduction on the AP, nicely out to length. No real reason why this shouldn't have healed, and yet at 5 months you can see that the fracture has developed a single plane non-union and gone on to continued pain with weight bearing. Very frustrating to see these cases that you think are going to do fine, and for reasons that we haven't quite figured out, patients will develop non-unions. Paper after paper after paper, and we've known this now quite some time. These are papers going back to the early 2000s, again, demonstrating 8%, 19%, 10% non-union rates. We really haven't moved the needle much on this, in the last 20 years. So, you know, recognizing that this is a problem, we've developed all these all these options for treating them: far cortical locking, dual plating. Now we're moving to nail plate combinations. There was a bunch of papers that looked at whether or not we should use titanium or stainless steel, and then maybe we should go back to using titanium again. You know, is there some medications we can add for this? You know, we continue to struggle with these. So, you know, everybody's got a theory on why this is. And I understand that he's the best, right? The best cricketer? Is he the... No, or is it... We like talking about this, right? Because everybody has their own theory. You know, everybody loves to talk about sports because you can sort of put your own theory out there. And I like talking about the distal femur because I can put my own theory out there. And nobody can tell me that I'm wrong, right? Because we just don't know. So I'm going to tell you what my theory on distal femur is. I'll stay away from cricket. I don't really know that much about cricket, but somebody can probably fill me in at the break as to actually who's the true. Dr. Dillon, I guess you work on the national cricket team. You work with the national cricket team. You probably have the best answer, right? Anyway, this is my particular theory about why we get non-unions in the distal femur. This is a paper that came out in 2021. I always like papers that tell me what I already know, right? That reinforce my own beliefs. That's, you know, this avoids cognitive dissonance. So this is a great paper. I think it's really interesting. Theoretically, and I'll just go through this a little bit slowly, they're bearing load on the femur and then looking to see what happens at the fracture gap, okay? That's the sort of tagline of the study is, we're gonna load the distal femur, we're gonna load the proximal femur just like you're walking, and then we're gonna look and see what happens at the bottom. And just fundamentally, you know, strain is a percent, right? Strain is a change in length over length, and I would have thought that when you load at the top, you would get very little displacement next to the plate here, because the plate would prevent that displacement, right? So you would have very low strain right underneath the plate. And over here on the far side, as you loaded, you would get a lot of displacement here, like this bone and this bone would come closer together. We'd get more change in length, and we would get a higher strain. So hypothetically, I have always thought that we would get this sort of strain ramp or strain gradient across the distal femur. And yet, that is entirely untrue. This is an interesting paper because what they really found when they loaded these fractures, again, we're just applying a load and we're looking at what happens. What happens is that you get a tremendous amount of shear and you get very little compression. And these pieces of the fracture here will slide apart from each other. And the amount of shear that you get is entirely independent of the type of screws that you're using. So whether you use bicortical locking screws, non-locking screws, near cortical locking, far cortical locking, it didn't matter. What's really dominating here is not compression across the fracture. What's dominating is shear. And fractures really don't like shear, right? They really like to have compression, and this may help to explain why we have such high non-union rates. The other part of this that I took away from this paper is that working length is crucial. And if you look at their data in the paper, the longer the working length, the more problem they had with shear. So if we had bridge spans that were relatively small, we had relatively small amounts of shear. If we had working length that was large, we got large amounts of shear. And that is the same, again, regardless of what type of screws you're using. You can use locking screws. You can use non-locking screws. You can use fancy far cortical locking screws. What really mattered was not the screw type. What mattered was the working length. So if there's one thing I take away from this paper, it's to keep a short working length. It will keep my shear down. So, you know, my theory here is that shear is causing these non-unions, in which case you would think that intermedullary nails should cause less shear and we should have better union rates with nails. We don't seem to have that case. So I'm not convinced that my theory is actually true, but it is an interesting paper. this was sort of a comparison of single lateral plate fixation with nail versus plates, right? And this is sort of, you know, one of those papers where you sit up and you think like, oh, maybe these guys are really onto something. They looked at 40 locked plates. They got 18% non-unions in their locked plates, and they got 0% in their nail plate combination. That's pretty impressive, right? To go from 18% to 0%. But this is a single center retrospective case control study, so you have to be a little bit careful about looking at this. And here's my big problem with nail plate combinations. This was a retrospective review that looked at 10 patients, 8 patients, 9 patients, 15 patients, 67 patients. We have a total of 67 patients in the literature with nail plate combinations reported. And it's really hard to make strong recommendations when you've only got 67 patients in the literature. And I would remind you that lots of case reports does not equal data. You guys have this phenomenon in India of people reporting alien abductions. We have a lot of case reports here, and during COVID, these case reports really went up. It's very interesting. There is no data that aliens exist, right? So we have lots of case reports on them and no data. And I would say that nail plate combinations are the same. We have a little bit of a problem with lots of case reports and no real data. So, you know, when you're critically looking at the data, I think nail plate combinations are used. I think it's a great tool. I think it's very useful. I don't think we can say in 2024 that nail plate combinations are better. I think they're useful, but again, I don't think they're better. So here's the situation that we had. This is my first case that I was showing. Fairly straightforward, have to address the non-union. In this case, I think the non-union is very nicely handled by just taking the plate off and putting a nail in there. You know, you ream that up and you put a nail in it, and within 5 or 6 weeks, the patient's feeling much better, and within 5 months, the patient's fully healed with just the nail alone. Now, I tend to use nail plate combinations for my non-unions. So what I actually do when I'm treating distal femur fractures is that my first choice is always going to be a nail. Largely because patients don't get lateral knee pain with a nail, and those locking plates over the lateral condyle really do cause some pain. So I try and always choose a nail as my first tool. If I have bad intra-articular involvement or something that's very distal and I look at it and I just think, boy, my nail is not really going to work, then I will go to using a plate. And for my non-unions, I am frequently using nail plate combinations. I have not yet moved to doing lots of nail plate combinations for primary fixation. I will say I'm tempted, but I'm sort of tempted in the same way that I'm tempted to try the latest fad. And you have to be a little bit careful about saying that this is data-driven. It's more interest-driven at this point than data-driven. Here's a nice case that was referred to me again with a non-union. Patient had a very short working length, and after 5 months developed a non-union. So my shear theory may not be 100% accurate here. This was, relatively easily treated with a nail plate combination, and the patient, fairly rapidly went on to union. I do think in these situations, I tend to take the plate off. It's a little bit tempting to want to just pull some of the screws and leave the plate alone and put a nail up there and then just add some screws back into it. I think if you've been walking on your plate for 5 months, you probably deserve another plate. So this is very straightforward. We take out all the hardware, put a reamer up there, put the nail in place, and then add the plate around it. I think, this was a patient with a total hip in place as well, and so you've got 2 good reasons to do nail plate. One for the non-union and one to protect the distance between the nail and the plate. Be careful about surgery, of course. Nail plate combination is a lot of metal, and this patient here had nail plate combination, and then the plate was really quite prominent in the distal femur here. So after we got her solidly healed, we went back in and just cut the end of the plate off so that it wouldn't be prominent and wouldn't rub on her lateral epicondyle. Of course, she is on apixaban for DVT prophylaxis and developed significant wound drainage, became infected, and her total knee needed to be removed. So, be careful about adding lateral plates if you don't need them. The enemy is everywhere. So in conclusion, I use nail plate combinations for non-unions quite frequently. I just don't think there's data to suggest that nail plate combinations are better than either nails or plates. We're getting consistently 10% non-union rates here. So my takeaway on this is long working lengths I try and avoid. I try and keep the working length as short as I can, and I'm happy to use nail plate combinations for my non-unions. Thank you.
Thank you, Dr. John. May I invite next speaker, Dr. Rajesh Malhotra.
Good morning. Thank you, Mandeep, Insignia, and welcome to AAOS faculty. ALKEM, of course.
Dr. Rajesh, hold on. I have to introduce you.
I thought we were going to skip that.
Can you put on the slide? After retiring from AIIMS, New Delhi, as a professor and head of the department, he joined Indraprasth Apollo Hospitals, New Delhi, and he was awarded B.C. Roy Award in 2014. After that, an eminent medical teacher in 2016, and after that, he has been on various task forces, government organized serial researches on osteoporosis, DVT prophylaxis, joint infections, and he was on fellowship on bone banking and has done extensive work on revision joint replacement. He has several fellowships to his credit. He has about 750 publications. He has been invited more than 1,000 guest lectures all over India and across nation. And he has conducted several training programs on orthoplasty, trauma, and osteoporosis. He has performed several live demonstration surgeries in India and abroad. Dr. Rajesh, can you start with your talk?
Thank you, Dr. Sandeep. Good morning once again. My job is to give a breather to John today. I mean, I'm just sandwiched between his two talks. I'm going to repeat some of what he said. I'm going to say something which he's going to say later. So I'm just the connect or the bridge between the two talks which John is going to give. Which one is working? Which one is working? So I'm going to talk about the periprosthetic fractures, and it's one of the difficult things to take care of, and it's an epidemic, surely. There's an increase in 13% incidence and 4.3% increase in mortality risk. And of course, when you go to the PubMed, the hits you get every few weeks increase, and you see how everybody is trying to find his own theory. So John, you are not the only one. And then, of course, we know that there is a projection of the primaries and revisions. So we are going to have all these, particularly because vitamin D deficiency and osteoporosis is so rampant in our country. There is significant economic burden, 4 times the cost of primary arthroplasty, but then also the mortality. These people die, and you'll be shocked to know that the distal femoral fractures, the mortality is much higher than the hip fractures. Probably many of you never looked at it that way, but it's so much more complicated to treat an osteoporotic distal femoral fracture than a proximal femoral fracture, which is still surgically treated so well. And this is the frustration which John mentioned. This lady was 55 and she has had 1 plate, 2 plates, 3 plates. It was not uniting. Then it went on to a distal femoral replacement, and then another 7-8 years, then she fractured at the tip, and then again the same problem. So tried to use a longer stem with strut allografts, lasted another 5 to 7 years, and then again she fractured, and then so the story goes, it goes right up to the lesser trochanter, and then again it fractured, so I had to have a proximal femoral replacement. So entirely ended up with the total femoral replacement with what started as a supracondylar periprosthetic fracture, which of course then dislocated and then needed the modular stem to be put in altered version so that it stays. So that's the frustration we are talking about. He just mentioned how it can get infected. This is another thing, you know, somebody got a bilateral knee, was operated, reasonably well united, and then came back with this. So never take these fractures lightly. They have mortality, they have cause, they have infections, they have everything. And then, of course, there can be cascade. Everybody knows this classification by the Lewis and Roraback. Very simple, non-displaced, displaced with component intact, and displaced with component loose or failing. So when you have an undisplaced fracture, this kind of thing is not done anymore. This is actually really very primitive. And it's almost like Mahendra saying, don't try to put K wires in the foot. You know, femur is a much bigger bone than the foot. But then, of course, if you can't operate on the patient, the fracture is undisplaced, you have restricted mobility, you can try it, but there are issues like the patient will be confined, he'll not be mobile, alignment may be an issue, non-union, malunion, then of course there's local skin problems can be there. It's this type 2 which interests everybody. So we had John tell us about plating and nailing. He loves nailing, a lot of people love plating. And I'll just discuss the advantages. So you can actually reduce them anatomically, not that you can't reduce them with nailing, but then you can have interfragmentary compression, the rigid construct. Nailing will allow load bearing and early mobilization, and then it has biological and mechanical advantages. And the availability of these variable angle locking plate system has really revolutionized. What, however, is important is not to leave any stress risers, and don't leave it thus distal to the lesser trochanter. Make sure that you don't leave any stress risers so that don't have the patient coming back again. Another example, you can do it very well, and this tibia femoral component had a stem, so by default became a nail plate construct even if this stem is not crossing the fracture site. But then you can do antegrade nailing, of course, that is possible. And then the retrograde nailing is quite popular. The issue is how to enter the canal so that you don't cause the malunion. We know that when we are fixing these distal femoral fractures, the hyperextension and valgus are the two very important things. So you may achieve union in these patients, but he has a badly aligned knee now, which is prone to fail. Similarly, the hyperextension is so common that some people have tried telling that, you know, hyperextension really is compatible with good function, but then it does lead to impingement, does lead to wear and early failure. So when you are talking about the nailing, what is retrograde nailing, the most important thing is the technique, and John is going to talk about it. And like I said, you want to avoid valgus and the extension deformity. And this is what is important for nailing. You have the ideal starting point, which should be at the distal aspect of the Blumenstadt line. So you can see this ratio, which is the femoral canal entry ratio. And then you have this ratio of X by Y, which is actually something which decides where you are going to enter, and it poses a risk to the injury to PCL. So the femoral component ratio as shown by X by 5, if it is X by Y, if it is bigger than the starting point ratio, then you will cause the extension deformity. So this has been looked at by the different knee design. So you must see the kind of design which has been put in so that you can be aware that, you know, whether your femoral component is going to be friendly to nailing or not. And then, of course, this latest paper says, which is, of course, accompanied by George, and it says that if you have 10-degree distal bend, there is less risk of extension deformity because the entry point is altered by that. Another thing you can think about, another theory, John. So this is what it is. A non-union and revision rates between locking plates and retrograde intermedullary nails are same. I do have to also quote that other paper which John showed. And then this is another paper which showed that the locking plates and retrograde nails are give rise to similar results. So if you have good bone stock, there's no problem. You can use locking plate or you can use the retrograde nail, and there's no superiority, similar results, similar function. And then the another paper which says that although you have extension deformity with the intermediary nails, but the clinical outcome between the two is really not different. This is the nail plate. Of course, the talk cannot be complete without the nail plate. That's a hybrid construct. You already heard John's views about it, but then it is said that if the patient is very obese and the patient is osteoporotic, and then of course, even John feels that it is a non-union, the nail plate combination may actually work better than either of these alone. So in poor quality bone, obese patients allows the load bearing across the fracture site may be a good technique. Again, Frank and Richard, they were here last year, good friends. They are the ones who have been talking about this, pioneering, giving a lot of basis for its success, even distribution of energy, added stability, and smoother transition of forces. So hybrid nail plate construct is another something which you have to consider. Now, those who are nailers, they would say that, you know, it may be easy to say that if you are somewhat proximal, use nail, somewhere in between metaphysical, nail versus plate, very comminuted, very distal ones, plate, and far, far distal revision. But now there's this recent paper which says that even in extreme distal periprosthetic fractures also, you can use nailing and the results can be as good as lock plating. So a lot is going on for the nailing here, provided you know how to do it well to avoid the malunion. Then of course, the revision, if it is periprosthetic fracture, the availability of the sleeves has made life very easy, so you can deal whole kind of defects. But when you have extreme loss in very young patient and you don't want to use a distal femoral replacement, you can use allograft like I did for this young lady, and this is now more than 15 years. Another problem that we see is that when there is a failure like this with severe compromise, you have actually compromise of one supracondylar ridge on one side. It doesn't allow placement of these cones, and like I said, the sleeves were not routinely available there. So we were using these off-label use, cut the cone into two, reconstruct the supracondylar ridge on the side where it is missing, so that not to take away the bone from the other side. And you'll be amazed at how much bone they form and how much they can last. Another example, similar one, severe compromise of the bone from one side, the fracture of the lateral condyle there, and then of course you have the same problem here, then fill in up the one side defect in the cortical defect in the ridge, fill it up with the half cone and see how much of bone forms all around it, and it's just embedded in the bone. So this looks a little complicated by Rorabeck and Taylor, but essentially talks about the same thing, deciding basically on whether the fracture is displaced or undisplaced, the bone quality is good or poor, and the prosthesis is stable or not. So this is another classification by Javed Parvezi's group, again talking about taking into consideration reducibility of the fracture, bone stock, and the component is well fixed or not, going from conservative to surgical fixation to revision with long stem to prosthetic replacement, essentially the kind of examples which I showed you. Now, the point which I want to make now is look at the patient, not just the fracture. Look at the biology of the patient. I would recommend in Indian scenario, go for the bone metabolism markers for all patients. Look at their calcium phosphate, alkaline phosphatase, vitamin D, and PTH. If the patients are highly diabetics, which is uncontrolled, which is not uncommon in India, you'll see that the repeated attempts at union will fail. Then the bone is marble-like. If some of you have operated on these cases, the implants keep on breaking and failing. And if you do the studies or metabolic studies on their blood, you will find most of them are not adynamic, but they are hypodynamic. You have a series of patients who had PTH in the range of 8, 10, 12, below normal, not as low as a renal transplant or a dialysis patient, not adynamic, not less than 1 or 2 or 5, but low PTH levels. That actually gives remarkable results in these patients. And second thing is the so-called off-label use of healing. Particularly these patients are osteoporotic and elderly. So there is a role of great role of the anabolic teriparatide for these. This is a lady who had a knee replacement 3 years back, sustained distal femur supracondylar fracture. This went to the same surgeon who had operated. He put this plate. Obviously, everything is wrong with this plate, and it's not a wonder that it failed and it was ununited. And I took it up for surgery, took out the plate, put two plates this time, and I did put the bone graft substitute, calcium hydroxyapatite cement to fill in the void, and then gave her teriparatide, and she formed fantastic amount of bone and was actually weight bearing in less than 6 months, actually more closer to 4 months she was full weight bearing. So the incidence of the periprosthetic fractures is increasing, but it is the stability and the working length of the implant which determines the treatment. Nails are getting more and more popular, but you should know how to do a good nailing to avoid the valgus and the hyperextension. The quality of the native bone will decide the fate, and the intramedullary nail could act as an option in most types of fractures except those where there is a loose implant. Thank you very much for your attention.
Thank you very much. May I introduce the next speaker, Dr. Jayashankar.
At the outset, let me thank for Insignia Learning and ALKEM and Mandip Dhillon to give this opportunity to come and deliver my lectures.
May I introduce Dr. Jayashankar? He has been past president of Tamil Nadu Orthopedic Association, Madras Orthopedic Society. He has been a past Inland Fellowship Secretary of Indian Orthopedic Association. He is at present trustee and medical director of Sundaram Medical Foundation and Rangarajan Memorial Hospital, Chennai. His current position are, he is a chairman of Ethical Committee of Madras Medical College. He is a faculty AO Trauma Educational Activities. He is president of Chennai Arthroplasty and Trauma Society. He has received the Best Doctor Award from the MGR Medical University. He is also trustee of AO Foundation and chairperson of AO Trauma India. Dr. Jayashankar, can you start with your talk?
Yeah, thank you. Yeah. My slides. Yeah. My talk is in MIO in distal femur and proximal tibia fractures. Yeah. You all remember, bone is a living tissue. It will only heal as long as it is alive. My whole talk is on how you preserve vascularity and soft tissues so that the fractures heal very well. Why MIO? You can see the evolution. We no more do any open procedures for intra-articular derangement of the knee. It's all arthroscopy. And then the laparoscope is also evolved through that. So why not, that's the evolution, so that's what we are looking at. So I was actually fixing the upper limb humeral shaft fractures through a minimally invasive technique, and that's what the femoral shaft fractures. I bridge the whole fracture and just fix the proximal and distal fractures with just 2 incisions, and that went on to heal. That is, just see the 2 incisions on the left side, and that is the healing of the fracture, and that is the function of the patient. So that actually enthused me to use MIO techniques in many other situations as well. So fixation without reduction is not MIO. I think you should remember, reduction is mandatory in trauma, wherever and how you deal with fractures. However, reduction must not come at the cost of vascularity. I remember 3 decades ago, we used to do all this, expose the fracture and then use all kind of heavy instruments to align the fracture and fix these fractures. But now we try to do all indirect reduction, and fracture is not directly exposed or handled. Reduction is achieved by using instruments or implants introduced far away from the fracture. So you preserve vascularity, preserve soft tissues for the fractures to heal. And even repositioning of the bone fracture, even if you are achieving direct reduction, you can do a minimally invasive way. But it is not really possible, or it is not advisable as when you are dealing with the intra-articular fractures. Intra-articular fractures requires open reduction and requires absolute stability. So in the majority of the situation, when you have a multi-fragmentary intra-articular fractures, you may have to do an open reduction. Whereas in the shaft fractures where there is a comminuted fracture, you can use a minimally invasive incisions and use minimally invasive circlage wiring, all minimally invasive tools to achieve a reduction. So these are all various kind of reduction tools, periarticular clamp, and then the collinear clamp and minimally invasive circlage wiring techniques. You can see the incisions on the skin and incision on the deeper tissues, and then these tools are very, very important to achieve a minimally invasive reduction techniques. So these are all various other tools, periarticular clamp, and then the surfer and collinear clamps are very, very important to achieve a reduction through minimally invasive techniques. So this is a 80-year-old lady with a distal femur fractures, and where we have used the surfer, and first you tunnel with the surfer, and then you create the pathway for the plate to introduce. And then this is what the jig we use, which is actually also a very important to use, important tool to fix the minimally invasive, innovative fractures. So this is ultimately what the incision will be. You can see the number of holes, but this actually jig is very, very important if you want to achieve these results with the minimally invasive incisions. So that is you first measure the length of the plate, and then how the plate is introduced with the jig. And this is after we fix, that's early return function. And that is the follow-up X-rays with a very good healing. So limited as a surgery need good anatomical knowledge, radiation exposure to patient, surgeon, and the team have to pay a keen attention to avoid neurovascular structures. Poor understanding will lead to all complications. And problems of MIPO, it's a COM dependent, difficulty in reduction, and it takes quite a long time. It's not that easy to do a MIPO technique in fractures or distal femur. Malalignment, technical demands, instrument and implant availability are very, very important. Distal femur, some more examples. And this is already a tibial plateau fracture was fixed, and this female patient sustained a distal femoral fracture, far distal fracture, and that is the use of this less invasive stabilization system has got all the benefits of MIPO, and using an LCP with the MIS jig comes very handy to do a minimally invasive technique. That's intraoperative picture, supine position, and this is how the patient is positioned, and indirect reduction with the shank spin and blunt force to counter the flexion in distal fragment. And once it is reduced, so you can see the reduction on the table and lateral approach, and that is the lateral approach, and that is the actually the incision which we make for introduce that plate. Mark the plate length, and then second incision proximally, and plate positioning after reduction. And there is a very interesting tool which is called whirly bird, which actually, once you use this actually brings the bone close to the plate. So you don't need to worry about plate coming out of the bone. So this is a very, very interesting tool which is keeps the plate close to the bone. Insertion and fixation, and that is insertion and fixation with a jig. That's the intraoperative picture using the jig and the lock plate. That is after immediate post-op. And that's the incision sizes on the entry side for all the minimally and the screws that have been put to fix the plate with the jig. That's the 3 months post-op. That is 6 months with a very good healing of the fracture. There's another periprosthetic fractures, the 3-year post-TKR. And same MIPO with the list plating, and you can see the circlage wiring, which is also minimally used minimally invasive technique. And that is 3 months post-op. That is 18 months post-op with excellent healing. So when you preserve soft tissue and vascularity, using all these tools, you can achieve a very excellent results. That's the follow-up of the patient with the clinical function. And that is another patient with a shaft fracture, which is extending up to the joint. You can see the fracture line extending into the knee joint, but minimally displaced. And on the table planning of the incision. And that is using a minimally invasive technique with the circlage wiring. You first fix the shaft comminuted fracture with the circlage wire. Once you have done this, then the whole fracture is reduced well, and then use a surfer and then apply a plate and lag screw for the intra-articular fragment applied separately. And that's the incision for the plate entry and the incision for the MIO circlage. And that's the complete fixation. And that's the 4.9 for 5 months follow-up of the fracture. You can see the healing of the fracture very well. And that's again another periprosthetic fracture of the total knee with a stable implant, with the comminuted fragment of the metaphysis. Femoral distractor were used to reduce the fracture. And here you can see all tools being used, periarticular reduction forceps and the less invasive system for the applying the plate. And that's the intraoperative picture. And you can see the whirly bird tool is being used to get the bone close to the plate. And there is a percutaneous reduction of the sharp fragment of the punch. So stable fixation, minimal pain, ready for day one loading. And that's the final picture of the intraoperative picture. And the patient is ready. It's a very stable fixation. You can make the patient walk on day one. And that's immediate post-op and the 1 year post-op. And that you can see clinically the incision size and see how we can preserve the soft tissues, vascularity, muscle, all that, so that it heals without any problem. Again, another post-TKR. I'll go a little fast on this. So the same system being used, and that's the post-op. So this is again what I said, articular fractures, does MIPO have a place? And definitely not. Only if the fragments are very big, you can use a MIPO. Otherwise, you have to reduce the intra-articular fractures by open reduction, get absolute stability. That's the post-op. Similarly, proximal tibia. Remember, timing is very crucial as far as we are dealing with the proximal tibia fractures and distal tibia fractures. Swelling often appears few hours after the trauma. Don't rush, wait and reassess. Limb elevation, ice packs, communicate with the patient and the relatives. For the delays, very, very important to take time to fix the proximal tibia fractures. And these are all examples. So MIO is minimally invasive osteosynthesis, or small incisions, beginner to deal with the articular fracture, small at the level of the fracture if necessary, and minimal incision over the remainder. And this is how at the end of the surgery, the number of incisions you have made on the leg. Goal is to have minimal footprint on the injured tissues. And does this kind of main big fragments, does it really require open reduction? Really not. You can actually use periarticular reduction clamp and then reduce it and then give a lax screws to achieve a very good intra-articular reduction, and also use a periarticular clamp in this. So that is the final picture after fixation. And that's the, always remember the underlying tissues when you're dealing with the tibia, deep peroneal nerve distally and the common peroneal nerve proximally, and articular reduction, intraoperative pictures, how you first do the articular reduction, apply a lax screw, and then you can, using a periarticular clamp, achieve a very good reduction, and then apply the lax screws. And similarly, you can also achieve a MIPO medial bridge plating. And that is then percutaneous lateral lock plate. And that's the intraoperative picture. That's the clinical picture on the table. And complete fixation. So that is the post-op, immediate post-op. And that picture shows the size of incisions we have made to fix the bicondylar fracture, and the lax screws on the top, fixing the intra-articular fractures, achieving absolute stability. So I'll just go on. So similarly, there's another picture. This MIO had made easier, they also had a very good targeter. This is for the variable angle plate for the tibia. And this makes the job much easier to do an MIO technique in the tibia. That's the intraoperative picture. You can see the reduction clamp fixing the intra-articular fragment. And then the plate is applied using the MIO targeter for the tibia. So that is for the tibia list system. That's intra picture. I use extensively the femoral distractors, all kind of reduction tools to achieve a good reduction. That's the post-op. Another example. That's the clinical picture. So advantage of MIPO is less blood loss, lower rate of non-union infection, easier rehabilitation and functional recovery. Take-home message. MIPO is a minimal soft tissue damage, less tissue trauma while achieving stable fixation of an appropriately reduced fracture. It's definitely not a cosmetic endeavor. Familiarity with various reduction techniques, instruments, tools, and lock plate were important. Limited access, indirect visualization, radiation hazard, or learning curve, when done properly, provides excellent outcome. Thank you.
Thank you, Dr. Jayashankar. May I invite the next speaker, Ajit Hulon. Ajit, Dr. John is next.
This is another nice topic for me because there's not a lot of data to drive this decision. I found myself increasingly, reminiscing about earlier parts of my career, which just means I've turned into an old fart, right? Like, back in my day, back when I was a resident, I remember when. And these are the old surgeon's lament, and I have to stop myself sometimes from saying these things. But I will say that nailing around a total knee reminds me of some previous times. And as I was doing some research for this talk, I found this AgeMe software. Are you guys familiar with this? The AgeMe software? You can put a picture of somebody in there and it shows you what you're going to look like in the future. And I tried it on myself. So this is what I'm going to be looking like when I'm in the future. It also, the software works backwards. You can put a picture of yourself in there and see what you used to look like. So I hope I took some liberties here. I found this picture. You can see what he used to look like back in 2008. So 2008, this is a paper from 2008. And, it's kind of interesting when you look at this is what they published this as, like, this is a great technique. Here's bad fracture, poorly treated, and we revised it. And every single one of these laterals, when you look at it, the nail looks terrible, right? This is not a great technique. This was before we were doing any sort of semi-extended nailing or before we were doing any suprapatellar nailing. And, they just didn't flex it very much. And so the nail, if you didn't flex it very much, the reamers would kind of chew away the front of the bone, and the nail would wind up a little bit too distal and a little bit too anterior. And this was fine. Like, we used to do this all the time, and you'd look at your post-op x-rays and think like, I better flex it a little more next time. But when you're doing nailing around a total knee, I just want you to think, what would I do in 2008, right? Because in 2008, you could get away with this, right? It was totally fine. And now we're just doing the exact same thing. We're just going back to the future. So think of 2008, turn the Maroon 5 on your radio or whatever it is that you used to listen to on the radio in 2008, and then just look and see whether or not you have any room and whether you're feeling kind of lucky. Because if you screw it up, then you're going to have to call your arthroplasty colleagues and revise the knee. But if you're careful and you're lucky, you can get away with it. This is a patient, sort of a good case for a nail, right? Like, this is kind of begging for a nail. Patient with poor soft tissues, and you really don't want to be putting a plate on them. And you've got plenty of room here. You can, make a little incision and clamp this in a nice reduced position. There's plenty of room to put a nail down here, right? So there you go. That's the end of my talk. If you look on the lateral and you think you have enough room to get a nail down there, then you probably do. Here they are in the front. I tend to stay a little bit medial on these from my start point just to stay away from the tibial tubercle. I haven't had any problems with the tibial tubercle doing this, but I do tend to cheat my start point a little bit medial on those. And again, this, nice way to treat these fractures. I find that this is a particularly useful technique for anybody who's very heavy. If you have crappy soft tissues and you just think like this is not going to be a good place for me to put a plate on the distal third of the tibia, then I think a nail's a good way to go. This was a 60-year-old diabetic patient. Patient had a BMI of 60, and there was some question as to whether or not the patient had chronic osteomyelitis of her distal leg. She had this wound over the lateral aspect of her tibia that she was just draining and draining and draining from, and they had gotten an MRI, and there was some signal within the bone, and one of my partners decided that they would use a 10-millimeter trephine and take some bone biopsies of the distal tibia. So you can see here a little bit higher. They did one here, and then they did another one here, and unsurprisingly, the patient fractured right through her trephine holes. So she came in with this distal tibia fracture. And again, if you have enough room on the lateral, it's really not terribly complicated for you to just run a wire in front of that. There's no different to any standard nailing techniques that you would use for the tibia. Don't try and do this through a semi-extended approach. I had one of my residents, I had to stop them from making a semi-extended approach on one of these recently. Just get your triangles out and flex it. The resident told me they had never seen a flexed nail. So this was a PGY4 who had never seen a flexed nail. So we talked a lot about how to do a flexed nail. So just put it in there, it'll be fine. Here's the patient with a nail in there, and they healed up very nicely. This is them now 2 years post-op. Terrible ankle from diabetes, and their ankle was not stable, but their fracture healed pretty nicely. And you can see the size of the leg here. This is a good way to get away from, having to deal with soft tissue complications in somebody who clearly has lymphedema and some real challenging soft tissues to treat. So nothing terribly complicated here. It'll be one last case. Here's a nice 65-year-old guy who was cleaning out his gutters and fell off. Again, you can slide the nail down there without really any difficulty if you have enough room. There it is with just a little bit of a medial start point for that. Here we're covering over this. This patient had really terrible soft tissue complications, developed a very large eschar over the medial aspect of his leg, and we were able to get the fracture to heal and treat the eschar without having to put any metal plates in there. So, in conclusion, the only thing I would say is just look on the lateral, and if you have room, then you can put this in without really any difficulty. This one, obviously, yes. This one, obviously, no, don't try it. And this one here, maybe, probably not. Just measure it out. If you have room for a nail, then I think you'll be fine. Thanks.
Thank you very much, Dr. John. May I invite now Dr. Ajit? As you know, we have our 69th annual conference of Indian Orthopedic Association in Bangalore, and he is the organizing secretary of that conference, December 2024. He's a senior consultant at Tejaswini Hospital, Bangalore. He's an excellent teacher, surgeon, and has delivered more than 60 lectures, national and international. He has several publications in national and international journal. He's an AAO faculty member since last 2 decades. He is president of Indian Orthoplasty Association. Dr. Ajit, can you start?
Thank you very much, Dr. Sangeet, for that nice introduction. That puts a tremendous load on me now. We thought that was a easy job, but welcome all to Bangalore for the IOCon. And at the outset, grateful to, while the slides come on, grateful to Dr. Mandeep and Insignia Learning for this opportunity. So my brief is to talk on my experiences with distal femoral fractures. The only caveat being that I'm not showing complications because all of us will have a lot of them, and there is no time for that either. So run through a few cases just to show some variety and some discussion maybe at the end. How does it move forward? Slide changer. Yeah, okay. Do I have the control here? Okay, so that's the X-ray of a 19-year-old male. And as you can see, it's a comminuted fracture. Obviously, it is unstable. And what you need to realize is, okay. There is also a HOFA type element in that. That's what I wanted to show, but do we have a different, this one, okay. Yeah, that was the HOFA fracture that was, okay. I think you already have seen that in the pre-op X-ray. If you had not looked at it well, if you had missed that, then it would have been a disaster on day one. Obviously, this needs a CT scan. It was done, but I have not put it up here. So just to start off with one simple or a relatively simple case for complex fracture. Yeah, okay, then that goes on to healing. What we need to be aware of is get the alignment right and also get your distance, the length right. Otherwise, there will be instability, not just a deformity. So this is the thing that we need to look at it very little more critically. So this is the second case. Again, a 19-year-old young man coming with isolated injury. And the history was that there was a piece of bone that was expelled through the wound, right? Many of us get these sort of scenarios, and the wound per se looks very benign, but when you actually get an X-ray, that's the situation that we have. And so you go, oh my God, you start scratching your head, you need help, you need to discuss with other people. And I think in a situation like this, you need to evaluate the neurovascular status as well. So then, okay, you need a CT scan, maybe you need an angiogram if you suspect some sort of vascular injuries, but then looking at this X-ray, what are the thoughts running through your mind about definitive management of this? Whether it's going to be staged, whether it's going to be initially X-fix, whether you want to do something on day one, go on. So these are the things that run through our mind, and that's what we need to sort out. So these are all the problems that we, how to restore the length, how to address the bone loss and the comminution, and And also the timing of surgery, like I said, whether day one, what do you do? In a delayed fashion, what do you do? And in a late manner, if you have to do anything at all. So how do you go about it? So CT angio, there was no issues. He was in shock when he came, so there was some issues about the quality of the pulse, but then it was okay. So this was the wound that was extended, debrided, and the articular area looked reasonably all right. So day one, what we did was put in a couple of screws to the distal femur there, like so. You have some access for a distal femoral nail, planned it out, and then did a retrograde nail all the way. And then you see there are two areas that are deficient. One is there and the other one is there. This was the open area. So we decided to pack that with bone cement. And then we were planning to address that with some sort of distraction technique. So that was why that area was left as it is. And on, I can't remember the exact day, I think, yeah, day 2 post-op, we put him on an orthofix, did an osteotomy at the proximal femur, distal to the lesser troch, and started distraction. And yeah, gradual distraction, and it came down to about that level. At that level, we decided to remove the X-fix because we were having problems with the pin sites, and also the longer the orthofix stays, the range of movement is an issue, at least in my hands. So that's we decided to get that off. Unfortunately, I think we lost some length. I don't know if that will show. We lost some length in that distraction there when we removed the X-fix, but we thought the nail would hold it. Anyway, went on and then subsequently used a RIA bone graft from the opposite femur and also a fibular strut, as you can see there, and then reconstructed that defect. And we put in, this is the longest distal femoral plate that we have, a 13-hole. This guy was 6'2", unusual for a South Indian at least. But that is why we had to put the plate a little higher up so that we could get above the osteotomy site for the distraction. So that was what was done. And that was the other femur from where we got the RIA bone graft for this defect. And he went on to heal. Unfortunately, there was a bit of varus malangulation at that level. That's the fibular graft that we took in a percutaneous manner there. I'll just run through that. That's the literature for that. And that's his final alignment outcome at union. And that's his range of movement that he had for this particular fracture. So this is another one. A Hoffa fracture was not covered here, so I just thought this is also an unstable distal femoral fracture. And as you can see, the fragment is rotated right around there. Of course, you need a CT scan to evaluate how you go about this. And that's how it was. It was totally rotated about more than, almost 180 degrees. The fractured area was facing the opposite side, and the articular surface was facing 90 degrees the other side. So also there was so much of comminution. So how to go about it? So thought about it. There was no way with any other approach that I would be able to derotate that large chunk of bone. So decided to put him prone and go posteriorly. That's the popliteal crease, horizontal. That's the nerve there, and that's the vessel marked out. And then went in, isolated the nerve, used 2 windows, one on either side of the tendon of the biceps femoris, went round, derotated that fragment, as you can see, got the correction done, temporarily held with K-wires, and then fixed it with a plate from the lateral window like so. So there was a lot of comminution and bone loss there, and it was not very perfect, so to say, there, but it was a stable fixation, and he had a good, that's at healing 3 months down the line, and that's the range of movement that he had. Okay, so another example, this is an elderly lady who was bedbound for a few months, and that was the fracture she had both in the femur and tibia. And I think yesterday there was some talk about conservative management. So this was one case that we put her into a cast. That was her situation. The family did not accept the risks involved for surgery, and I also thought it would be a little daring to do anything for her, considering the quality of bone. And just with a long leg cast, probably a Scotch cast would have been easier on the lady, but a conventional plaster of Paris cast was applied, and she went on to heal like that. So just another variety. So this is probably my last case, a variety. Again, seeing the wound looked decent, but when you get an X-ray done, that's the comminution that was there. And looking at the articular surface, as you can see there, I thought a good option would be an arthrodesis here, because the entire lateral articular cartilage is gone, and I didn't know in the long run what would be the outcome. That was looking at the X-ray. But when we opened up and had a look at the soft tissues, it looked really bad, really contused, and we had to cut out a lot of the contused muscle. And here, one of the thoughts that was discussed with the patient was an eventual amputation as well if he did not agree to it at the outset. So all these things were discussed, and then he wanted the limb to be saved, and so went on. Those were the bits that were loose and that was removed. And the articular surface was reasonable. We could get a good reduction there, fair reduction, so to say. And then held it with K-wires, temporary, and went on to again do this nailing, because in our experience, an intramedullary nail will take less bone graft than an extramedullary plate. That's the thinking that we have. That's the defect, more than 6 inches of bone defect there. Again, temporary cement spacer there, hopefully acting as a membrane for subsequent bone graft. That was the nail that was put in. And then fibular bone graft with, there was some amount of unhealthy tissue, so we put in stimulant there along with the fibula. And that's I think this is the current status as things are now. And that's the tibia. Yeah, that's not yet consolidated solidly, but he is up and about on a walker. He's happy that he's got his own limb to walk on. But he's a young man, and I don't know, with the frustrations that come in with not being able to get back to work, how he will behave in the days to come, I'm not sure. A brief word about dual fixations. When in the distal femur or unstable situations do you use bilateral plates? As you saw, most of my examples did not have a medial plate, but this is the European journal that from Stoffel's place that suggested that in osteoporotic bones with multiply comminuted areas, periprosthetic fractures and non-unions are the main indications for dual plate fixations. Our approach has been to use a medial fibular strut and a lateral plate, or a nail with added plate. That's been our experience mostly. We are a little reluctant to use medial plates. Maybe we'll get over that. Thank you very much for your attention.
Thank you, Ajit. Wonderful cases. We have some time for questions from the audience. Yeah. We will address that as mic 1, 2, 3, and 4 from mic 1.
Yeah. Dr. Ajit, sir, this is Dr. Ambole from Patna.
Ajit.
Dr. Ajit.
Question for you.
Yeah, this side.
Yes, sir.
Regarding your big bone loss in the femur, in the compound injury, what all precautions do you take while putting the nail so that you have got an equal length from the contralateral side? And also, when you are transporting the bone over the nail, what all precautions have to be taken precise? Because once the nail is stuck, it's very difficult that bone can be transported over it.
Was the first question about the length?
Yeah.
The length?
Yeah.
Yeah, I mean, ideally you need to check out the opposite limb, the length. And in these situations, the patient is not on a fracture table. You can put him on the ordinary table and you can assess the length that you have. And at the outset, I think the important thing is to counsel them that they may be a centimeter or two short. That's not the idea. The whole idea is to get the bone united. That's what we counsel our patients at the outset in such challenging cases. As regards lengthening over a nail, there is no major problem. The locking bolt is proximal to the osteotomy site, so you can actually transport it in a standard manner.
Regarding the width of the nail, once it is tightly fitting, it is very difficult to transport the bone.
Yeah, I mean, if it's a very tight fit, yes. Like you said, sometimes the shan spins actually start bending a little bit.
That's true.
But I mean, in a size 10 is the smallest nail that you have. So if there is space around, you can transport it. There's no problem.
Right.
Mic 2. Speak louder. Can you come on the mic, front mic?
My question to Dr. John, he said the shorter spanning plate gives less stress on the shearing stress on the fracture site. But as we know, the longer the plate, it is a better fixation and have less shearing stress on the fracture side. I want a clarity on that.
Right, so a shorter working length, when possible, gives you less shear. So you have to be a little careful about the concept of shear versus strain.
Okay.
And if you're trying to minimize your shear forces, then a shorter working length will help. But you're right, that does concentrate more of the distance over a shorter segment. But if your proximal segment is intact, then it doesn't change. Your forces are still going to be concentrated over the short area of the fracture. So if you have a longer fracture length, then you can't make the working length shorter. But if you have the option for making the working length shorter, then I would choose always to make the working length shorter. I'm not sure that really answers your question.
Okay.
So when you have the option to make your working length short, take that option, make it short. Oftentimes you don't have any choice. You might wind up with a long working length simply because you have a longer comminuted fracture that extends over a longer distance. In that case, you don't really have the option.
Okay.
So we have still more time. May I ask all the faculties, what is a weight-bearing protocol in the different modality of construct you make for distal femur? And what would be a robust fixation in an elderly osteoporotic or a periprosthetic fracture?
Yeah, you know, we all have a tendency to want to protect our x-rays, right? We want our x-rays to continue to look exactly like we left the operating room. And early on, I've had a patient, that I know I have protected to non-union, right? By not letting them bear any weight on it. And if you don't bear any weight, then you don't get any change in length, you don't get any strain, you don't get any chondrocyte activity, you wind up with a non-union. So I'm pretty aggressive about weight bearing them. Everybody is 50% weight bearing out of the operating room, and if they make it to their first visit without falling apart, then they all get weight bearing is tolerated. So, at 2 weeks, everybody's weight bearing is tolerated, presuming that they're, I give them a couple weeks just for me, right? I'm treating myself. So I give them a couple weeks just to make sure they're not going to totally fall apart, and then when they don't, we make them weight bearers tolerated at 2 weeks. Is that
anything
what you guys?
I make the patient weight bear immediately, almost post-op. Your fixation must be so stable, and we are strong enough. I think you are very, at that age, the osteoporotic patient, even if you tell them not to weight bear, they'll weight bear. To see that your fixation is stable and strong.
Particularly in the elderly people, elderly osteoporotic bones, we use the nail plate construct and we allow weight bearing because it's very difficult for those elderly patients not to, very difficult to actually hop on one leg or non-weight bear. So that's difficult. So that's the indication for us to use a nail plate construct in elderly comminuted osteoporotic fractures. But in young, touchdown weight bearing, complex fractures like that, even a couple of months of touchdown weight bearing is.
We have an interesting sort of a social phenomenon as well, in that a lot of our patients will go to a nursing home or a facility after they leave the hospital. They're not going home. And when they do, if the facility is not well staffed, they frequently just park the patient in the bed and then they don't move them, or they get very minimal amounts of physical therapy if they're at a nursing home which is not that well run. So I find you have to at least give them something. Otherwise, they'll just park them in the bed and the patient will never even get out of the bed. So
for us, it is mainly weight bearing as tolerated, but which amounts to full weight bearing in most cases. But if I'm really worried about whether that fixation will hold in severely osteoporotic bone, I don't shy away from the old-fashioned training days when I was a resident lament to say that I'll put them in a quadrilateral socket and I'll give a calf piece and give them a hinge knee brace while I protect the at least any angulatory forces at the fracture site. So I would not hesitate. I can't stop them from putting weight, but I'll protect it in some kind of brace which allows knee movements also.
So if you have to give a message, probably withholding a weight bearing would be not appropriate, irrespective of whether you use a nail plate or a combination. You must start a weight bearing as tolerated as early. Last question.
Dr. Oswal from, hello, Dr. Oswal from Pune. I've got two simple questions for Dr. Ajit. One is some tips and tricks. Dr. Ajit, some tips and tricks to avoid the screws getting into the intercondylar area in the femur while putting lateral plate. And second is, can we use those bone grafts which you removed in compound fracture in any way, either immediately or later?
What was the second one? It's echoing here.
Yeah, no problem. First question is, while putting lateral femoral plate for intercondylar fractures, how do we prevent getting the screws into the articular surface or intercondylar area?
Articular surface?
Yeah.
Okay.
And second is, you removed those bone grafts from that compound fracture femur. Did you reuse them, or can we reuse them, or can we reuse later?
You mean the fragments that we have removed?
Yeah, absolutely.
They were discarded. They were not
no,
used.
I was just theoretically asking, can we reuse them? Maybe after, ETO or later.
I don't think that's a good idea unless we have done that for the articular chunk. The entire distal tibia had come off. I mean, there was no other option. We had cleaned it up and put it back. And even that got infected. So that was...
Would you do same thing for the fractures, non-compound fractures, simple fractures? These fragments, would you remove them?
No, I mean, you have enough bone graft even from the patient's own self, like your iliac crest, your fibula, and we have the facility of a bone bank locally. So there is no issue with getting bone graft rather than risking, non-viable or potentially infected sort of avascular bone.
Yes,
We will be breaking for a lunch in short time. We can ask the question later. First question, how do you avoid interarticular penetration of the screw?
Yeah, I mean, those plates, anatomical plates, are meant to be in a particular position. Okay, so you at the flare where it matches the flare of the distal femur, that's where it should be. And sometimes you may have to collapse the fracture a little bit, and you may have to come a little distal to sort of get a good purchase. So maybe in those situations, we leave the last hole so that it doesn't. Sometimes it does come into the intercondylar area, and if that is giving me added support, particularly in an osteoporotic one, I would not bother too much about the structures in the intercondylar notch. I would use that screw because it's not going to interfere with the range of movement.
You can remove it later.
Yeah.
Okay.
So thank you very much.
Thanks, Chairperson, Dr. Sangeet, Dr. Paul, Dr. Ajit, Dr. Malhotra, Dr. Jayashankar for a wonderful deliberation. We move on to our session before lunch. This is the last session before lunch, and this is going to be chaired by Dr. Chetan Pradhan. I welcome Dr. Chetan Pradhan on the stage. He is a consultant orthopedic surgeon of trauma and emergency medicine and head of trauma at Sancheta Institute of Orthopedic and Rehabilitation, Pune. He has worked as clinical assistant to Dr. Didi Tanna, which instilled in him passion for trauma. He has received various international fellowships, including AO International Fellowship from Auckland City Hospital, New Zealand, under Dr. Bruce Twaddle, 2008. He has received Accident Emergency Trauma and Orthopedic Fellowship from Sally Oak Hospital, Birmingham. Also a fellowship in trauma and orthopedic from Queen's Medical Center.
I think that's fine. We can move on because it's getting late.
So I request Dr. Chetan Pradhan to take the session forward.
So I think before lunch, it's appropriate that we move on to one of the most awaited, most important sessions, and that's the proximal femur. And I call Dr. Paul Toogood to deliver his first talk on the femoral neck fixation or arthroplasty.
Great. Well, hello again. Hang in there. It's 3 talks to lunch, so we're getting there. So I'm going to talk about a very common problem, which is femoral neck fractures. I'm going to try to specifically focus on the occasional decision you have to make about fixation or arthroplasty. There are plenty of people that are going to fall into one category or the other, and there are some folks where you have to make a decision, and this talk is about those folks you have to make a decision. No disclosures here, except that I'm not going to tell you the answer. I'm just going to sort of discuss factors that you should consider when you're trying to make this decision for a patient. And so this is the patient that I'm talking about. So this is the injury. It's a displaced femoral neck fracture. If this patient were 25, I think the strategy is pretty straightforward. You're going to fix that. If this patient was 75, I think the strategy, again, would be pretty straightforward. That's someone who's going to get a form of arthroplasty, either total hip or hemiarthroplasty. But this guy's 50, and I think there's a decision that needs to be made. Are you going to try to fix this, or are you going to try to replace it? And that's a decision you're going to have to make with the patient. So this is the central outline for the talk. I'm going to talk about some things that I think are the benefits and disadvantages of each approach, things for you to think about when you're trying to answer this question when it comes up in this kind of patient. All right, so I sat down and I tried to think, okay, what are the good things about trying to fix femoral neck fractures, assuming that things go well? So one good thing, if you choose fixation for this kind of injury, and if it goes on to heal, is that it provides a very durable result. Assuming they don't have a complication like non-union or AVN, probably the best tip you can give someone, particularly if they're on the younger athletic or active side, is their own hip rather than arthroplasty. These people, at least in my hands, are not going to be given any activity restrictions if the femoral neck goes on to heal, and there are potential salvage options if things go wrong. And then, unfortunately, I think when you're going to fix a femoral neck fracture, there are a long list of potential disadvantages, which is why, again, in this patient, where both might be an option, I think you should at least take a moment to pause and consider some of these things. So personally, I think that compared to total hip arthroplasty or hemiarthroplasty, ORIF of a femoral neck can be more technically challenging. I also think there's some uncertainty with regards to how to do it, meaning that it's not totally clear to me if we should be doing open or closed reductions. That pendulum seems to swing back and forth a little bit. And there's been a lot of effort to figure out what implants to use, but we still haven't reached much of an academic conclusion yet. And then on the practical side, most of these folks are going to have to be kept non-weight bearing for a period of time. And there are real rates of non-union and AVN that we haven't seemed to improve over time. And then even if you do win, you get this femoral neck to heal, there are consequences to having a shortened neck. So I'm going to try to prove some of this by going through a case. So this is a gentleman that I took care of 7 or 8 years ago now, named Vinny. And he had his headphones in, and he was walking down the street in San Francisco, and he crossed the street and got hit by a car because he was too busy listening to music. And he had a couple problems when he showed up. He had a pelvis injury, he had an open tibia, and then he had this femoral neck fracture. And so this is what I did for Vinny. He got an open reduction, and he got fixation with 3 cannulated screws. Interestingly, the reason he got these 3 cannulated screws was he was enrolled in the FAITH trial that I'll talk about later, and so he was randomized to this fixation. But anyway, this is what Vinny gets. He gets an open reduction, he gets fixation. And then he's a nice kid, he comes in and talks to me at 3 months. He's overall pretty happy, but he says, boy, I got some groin pain on the left. I really am having trouble putting full weight on this. And I think it's fairly clear that he's had some shortening, he's fallen into varus, and this is probably going to go on to establish non-union. And so we jump on this and we do the operation that I went through yesterday. And fortunately, he goes on to heal that. And this is his 7-year post-op. He's one of the rare people that actually comes back to see me on occasion beyond 3 to 6 months. So, you know, with that case, in this relatively young, active person who was listening to music, walking down the street when I got hit by a car, I think I managed to give him a very durable hip. He doesn't have any specific activity restrictions that I've given him, and he did go through a salvage option, and that salvage option worked. So Vinny sort of demonstrated all the advantages of having an ORAF of your femoral neck. But he also had some struggles. This was a technically challenging case. He got randomized to a fixation strategy that I wouldn't have chose on my own, and I like to think that the use of cannulated screws here may have caused him a problem. He was not weight-bearing for a long time. He got a non-union, and there are some functional consequences to his current hip anatomy. He complains that his skiing is not as good as it used to be. So Vinny had all these pros and cons of femoral neck ORIF. There's some data to support what I'm saying. So this is a study that looks at the technical challenges of ORIF of femoral neck fractures. So the hardest part, like I said, for the calcaneus is also true for the femoral neck. You got to get this fracture reduced if you're going to fix it. And here's some data to prove it. So this is a small study. And all they did for these patients was at the end of the case, they got an AP and a lateral. And they said, does that look good on the AP? Does that look good on the lateral? If the answer was it looked good on both views, they called that a grade 1 reduction. If it only looked good on one view, they called that a grade 2 reduction. And if it didn't look great on the AP or the lateral, they called that grade 3. And what you can see is that the complication rates, specifically non-union here, goes up nicely with the quality of your reduction. So these are technically challenging cases. The reductions really got to be good if you're going to try an ORAF, and there's the data to prove it. I mentioned that one of the reasons that might give you pause to do an ORAF is we're not totally sure how to do it. When I started my training, the group that was training me was very dedicated to open reduction, and the reason was basically the last slide. I just said that you have to have an excellent reduction if you're going to fix these people, and so the rationale was if you need to have a perfect reduction, then you got to open to see it and clamp it and get that reduction right. As it turns out, that's been hard to show that that's really the case. So this is a study that compared closed versus open reduction, and their rates of AVN and non-union were just about the same. And interestingly, this is an article that was written by one of my partners who was very dedicated to open reduction of femoral neck fractures, very dedicated. Thought it was a crime to perform a closed reduction on a femoral neck. And unfortunately, when he looked at data and tried to prove this, he actually showed the exact opposite. And he very humbly wrote this up and has changed his opinion on this. In this particular series of patients, after doing a lot of fancy math, actually what he ended up showing was that people with open reductions tended to have a higher reoperation rate than closed reductions. But nonetheless, whether or not to do an open or closed reduction for femoral necks, I still think is a little bit unanswered. I mentioned there's some uncertainty about implants as well. So there's been a couple of FAITH trials. This was data from the FAITH 2 trial. They got the appropriate age group of patients here, at least these patients were in their 40s, and they compared cannulated screws, which is the CS there, to the sliding hip screw in a hope to find a difference between outcomes, and essentially they didn't. They found really no difference in major complication rates regardless of what implant you used. And they also found out that they were not going to be able to continue the study. They basically didn't have the enrollment necessary to really reach the conclusions they wanted. In my own practice, and as long as I'm not participating in the FAITH trial, I think it's okay for people with relatively horizontal femoral necks to be treated with partially threaded cannulated screws. I think that's reasonable. The more vertical the fracture gets, I'm more likely to use a sliding hip screw. There's some biomechanical evidence to demonstrate that that makes sense, and certainly it makes common sense to me. And just as a reminder, if you're going to fix femoral neck fractures, you should generally be doing this with implants that allow for controlled collapse. And obviously, partially threaded cannulated screws and sliding hip screws allow that. So this is just an example of a locked plate that didn't and went on to a non-union. Again, something to give you a pause if you're going to consider fixing these patients. The AVN rates and the non-union rates really haven't budged over many years. So Jack showed data spanning the decades of the rates of distal femur non-union being 10 to 15%, and the rates of AVN and non-union for femoral neck fractures continue to be about the same. It's about 10% each, and that's what I quote patients. So overall, you're looking at about at least a 20% major failure rate for ORIF. Okay, so that's the pros and cons of ORIF, and now I'm going to do the same thing for arthroplasty. If you do arthroplasty, I think these are the benefits. It's a pretty technically straightforward operation. I can do a total hip in about an hour, skin to skin. I can't do an ORIF typically that fast. I let people immediately weight bear if they get a total hip or a hemiarthroplasty, which can be very important for some folks. And I don't think there's much uncertainty about outcomes. There's lots of big studies looking at lots of patients that can tell us what our complications and success rates are for this procedure. The disadvantages, you could argue durability in young, active people may not be as good. Some people might give folks formal functional restrictions after an arthroplasty. I don't tend to, but some people might. I do think anecdotally the outcomes for hip arthroplasty are not the same for fracture versus arthritis. Arthritis patients are very happy with their total hip. They tend to love it and give you a hug on their first post-op visit. The fracture patients are satisfied, but there's no hugs involved in the post-operative follow-up. And we all know that there are arthroplasty complications that are pretty serious and difficult to deal with. So those are the disadvantages of thinking about total hip arthroplasty or hemiarthroplasty. So this is Robert. He's a neat guy. He's got a tattoo of an octopus on his hand. And he got hit by a car when he was crossing the street on his way to the aquarium. And this is his displaced femoral neck fracture. And he's in his mid-50s, and he ended up deciding to get an arthroplasty instead. And so in this particular case, maybe a little bit less dramatic than Vinny's, again, the benefits for him was that this was a technically straightforward operation. He left the hospital the next day walking out on his total hip. And I could counsel him a lot on what the pros and cons are of his arthroplasty choice. In general, he didn't have any complications, so he didn't have too many of these disadvantages. But again, he didn't give me a hug on his post-operative clinic visit. He was satisfied, but preferred his old hip before it broke. Just a little bit of data to add to that. So I mentioned that unlike femoral neck ORF, we do have a lot of good data. We do have big studies to let us know how these patients are going to do. So let's review some of the data on these complications. So femoral neck fractures treated with arthroplasty do have a higher rate of dislocation than those for arthritis, but it's still pretty low. This was a study with about 700 patients in it, and the overall dislocation rate was 6%. We also have good ways now to try to lower that dislocation rate, both with approaches and also with implants. Dual mobility constructs have come along, and they are showing a reduced rate of dislocation. So that's something I will routinely use. We all know infection is a devastating problem for arthroplasty. And again, we have big data that'll tell us what the infection rate is. For primary arthroplasty, it's probably less than 1%. If you're getting your total hip for a femoral neck fracture, it's a little bit higher, maybe 2%. But if you compare that to the 10% non-union and 10% AVN rate with femoral neck ORF, these complication rates are pretty low, and again, have a lot of data to tell us what those numbers probably actually are. And durability is not something that I worry too much about. I didn't go through the age of conventional polyethylene and osteolysis. I have never seen a patient with a contemporary arthroplasty have those kind of problems, and 15-year data on wear rates demonstrate that the longevity of contemporary arthroplasty is probably excellent. And most people, if they don't live to 100, are probably only going to need one surgery. So, like I said, I don't think I provided you guys with any answers on what to do for that 50-year-old patient with the femoral neck fracture. I still think some of you are going to pick the ORAF, some of you are going to pick the total hip, and that's okay. I don't know if you guys have this expression in India, the elephant in the room. Seems like you should, because I think there's more elephants in India than in North America. But in North America, it's the big thing that nobody's talking about. That's the elephant in the room. And I think for this topic and most topics in orthopedics, that's probably the surgeon's skill set. So there's probably people sitting in this room that feel very confident in ORAF, and there's probably people in this room who feel very confident with arthroplasty. And I think for a lot of things, including femoral neck fractures, it's okay to consider your own skill set when treating these patients. So if you feel very comfortable with ORAF in a 50-year-old, that's okay if that influences your decision making, and the opposite I think is also true. If you do 500 total hips a year and you feel very good about that, I think it's okay if that influences your decision making, as long as you're open-eyed about it. So in summary, again, I didn't give any answers here. I think in that 50-year-old patient with a femoral neck fracture, fixation and arthroplasty are always both going to be options for those patients. I think you just need to be aware of the pros and cons and make that decision together with the patient. I will say that for anyone who's over 50, I do think that arthroplasty is something that is worth considering. The days of calling femoral neck fractures an unsolved fracture for people who are under the age of 65, I don't think that's true if you're over 50. I think for a lot of people we have a very good solution if we're just willing to admit it. All right, well, thank you again.
Thank you, Dr. Paul. Please come and sit here. So next I invite Dr. Christina Boulton for her talk on trochanteric fractures. Dr. Christina is an associate professor of orthopedic surgery in Arizona College of Medicine, Tucson, where she's been since 2016. She specializes in orthopedic traumatology. She's a board-certified Academy of American Surgeons, and she's on the faculty of OTA as well as the AO Trauma and the Arizona Orthopedic Society. She's an invited faculty all across the world, and she maintains a busy full-time clinical practice at the Banner University Medical Center, focusing primarily on orthopedic trauma, but also has an interest in disorders of foot and ankle, as well as treatment of post-traumatic conditions such as limb deformity, limb-length discrepancy, chronic osteomyelitis, and post-traumatic arthritis. So with this introduction, I would invite her to start her talk on intertrochanteric fractures.
All right, so you guys are 2 lectures away from lunch now, so hang in there. We're close, I promise. So I'm going to talk to you a little bit about trochanteric fractures. And I think, probably I do 1 or 2 of these a day. I'm sure that you probably do a similar amount. These are extremely common, but I don't think that means that we do them perfectly. So we're going to talk a little bit about how to obtain and maintain and judge our reduction, where to place the implants for greatest success, and then which implants to use if we have a choice, and then which pitfalls we want to avoid. So why are we here? We're here to avoid that first fracture that you see, but we're also here, I think, to look at these 2 in the same patient and figure out how can we take the one that's good but not perfect and make it the one that looks a lot better. And there, I think, are very simple and subtle things that we can do to improve our fixation and improve our reduction. So I think a lot of times we don't care about that, right? This is a fracture that tends to be pretty forgiving. A lot of times we can just let our resident throw the nail in and the patient still does okay. But that's not always the case. So some of these more challenging fractures, so either challenging fractures or a challenging patient size, can make your case quite difficult. And you all know these unstable features, the things that make these fractures more difficult. And I just want to remind everybody, as I often will remind my residents, that a lot of these will have non-displaced fracture lines. So a lot of them will have a non-displaced intertrochanteric or femoral neck fracture line that is just waiting to displace intraoperatively. That will really change your case and change your day. So keep that in mind as you're moving forward and looking and planning. And so we also have some really ugly fractures, right? So these are some of the ones that I think can get quite challenging. And so we have large LT fragments, or the 2, the middle one and then the side one are both sort of examples of really bad, I think, greater trochanter injuries. So split greater trochanters that are in multiple different pieces that really won't have any of your fixation with a standard nailing. And what do we do with that? So how do we achieve a reduction? So let's move forward with that. I would like to make a plug for lateral nailing. How many of you nail laterally? That's good, like 3 people, that's perfect. So many people don't do this. I do all my nails laterally, every antegrade nail except for 1 or 2 a year. That anesthesia won't let me do that way. I think it's very helpful because in larger people, the soft tissue falls away with gravity, right? You put someone on the side, the soft tissue gets out of your way. In the same way that you would do a periprosthetic femur fracture, and the same way that you would do an open reduction, or even a hip hemiarthroplasty, I do in this same position. So it's a very familiar position, very familiar approach. If I want to make it more of an open approach, it's very easy and accessible. And then the clamps that you put on, the clamps don't get pulled down by gravity, right? They're not sitting horizontal when you're on the fracture table. The clamps don't try to drop to the ground. They're actually staying up in a way that, that helps you, not hurts you. And then for subtrochanteric fractures, really difficult subtroch fractures, instead of struggling with that flexion and external rotation of the proximal segment, you can just pick the leg up and move it to the, move the distal part of the fracture to the proximal part, and that really helps you with your reduction. So I think people who don't nail laterally get really frustrated with the imaging. So this is what you see, and you see, oh, this is why I don't nail laterally. That looks terrible. And I would argue that you can make it a lot better with just a couple quick steps. So the way to make that first image look like the second image is just a couple changes in your C-arm. So you roll your C-arm over further, that unoverlaps the 2 legs, and then you cant towards the head, and that opens up the femoral neck. And so when I position the patient, this is what it looks like. We're rolled over 15 or 20 degrees with that lateral view, and then we're canted towards the head 15 or 20 degrees. And that really opens up the imaging and allows you to see the same view that you would see on the fracture table. And then let's move on to reduction aids. And so we've already heard about some of these earlier, but these are sort of my 3 weapons of choice for most proximal femur fractures. I think that I'll talk to you about the cerclage wire in a little bit more, but I think people are hesitant to use the cerclage wire. When I was trained, it was the tool of the devil, but I actually think it's very helpful in certain fractures. And here's an example. So for a subtrochanteric fracture, either this pattern or a spiral pattern, I find extremely helpful to have a cerclage wire. So I think there was a picture of this earlier, actually the same kind of percutaneous passer, but you basically put 1 on each side, thread your wire through, twist the wire from the outside, and it really facilitates your reduction. So that can be a very quick, easy way to help your reduction, to hold your reduction while you put the nail in, but also to bring the fragments closer so that it's easier to heal and to give the patient a little bit more stability as they start weight bearing. And so don't discount the cerclage. And then I tend to use the bone hook a lot also. So I'm not sure how well this is projecting, but you can see that there's a gap there in the inferior neck as I'm starting to put that guide wire in. When I use this bone hook, I put it through the exact same incision that my cephalomedullary screw is going to go into. So I don't make a new incision, but I usually bring it down the anterior aspect of the bone and hook it under the anterior femoral neck, but you can also come posterior if you would like to. And then essentially we take that malreduced fracture into a fracture that looks reduced, and we go ahead with the surgery that way. You have to be a little bit careful not to over-reduce because that brings you into varus, so be very careful how much you're pulling. And then keep in mind that it also works in both planes. So by bringing that hook over the anterior aspect of the neck, you can pull back and correct this rotation deformity at the same time as correcting your varus and valgus. And then typically, for maintaining the reduction, I will keep that bone hook in place as I put the guide wire in, as I do my entry aiming, as I put the nail and the screw in place, and that will keep it solid. That doesn't always work, and we'll talk about that in a second. So here's an example where I either need my hands free and I've taken the bone hook out, or the bone hook is augmented in that first picture with some additional wires, maybe to stop displacement of a non-displaced fracture. And so I'll put some of these wires in prophylactically to make sure that I don't knock off that non-displaced intertrochanteric fracture line that we talked about earlier. Sometimes if the fracture is particularly difficult, I'll have wires and the collinear clamp, and then maybe some more wires in addition to that, and occasionally the bone hook, so we can sort of escalate as things get more difficult. And then here's another couple of examples of the cerclage wire used to hold reduction, but also to maintain reduction after we leave the operating room. And so occasionally I will find myself, instead of a cerclage wire, finding a fracture line that I think would be better served by a supplemental screw. I rarely do this, but occasionally I do, and often in patients who are heavier, to help offset the burden of how much of the weight that the nail will take. And so what happens if you do this? Essentially, your fracture was reduced. You didn't have the bone hook, but it looked great on your initial imaging. You ream, and then you put your nail in. And hopefully, before you put your head screw in, you notice that there is a malreduction here and that you have sort of pushed that proximal fragment off. And so for me, this is not the same as having that malreduction initially and correcting it. When this happens, when I see this happen, I think it can be under-recognized that what's really happening is that whole proximal segment is rotating. It's being pushed away by the nail, and it's essentially gapping through the fracture. The nail is causing it to gap. So in my opinion, if you don't take everything out at this point, you're really putting yourself at risk for fixation failure. You have to pull your nail, pull your screw, pull everything, and re-reduce and hold, re-ream, redo everything, and then when you get your alignment appropriate and your screw back in the right place, then you'll have a construct that's more stable. And then how do we judge our reduction? So things that we can look at intraoperatively. So this is in the literature. A lot of people talk about it, I think, and some people maybe aren't as aware that it is something that's more recently focused on. But this anterior medial cortical support, and that's really important because most of these unstable fractures have no posterior medial cortical support, right? So the only thing that we can use for support is anterior and medial. I personally use medial more than anterior because I find it easier to judge on the AP radiograph than the lateral, but you can use both. And so here's what we look at. So if you have this positive overlap, meaning that the proximal fragment is overlapped with the shaft but outside the shaft, or neutral, meaning they're touching, lined up, that is better than having the proximal fragment kind of tucked into the shaft or intussuscepted into the shaft, because that can predispose you to failure and varus. And so you want to try to make sure that you have one of these two kind of constructions before you leave the OR. And then just keeping in mind that this positive medial cortical support, that's not the same as having a positive alignment but no cortical support, right? So that second picture, you're not actually touching. There's no inherent support of the cortex there, even though it's in a positive alignment, meaning the proximal fragment is outside the distal fragment. That is actually no support, and that's probably one of the worst case scenarios where you have nothing that's actually supporting that fragment. So let's talk a little bit about what implant you might put in and does it matter. And so I would argue that sometimes it matters what implant you put in, but for the most part, it's not as important as how well you reduce the fracture and where you put your implant. And so let's talk about what we mean by that. So for me, optimal starting position, and this is a little bit from kind of anecdotal experience, but also a lot from what's out there in the literature that tells us what works and what doesn't work. But I prefer my starting point to be either choke tip or medial. So this is an example of medial. This is usually where I will err most of my start points, just medial to the trochanter or trochiformis. Usually I will put my cephalic screw a tiny bit posterior of central, but you can also put it central or anterior as long as you're low in the neck. I will tend to go below the equator of the femoral neck or lower when I place the screw in, because that's the best bone that the patient has and the lowest chance of failure. And then in terms of the depth, I'll make sure that that screw goes all the way into the stronger subchondral bone, so usually less than 5 millimeters from where the femoral head subchondral bone is. And then I really focus on trying to get no lateral protrusion of that screw past the lateral cortex, and we'll talk about that in a second. And the other thing that I focus on is most implant companies will have an external compression device on their nail, where you put the screw in and then you can actually screw the guide that pulls the screw back towards you. I always use that every single time. because in my view, the patient's going to do that as soon as they start walking. And I would rather do it in the operating room in a controlled way with no chaos and no instability, and leave the operating room with the collapse as supported as it can be. And so symptomatic hardware, I think, is a real thing. As people collapse, that base of the screw really rubs against the trochanteric bursa. They get pain, they have injections. Sometimes they even go through another surgery to have their screw shortened. And there's been shown to be no mechanical advantage of having that screw base protrude. So there is no reason to bring that screw base out of that lateral cortex. You should cheat it short. And then only sometimes, I think, does it matter what implant you're using. So do we still use a sliding hip screw? And I would assume that many of you do. I actually love the sliding hip screw. And then 1 or 2 screw cephalary nails, like the very end picture, and then short versus long nails. So just to quickly talk about those. If our lateral wall is intact, like this initial fracture, then it doesn't matter, right? You can put in a beautiful sliding hip screw, you can put in a beautiful nail, whatever you want, whatever's available, whatever you prefer. If you have an inadequate lateral wall and you put in a sliding hip screw, then this is what will happen. And sometimes this is what will happen in the operating room, sometimes this is what will happen after you leave the operating room. And so you just have to be really careful about having at least 1 to 2 centimeters of lateral wall to support your sliding hip screw if you're going to use that construct. And then if we're using a nail, there's nails that have screw devices with 1 screw. There's nails that have 2. These 2 screws kind of slide against each other to control the collapse. And it's been shown in biomechanical studies that there's higher stiffness in that construct, there's a higher load to failure, and there's increased cycles to failure. It has not really been shown yet that that makes a clinical difference to most patients. And so I don't routinely use this, but sometimes I will use this as a revision for a failed fixation of a different type of nail. And then long versus short nail, from my perspective, all that changes is where your next fracture is. If the patient falls again, where the next peri-implant fracture is. It's either higher in the femur or lower in the femur, and it's been shown to make no difference for that patient's actual healing as long as they don't have a long trochanteric extension. And so then I just want to touch base quickly on some of these uglier things. So what do you do with a really widely displaced, really big lesser trochanter piece? And I would say the first 3 things that you do with that is nothing. It is okay to do nothing, nothing, and nothing, as long as the rest of your construct is strong. If it really bothers you or you really feel like they're missing a huge part of bone that's going to inhibit their healing, then you can clamp or cerclage, but I maybe do this once or twice a year. I don't do this routinely. The ones I find more difficult are these split greater trochanter fractures. So you fix it, but essentially you have fixation in the shaft, you have fixation in the head, but the trochanter pieces are just floating in space. And so is that really the best for that patient, and how does that patient walk afterwards? So there are different things you can do. Again, you can do nothing. You can just let the troch solidify around what you have. You can do cerclage wire. You can do screw fixation. And what I sometimes will do is actually an ethibond suture fixation as well. And so essentially just ways to lasso those troch pieces and to keep them where they're supposed to be as the patient heals. When you're going to choose to do this, you have to keep in mind that if you take the time to stabilize the trochanter, you increase your surgical time, you increase blood loss, and you may have some effect on functional score and fracture collapse. But it is a price, right? You choose to pay the price to do this. So it's not appropriate for every patient. So just as a quick summary, consider the lateral position. It's not as hard as you think. There's a couple quick things you can do to make that positioning and visualization easier. Consider bone hooks, cerclage wires. Don't be afraid to use the cerclage. I think it's a very powerful tool. And then scrutinize your anterior medial cortical reduction before leaving the operating room to make sure you have cortical contact and that it is not tucked into the shaft to put you at risk for varus collapse. And then which implant you use is less important than where you place that implant, but don't leave that screw prominent if you can help it. And if you start to see malreduction as your nail goes in, take it out and start over. That's it.
Thank you, Dr. Christina, for that brilliant lecture in a very short time, covering almost everything about intertrochanteric fractures. I fully agree with you. I have been nailing only in lateral positions for the last 15 years or so, and it's immensely easier than, yeah.
So once again, Dr. Ajit Kumar for proximal femur fractures in young adults, bailout plans and challenges.
So Dr. Christina has very elegantly shown all the tips and tricks that need to be done. In the proximal femur or subtrochanteric region, what may be a little different is that maybe in the trochanter sometimes if you're slightly at the tip of the trochanter or even a little lateral, it may be all right. But the subtrochanteric region is much less forgiving. And if you are over the slightly off your medial entry point, then invariably there will be varus, and that is going to fail in due course. Also, the other difference would be that here you will always be using a long construct. I think what you need to bear in mind is many of our patients are elderly and osteoporotic, bowed, so you may need to get an implant which has a greater curvature, radius of curvature. You need to keep in mind those sort of issues. So these sort of fractures are always a challenge, and we need to take time, we need to plan, we need to execute our plans perfectly so that they go on to healing well. So most of the points have been covered, so I will just rush through that. I mean, this is, most of you have seen Dr. Shiv Shankar's live surgeries and also the YouTube videos. You know how to reduce and hold. So all that has been shown, I'm just running through that because lunch is beckoning you. So hold it there. Once you do that, you can actually adduct the limb to get a better entry point as well. So that's also important. So the other important thing that Dr. Christina mentioned was you hold it until you have your distal locking in place. Until you do that, maintain your reduction. So just a few tips and tricks: holding the fragment there, getting the reduction, getting your preliminary cerclages if you want to. The entry point, make sure that you're just medial to the tip of the trochanter, if not in the piriform fossa. It'll be difficult with an angulated nail, but with a straight nail, you can definitely go through the piriform fossa. So ream through. So some instances, you may have to use a tipped guide wire to manipulate into the distal segment. So, and then you ream there, pass your nail, and that's been shown. Okay, so just to tell you that you need, if you get your entry wrong and then you see that in varus, no matter whatever cable wiring that you do, this is going to fail. So I'll just show you yeah, that's the sort of armamentarium that you need for each and every case. And that apart, you need backup of all the available trauma implants that you need, as I will show you in one of the examples. I'll rush through some atypical examples, but I think this was a standard one. This was done about 8 months ago elsewhere. And as you see, the entry point is so lateral. Obviously, there will be varus, and there's nothing happening there. And you know the stress is going through that region. This is going to fail. And so that was what was done. In the non-union situations, we do prefer a nail plate construct, even in this situation. So, and that's gone on to heal. So some bailout options, that was the topic that was given to me. So this is a scenario. Left side thigh pain. Any quick guesses on the diagnosis here? Okay. Osteopetrosis, that's what it looks like. This is not bisphosphonate-induced fracture. So you have, even the skeletal structure looks different. This is smaller than the other side. And it's not just the X-ray projection. So no history of bisphosphonate use, and suggested surgery, didn't undergo the surgery and comes back with this at 3 months. So what implant to use, that's a problem because the bone is really hard to drill through, it's very difficult. So that's just to show the rugger jersey appearance in the spine and also the thickened this thing. So this was what was done, and as you can see, we could not go through all the way, but doesn't matter for a subtrochanteric fracture, and this went on to heal. As you can see, there is a bulge or a sort of a step there in this side, on the right side as well, and 6 years later, she was symptomatic, suggested surgery, again refused, and after about a year comes back with that sort of situation on the other side. So now what to do? As you can see, the canal is very narrow, right? But we do get 9 size implants in the local manufacturers. So often for tight canals we use that, but it was not possible in this particular situation. As I said, yeah, unable to enter, very hard bone. It kept slipping off there, trying to enter there. So we planned a DHS just because the opposite side had a DHS. So another incision, guide wire passed, and subchondral. The triple reamer, the third portion, would not go through the outer cortex. So we were stuck on table, and so there started reaming, that went through, and finally we had to go on to put on a surface implant there, I mean a plate like so. Right? So that was what was done. You could argue for a longer plate with a maybe stress distribution there, but this was it's like a pathological bone. I don't know how much difference that would make, but eventually, slowly, it went on to heal, although I suspect there was some varus there with that sort of this thing here. So that's at union, and that's the lateral views there. So that went on to heal, but the message is that you need the entire trauma implants available when you're dealing with such unusual presentations or complex situations. So here's a 14-year-old boy. I'd never seen a fracture like this, and this also looked quite pathological if you just see the skeleton. And if you see the whole bone, that's what it is. We didn't know what we were dealing with until we got the pediatricians in, and when we looked up the atlas, this turned out to be Piles disease. So it's some sort of skeletal malformation that is there in a genetic condition, autosomal recessive apparently. So did the same thing, a surface implant like so, and he went on to heal. Right, he went on to heal well. Another situation, not very sure, I think this was a diabetic. So extremely displaced sort of fractures here, very difficult sometimes to hold the reduction in place. You will have to either wire it or even hold it with K-wires while you go on to getting your entry point. So that was done. We could not get even the 8 size reamer down. So I don't know if I can go back to the first X-ray. We thought we can push in a 9 size nail. We could not. And then we had to go back to a surface implant. So again, the message is, if you have only a nailing sort of instrumentation with you, you may be stuck up in certain situations. So went on to fix this. As you can see, the canal here is very, very narrow, and the 8 size reamer would not budge beyond that. So that's another situation. Went on to heal well there. So here's one pathological situation. He had undergone some surgery some 7 years ago, and he did not have the details when he came to us, and he had some thigh pain here. This was not the old Kunsha nail that was available those days. It was, I think, a fibrous dysplasia situation that had a fracture some years ago when he was an adolescent, and he came back. This was the old X-ray. He comes to us with this sort of a situation. So a extremely wide canal like so, and a bent nail. So he had a fall and he had developed a bend in the nail. So a nail plate construct again because non-union, or so to say, and a wide canal. This was what was done, and he goes on to heal well. So that's, I think, that's the range of movements that he had. So last one to show to the American colleagues that we do also have some firearm situations, but the gun licensing scenario is very strict in our country. This was in the line of occupation. He is a forest ranger, and he had this injury. And yeah, I mean, nothing great about it, except that you don't go after all those pellets, thorough debridement, and then a standard sort of nailing that you do. Yeah, and that he went on to heal weight bearing comfortably. So the take home message is these are very challenging fractures to treat, the subtrochanteric and proximal femoral fractures. You need to understand the deforming forces, you need to plan the surgery, and most important, have all the armamentarium at hand, and then you open reduction is definitely then fixing in an unreduced portion. So don't end up in a situation like you see there. Thank you very much for your attention.
Thank you, Dr. Ajit. Excellent cases as usual. Any questions? No one there to ask questions, I think. Yes, sir. Somebody has a question.
Hello. Yeah, am I audible?
Yes.
As Christina, madam, I am Dr. Dilip Shah from Mumbai. I want to ask you that when you do the compression, you expect the proximal screw to back out by 5 millimeters or 7 millimeters, and it will project out. Then do you screw it home, or preemptively you put it more inside? What is your key point in that?
So, so I think I heard you say when I'm doing the external compression, essentially pulling the screw back to compress the fracture, does that cause the screw to pull out? Or like, are you saying kind of pull out of the bone in the head?
Right, exactly.
Or it comes lateral?
From the lateral,
okay.
lateral side,
So,
it comes out.
Great. So I usually put it in a little bit further than I want to put it in, and I also cheat it short. So when I drill, the measurement that I take as I drill, I usually take 5 to 10 millimeters off of that, so the screw is in quite deep, almost to the edge of the nail, before I start compressing back, so that it ends up just right on the border. So it doesn't stick out.
So that point is to be noted, right?
So yeah, no, I think that's really important. One of my partners never does this because he swears that if you screw that down, you'll just pull the screw out of the head in someone who has very bad bone. I believe him, but I've never seen that happen yet. And so I think that taking as much chaos out of their post-op walking as possible really helps them.
Another question, only one more. In difficult cases and in porotic bones, do you keep hemi or total joint replacement as standby?
For intertrochanteric fractures or?
Yes, intertrochanteric.
So tomorrow, I'm giving a talk on controversies in the hip. And one of the things that I'm going to cover is that controversy. So if you have a terrible, terrible pertroche, is that better just treated initially with arthroplasty with a troche repair around a calcar replacing stem?
Exactly.
Or is it better to try to fix them with a high failure rate and then bail out to arthroplasty?
Thank you so much. That's what I was hinting at, that primary arthroplasty.
Yeah, I think it's a great question. I don't think we know the answer.
I think we'll have to wait till tomorrow.
Yeah, wait till.
Stay tuned.
Okay.
Hi.
Any more?
Yes, it's one question to Christiana, ma'am.
To
Christiana, ma'am.
Christina, okay.
I'm Dr. Ajaz from J&K. My question is that you said that once we are using SHS, sliding hip screw, in intertrochanteric fractures, you need to have a lateral wall. So what is your role on using the trochanteric stabilization plate in these fractures when you have sliding hip screw along with the trochanteric stabilization plate, TSP?
No, you're right. And so I did not go into that, but you're 100% right. If you want to use the troch extension plate, then it can work without your lateral wall. That absolutely is a solution. I would say that it's a great solution. I think it's a very elegant solution. I have used it in the past. from what I hear, especially and it's probably different here, what I hear from my American colleagues is that most hospitals, they don't even know where that plate is.
Okay.
So if they're in the middle of the surgery and they need it, nobody can find it, nobody knows, which tray it's in, nobody knows how to apply it. And so then they bail out to a nail when they may not have needed to do that. So I know where it is in our hospital, but I think a lot of people don't know where it is, but it absolutely would work. So I didn't mean to imply you can't do a sliding hip screw. You have to use the troch stabilization plate, for sure. Yeah.
Thank you.
Okay, I thank all the speakers. Christina, hold on, we'll take a photo, please, for this wonderful session and then join for lunch.
What's your opinion on cement? How frequently do you? I only use it for rubbish.
most of us or all of us probably know already. We're going to review which patients are at risk for hemodynamic stability. Again, I think that can be done quickly and with common sense. And then finally, we're going to go over a simplified algorithm of how to deal with it. All right. So the good news about hemodynamic instability with pelvic fracture patients is it's not really that common. It depends obviously where you work. The closer you work to a highway, probably the larger percentage of your patients are going to have hemodynamic instability on presentation. But on average, the rates somewhere maybe between 1% and 4%. The bad news is if they have hemodynamic instability at presentation with a pelvis fracture, it's a bad problem. And mortality rates might even be as high as 20 or 25%. So this is one of the few things that we're going to get called about with some regularity that can actually impact life and death situations. So, all right, so who's at risk? I think this is, or sorry, that was who is at risk and what causes them to be at risk. So the thing that causes hemodynamic instability is bleeding, obviously. I think we all know that. All these numbers were painstakingly put into this chart by me from this one old paper. You don't really need to look at the numbers in detail because I will simplify it. So basically, the reason you're going to get unstable is because you're bleeding, and when you bleed, it's more often going to be venous than arterial. Although you can see the arterial numbers are not negligible. Somewhere between 1 and 20-something% might actually have an arterial bleed, depending on the pattern in this paper. But it's bleeding, and it's most often going to be venous. And then I think, the people who are at risk are the obvious ones. They're the bad players. So if you use the Young and Burgess classification, the folks with the injuries at the end of the spectrum are the one that are going to be at highest risk. So your LC3s, your APC3s, your vertical shears. And I think that all makes sense. So let's spend the rest of the talk not talking about this algorithm. So when I had to put this talk together a couple years ago, I did the usual thing where I looked through the literature and tried to get an algorithm that someone else had made. And I found this thing, and I thought, boy, this does not look helpful. This looks very complicated. There's no way I could remember all this if I was in the trauma bay and nervous about an unstable pelvis patient. So I promise you we're just going to simplify it and have a 4-step algorithm instead. And the only step that I'm usually responsible for in totality is step 3. So anyways, let's go through the 4-step algorithm of how to treat patients with hemodynamic instability with the pelvis fracture. So the first thing is something that no one's ever going to forget. It's just ATLS. So this is the first step for any trauma patient, including the hemodynamically unstable pelvis patient. Where I work, this is not run by the orthopedic surgeon. This is run by either an ER doc or a general surgeon. And most of the time, they don't need a whole lot of input from me. But there is the occasional patient who will have a pelvis fracture, even one that's already been recognized, where the appropriate steps are not being made to control hemorrhage. And sometimes I will have to butt my way in there to make sure that hemorrhage control is being done appropriately for these patients. So step 1 is ATLS. Step 2 is to figure out that someone has a pelvis injury and that it's at least contributing to their hemodynamic instability. And there's no right one way to do this. It's varied over time and varies by institution. I think traditionally this was done more with plain X-ray and ultrasonography. Contemporarily, at least in my own institution, it's pretty hard for people to get into the ER without a CT scan of some sort. So that's also helping us to identify these patients. But regardless of what sort of imaging modality you might want to use in your hospital to help identify the pelvis fracture, obviously you need to know that it's there. And if you know that it's there, ideally you're going to be able to try to guess whether or not it's an arterial bleed or a venous bleed, or perhaps a combination of both, and contrast in a CT scan is going to perhaps help you make that determination. So step 3, I think, is the most important step if you're going to be an orthopedic surgeon when you grow up. So ATLS I'm not super involved with. I don't order CT scans or plain X-rays in the trauma bay. That's being done by someone else. But skeletal stabilization is obviously where we're going to come in. And this is step 3. It's not step 4. So I haven't talked about step 4 yet. It's going to be control of hemorrhage. But step 3 is before step 4 for a reason. This is a nice study that proves the point that I want to make, so that's why I picked it. It was a tiny little study, and basically there were 4 groups, and so I'll go through those groups. So all of them have unstable pelvic ring injuries. This group over here just gets an external fixator. That's the only thing they get. This group here gets an external fixator and then goes to angio. This group here gets an external fixator and then gets pelvic packing. And then there's this group down here in gray that got bleeding control, an attempt at it anyway, prior to pelvic stabilization. So these guys all have the external fixator go on first. This group down here had the external fixator, or whatever you wanted to use to stabilize the pelvis, go on second. And then these are the survival rates in this study. So there's a ton of selection bias in this study, admittedly. The people down in the gray box are probably not the same people in the other boxes, particularly this box up here. Those are probably just different patients. But nonetheless, it makes the point that I want to make, which is that a major factor in hemodynamic stability in these patients is pelvic stabilization. So we need to control the pelvic volume in order to control their hemodynamic stability. You don't want to be down here in this category. Okay, so getting someone's pelvic volume closed down is a big part of how you're going to stabilize these patients, and there's a lot of ways to do it, and I have them listed here, and I'll go through it. The degree of difficulty here, the degree of difficulty here I've sort of said is, hard up here and easy down here, and you'll notice over here the degree of effectiveness is really not clear to me. In fact, I'm willing to bet it's largely the same between these methods in a lot of circumstances. Just to go through these, if you want to be fancy and sophisticated, one way to control the pelvic volume is to do this anti-shock screw. I've seen this done once. This is an example from the literature. This is a effective but technically challenging way to solve this problem in a hemodynamically unstable patient. You can put on a C-clamp, and I think this is not something I've ever used. Some people here may have this at their facility and like it. Depending on who you ask, some will tell you it's easy to put on, and some will tell you it's tough. But this is another way that's you're able to close down the pelvic volume and help resuscitate a patient. There's an external fixator, either crest pins or supraacetabular pins. And then finally, there's a sheet. This is something that is very effective and can be life-saving and requires essentially no medical training whatsoever. So the point I'm trying to make is this. I think skeletal stabilization of the pelvis is extremely important in the resuscitative efforts of these patients. You have to do something. I think what you do is probably less important, but you can save a life by closing down the volume of the pelvis in whatever way you feel comfortable. And if all that means is putting on a sheet or a binder and transferring them to another hospital, I think that's perfectly adequate in most situations. So do what you're comfortable with, just make sure you're involved in skeletally stabilizing these pelvises. And then step 4, once the pelvis is stabilized in some manner, is to control the bleed. I think the way that this is done is highly institution dependent and opinion based, but there's 2 essential options. One is to do some sort of IR embolization, and the other is to do pelvic packing. To me, it made some sense anyway that if you have a known arterial bleed, if you have a blush on a CT scan, then perhaps going to IR and coagulating that bleed makes the most sense. And then the opposite would be true for venous bleeds. So if you don't know if it's arterial or venous, or you know for sure it's venous from a retroperitoneal hematoma on a CT scan, then to me, pelvic packing seems to make the most sense. And then if you do one and they're still hemodynamically unstable, then doing the other makes sense. So if you've packed the pelvis, they're still unstable, then going to IR makes sense. And vice versa. If you've gone to IR and they still seem unstable and the pelvis is stabilized, then doing pelvic packing makes sense. But those are your options, I think, your basic options for controlling bleeding in a hemodynamically unstable patient. Okay, so that's the much more simple algorithm. No one's going to forget to do ATLS, hopefully. Once you've gotten through ATLS, you need to identify the pelvis as a source of bleeding. I think that can be done in a number of ways. Plain x-rays work just fine. CT scan with contrast, if you have it, it may help as well. The next step is to stabilize the pelvis. Remember the group in that small bias study, that had the highest mortality rate was the group that didn't have the pelvis stabilized before the bleeding control took place. Once the pelvis is stabilized, however you'd like to do it, whether that's a sheet, a binder, an anti-shock screw, however you want to do that, then I think you can work on controlling the bleed. And that can be done with pelvic packing if you think it's a venous bleed, or you can go to IR and do embolization if you think it is an arterial bleed. All right, that's all I've got for you. Thanks very much.
Dr. Pal, can you please have a seat? I would now request the very young traumatic orthopedic surgeon from India, Dr. Vivek Trikha, to please come deliver his talk. Dr. Vivek Trikha is the professor of orthopedics at JPN Apex Trauma Center, AIMS. His chief areas of interest includes managing pelvic and acetabular trauma, complex intra-articular fractures, polytrauma cases, and infection. He is an inventor and has a patent for a limb immobilization device which is being used in pre-hospital services in India, having mass production by the Government of India undertaking from November 2012. Dr. Trikha has been invited as a faculty in various national and international meetings of CCOT, APOA, and AO Foundation over the years and has delivered more than 700 talks. He is associated with Indian Journal of Orthopedics and Journal of Clinical Orthopedics and Trauma, PubMed indexed in the editorial board. He has over 150 indexed publications on orthopedics and trauma. Dr. Trikha is a member of some professional bodies such as American College of Surgeons, American Association of Dynamic Osteosynthesis, AO Trauma, Association of Spinal Surgeons of India, Indian Orthopedic Association, Indian Arthroplasty Association, and Orthopedic Trauma Association. So here we have Dr. Vivek delivering a lecture on management of marginal impaction in acetabular fractures. Dr. Vivek.
Thank you, Dr. Prabhu, sir. I'll be speaking on a topic which is very important for the people who are managing the pelviacetabular fractures, the marginal impaction and how do we deal with that. No disclosures from my side. First of all, let's understand what is marginal impaction and what are we talking about. It's a rotated, impacted, and fragmented. Remember these three things, rotated, impacted, and fragmented fracture, which has got depression of the osteochondral fragment. We pelvic acetabular surgeons try to make it more glamorous by saying it's marginal impaction. Ultimately, it's the joint or the tibial condyle, the depression which you see, the calcaneal fractures, the posterior facet depression which you see, or in the plafond, what happens in the plafond articular. The same thing is known as marginal impaction in pelviacetabular injuries. But what is very important here is, since in acetabulum, 1 to 2 millimeters of incongruity is going to give you different outcomes. The displacement out here, which will create the incongruity, it will lead to development of osteoarthritis because your margin of error in acetabular fractures is very minimal, 1 to 2 millimeters. Unlike the tibial condyles where you will have around 4 millimeters or 5 millimeters of articular cartilage thickness. If we look, there will be two sorts of marginal impaction, and I'll be showing you the first ones which are on the posterior side, as well as the second ones which will come in the interior side as well. If you look at the posterior wall fractures, the most common way by which the outcomes are dependent upon is pattern, timing. These are very important for us in India, but the quality of reduction, as I was saying, is very important. If you look at this paper from Hans Kreder, you can find out that the maximum displacements and what leads to arthritis is the fracture pattern, the marginal impaction, and the residual displacement or the incongruity which you leave behind after fixation, which is going to give you bad results in posterior wall fracture. So remember these things, because in other articular regions, we can get away by having a 2 or 3 millimeter depression. But in an acetabular fracture, when you have this impaction, you will not be given that leeway, and the results will be on your face within 3 months to 6 months. So there is a classification by AO as well, which tells you that this is that fracture, the 62A 1.3, where you can see that that fragment is small, broken, impacted, separated from the rest of the posterior wall fractures. How and where do we see it? For the people, 2D scans, look at the 2D scans, not the 3D scans. Our young people out here have that thing that we'll see the 3D scans and get into where to fix it. But you will miss out on this marginal impaction until unless you see the axial scans, especially for your posterior wall fractures. So remember that the depression which you are seeing, which has been marked by the white arrow out there, that is the marginal impaction which you need to lift up and bring to the contour of your femoral head, just like the talus and the plafond which was shown in the morning session by Dr. Dhillon, or in the proximal tibia like we do that. I'll just show you one of the examples of this. How do we do and go and fix that? So this is a posterior wall, a high superior posterior wall fracture, which you can see. And you can also see the depression out there, just where the fracture is there of the posterior wall. Adjacent to that, you can have that, this part. That's the one where you will see that marginal impaction, which needs to be lifted up. How do we reduce that? If you see this schematic diagram, you need to lift up that posterior wall, just like you do for any of the proximal tibia or for the plafons. Make sure that the gap which you are remaining needs to be filled up with graft. It may be bone substitute, or you can have your straight autogenous graft right in front of you, which is the greater trochanter, and you can take it from there. And if possible, you put in a raft screw, just the same way as you do in other articular regions, and get your articular cartilage in contour and proper congruity with the femoral head. So this is how it looks like when you open up. When you open up, you will find that the articular cartilage of the wall is looking at your side rather than towards the femoral head. And that's the critical thing out here. This part is the one which is wound. This is the femoral head. This is the second part of the posterior wall. And that's the part which has gone backwards and got depressed, which needs to be lifted up. In more zoomed fashion, you can see what I was saying, the posterior wall fragment, the femoral head, and the depression or the impaction, which needs to be lifted up, just like you do for your posterior facet of your calcaneal fractures. Once you try to lift it up, as it has been done here slightly, and you can see that the entire contour which was empty out here, this thing is shifted towards the femoral head, and the rest of the void which is coming is filled with graft. And that's how you can use a periosteum or an osteotome to lift that up, push it towards the femoral head, make sure that your femoral head is not pressing on that wall at that time, because that will lead to incongruity. And then subsequently, the walls have been fixed, the grafting has been done, and you can see that the entire area has been filled up with autogenous graft out there, so that that void fills and the cartilage is towards the femur. Once you do that, this is how it looks before reduction, and this is how you have pushed back that articular cartilage towards the femoral side and filled it with graft, so that you can now push the posterior wall fragment back onto it and fix it the way you want it to. And that's how you have put in the screws, and then subsequently the way you fix in your plates for the posterior wall has been done. And this is the follow-up films subsequently later on as well, where you can see that it is remaining there as much as possible. Now let's come to a more common fracture or the impaction which happens on the interior side, which has been shown by Jeff Anglin as the gull sign, if you can see, the distinctive double arc on the radiograph. It gave it an ominous look that it is always a pathognomic of having a bad result. But over the years, people have found out and shown that this is not so bad as it was shown out to be in 2003. It's the anteromedial impaction, which is very common in the young patients or in the slightly elderly in Indian population, the anteromedial fractures which you see. And this is the impacted fragment, just like in tibial plafond that you will find. This was the paper which I was talking of. They had 48 patients above 60 years. They had 61% good results, but what they found was the patients who converted to arthroplasty, majority of them had this sign, and it was said to be a prognostic sign, which was bad prognostic sign. But over the years, many papers have come out which have shown how you can get good results even with this dome impaction which happens. This is a new paper which I found in 2023, which also tells you where exactly that impaction is, whether it is superomedial, anteromedial, or anterior, or posteromedial. And based on that, you know where to push back that impacted fragment, because sometimes it may not be visible to you. I'll just show you one of the cases out here with different approaches. We can use the ilioinguinal, we can use the intrapelvic approaches, we can use the modified iliofemoral or the Smith-Peterson with the lateral, with the ASIS osteotomies. So I'll be showing you some cases how we have done with these different approaches. The anteromedial dome impaction. This is the classical anteromedial dome impaction. You see that gull-wing sign out there, and classically it looks like this. The superior part, medial part has gone up. This is the 3D scans, and you can see it in different views. This was done through ilioinguinal. Sometimes you need to make a cortical window over that, and if it is anteromedial, with the bone punch, you can go into that fragment and ensure that you are able to restore back that articular thing. Once you are able to do that, then a raft screw can be put in an ilioinguinal approach, the way it has been put here, maintaining that so that it does not go up, and subsequently with an ilioinguinal approach, this was done around 10 to 12 years back by me. And this is how the fixation was achieved at that time. Over the years, this is the 8 years follow-up, and after COVID also I had that follow-up. And you can see that the thing still remains there after 8 to 10 years, and this guy comes to me even now just to show that he's fine and perfect, and he's now around 75 or so. With anteromedial dome impaction, with gull-wing sign, can be managed, and you can get good results. Not a sign to go in for arthroplasty straight away. Now, another case, which I'm showing you here, where the same thing, that dome impaction you can see out here, has been there. And this was done through the intrapelvic approach, which is a more common approach nowadays. So you go through the opposite side, you look through the window of your fracture, you can use a Cobb's elevator, go above that impaction, pull that thing down in stepwise manner as you are seeing it here. And again, that bone substitute has been put, and then you put in the raft screws there through the intrapelvic, where you can see that fragment, push that down through the window which is given by the quadrilateral plate fracture, and subsequently through the intrapelvic, you can get that fracture fixed up just like that and get the dome back to its position. Another case, similar way, intrapelvic, you can see the dome impaction out there. The classical osteoporotic fracture pattern which we see nowadays so commonly among 45 to 55 years age group in our Indian settings. And the same thing through intrapelvic approach, you can see that the dome has been restored properly back through the intrapelvic approach alone. Through this approach, and this is the follow-up of that patient. Another case showing you the same impaction, very commonly, because remember, you may venture into acetabular fractures, but this has become so common in our nowadays practice that we get around 30 to 40% of our patients are in this age group of 40 to 50 or 40 to 60, and invariably have this sort of a dome impaction for them. You can see this going up, combination, and this was done recently by me by an iliofemoral, which is a modified iliofemoral, the lateral window, along with ASIS osteotomy alone. And the same thing was done, followed first marked out at K-wire where exactly I have to go, saw that impaction, again pushed up with a cortical window, pushed that thing down, made sure that I am able to hold that, put in my posterior column screws, the raft screws above that fragment, and subsequently get the fixation just through a Smith-Peterson with an ASIS osteotomy with a small approach, minimal insult to the patient. However, remember, not everything will be all right always. Anglin had told that there will be failures. This is a 65-year-old male. See the amount of impaction which it has got. We tried to go in and fix that. And this is what we were able to get. We thought we had got good sort of a elevation and compression was taken back. The articular margins were got back. But within 6 months, it failed because it again disimpacted, went back, and it had to be converted into a total hip replacement. So, for marginal impaction, always look for that preoperatively, correct the impaction using the femoral head as a template, can use these grafts, bone substitute or allografts as a for the impaction part. And to conclude, I would say that remember this is the most important cause for the failures of your acetabular fracture, which we in India are going to be getting right now, as most of our population is having this fracture in 40 to 50 age groups right now with the impactions. Always look at the 2D scans. For the posterior side, best is to look at axial scans. For the anterior side, the coronal scan gives you where the impaction is. You need to disimpact it either by making a cortical window or through the fracture site, go inside and push it down just the way you do for any other articular fracture. Use the bone grafts, bone substitutes, or allografts. Accurate reduction, if possible, a raft screw above it, that is going to be giving you good functional results. Remember, as I showed you in the last case, malreduction will lead to poor outcomes in such cases. So be aware of this and make sure that you disimpact it well, fix it well to get the good results. Thank you very much for your hearing.
Thank you, Dr. Vivek, for explaining such complex injuries in such a simplistic manner. Thank you. Can you have a seat, please? And now I invite Dr. Samir Agarwal, who currently works as a professor and is in charge of Level 1 Trauma Center at PGI MER. Currently, he is the chairman of International Affairs and Foreign Fellowship Committee of IOA and president-elect of Association of Pelvic Acetabular Surgeon. He has about 150 publications internationally and national journals to his credit. So he is going to talk on combined pelvic acetabular injuries. Dr. Samir Agarwal.
Good evening, everyone. After two talks, one on pelvis, one on acetabulum, I'm going to talk about what you mean by combined pelvic and acetabulum fractures and how you can manage these fractures. So if you talk about definition, pelvic injuries that require surgical intervention, independent of that needed to achieve acetabular fracture fixation should be considered combined injuries. So both pelvis and acetabulum needs surgical intervention. So if you see this, there's a definitely fracture of the pelvis, but if you see this, is there acetabular fracture? But it may not need surgical. You can call this a high SPR, superior pubic rami fracture, or low anterior wall. So this is not a combined fracture. Another case, this is a primary acetabular fracture. You can say that SA joint is mauled or extension is there, and this is a gray area. You can call it as a combined injury, or you can call it just a acetabular fracture, because fixing acetabular fracture will lead to the corrections of this. But true combined injury is when both acetabulum and pelvis need surgical intervention. The incidence, this paper by Brian Tibbs in American Surgeons in 2008, he analyzes near about 1,034 patients, and out of that 24 patients has isolated acetabular fractures, and near about 61% were pelvic ring fractures. And how many combined? Only 14.1% were the combined injuries. This paper in JOT by Greg and Osgood, he was able to see 40 combined injuries. And he says it is 5% of 854 pelvic ring fractures and 9% of all 457 acetabular fractures. So there is a great variation is there. Some says 5%, some says 14%, 15% are combined injuries. Why it is so? Because there is a lack of uniform definition of what constitutes a combined injury, or when we are writing a paper, a common publication bias of excluding these combined injuries, we want to talk about only pelvic injuries or acetabular injuries. So, how it happens? It can be because of lateral compression injuries when there is a lateral impact to acetabulum of the femur. There is a medial migration, there is a fracture of the acetabulum is there. It may be T-type or transverse fractures. And further, if there is a further force, you can see that it goes to the other side if contralateral pelvic injury is there. So there is acetabulum fracture and pelvic fracture is there. Similarly, if forces are somewhat superior, it may lead to if same T-type fractures or transverse fracture, but ipsilaterally pelvic injury is there. So it can be contralateral or it can be ipsilateral fractures can be there. And remember, significant energy, these are high velocity. So you have to plan it, that is a high velocity injury. Other injuries are, associated injuries are always there. Another, when there is a posterior directed, there is forces that leads to posterior dislocation and further leads to APC type of injuries. There is opening of the pelvis. So there's a fracture of the acetabulum is there and there's an injury to the pelvis in form of APC type of injuries there. And remember, these patients are more often polytraumatized. It means they have a higher injury severity score, greater transfusions are required, and lower systolic BP is there. You have to take care of these patients. And management is two. First is emergency management, then we go for the definite management. And life-threatening injuries must be identified and managed according to the ATLS protocol. You know it. And initial management to be done in conjunction with multidisciplinary team because it may be associated with head injury or blood trauma chest or abdomen. So all the team members should be there. There is a dilemma. Hemodynamic unstable patient with combined pelvic unique treatment dilemma. Normally we say apply a pelvic binder or sheet. But in these cases, it may cause malreduction of the acetabulum fracture, especially when there is a medial dislocation and you apply a binder, it may displace it more. Or you put an external fixator, and you want to fix the acetabulum. That pin track infection may cause infection when you are operating a acetabulum fractures. So, similarly, if there is a posterior dislocation, remember this pelvis is unstable. So stand-up maneuver will not be effective in this case because pelvis may be floating. So if you apply the counter traction has to be there when you are reducing these fractures. So definite fixation, we want to need fixation of pelvis and restoration of acetabular stability must be required in these cases. Remember, pelvic ring injuries are more likely to be life-threatening. It may be appropriate to stabilize the pelvic ring injury first and then acetabular fractures. And definite surgical timing, management of combined injury should be performed as per the patient physiology. Patient is stable, unstable, general status of the patient, and what are the associated injuries. You have to plan it like that. So timing of surgeries should be as early as possible and both should be treated simultaneously. That leads to low rate of pulmonary complication, less organ failure, shorter hospital stay, fewer transfusions, no difference in blood loss and reduced mortality if you treat it. For any trauma surgery, you have to pre-plan it. What should be the imaging? You should at least do so that you can know the injury, what is the injury in the pelvis, what is the injury in the, what type of asteral fracture is it a T-type fracture, is it anterior column fracture, what should be the patient position, what should be the surgical approach, what should be the sequence. You have to pre-plan after seeing all the radiology and patient conditions. And whenever possible, you should try to do it a single approach, because it allows surgeon to deal with both pelvis and acetabulum in a single approach, and he can manipulate the fracture fragments to achieve the anatomical reconstruction. Ilioinguinal is one of the approaches. Nowadays, people are not. So, order of fixation. Surgical reduction of acetabulum signifies correlate to residual post-operative posterior pelvic displacement. So, if you want to fix the acetabulum, your pelvis should be stable enough. So, initial accurate reduction of posterior pelvic lesion must be performed. So, order should be mostly pelvis first, then you go for acetabulum fractures. And as a rule, fixation should from posterior to anterior and from lateral to medial side. And pelvic fixation can be either open or can be closed to provide a stable construct over that. This you can see, there's a fracture of the acetabulum and there's a fracture of the sacrum. Which one to fix first and how to do it? If you see the CT scan, you plan it, and after fixation of the pelvis, percutaneous retrograde screw fixation done, and with only percutaneous fixation, you are able to fix both of the fractures, pelvis and acetabulum. Minimal surgery, and these are the x-rays. Another case, polytrauma, associated both column, lateral compression injury. Again, you have to plan. Go for. So, how can you fix a acetabulum? You have to fix the pelvis first, in this case. And you plan it, you fix it with a single approach. And these are. In this case, if you see, now your pelvis area, if you see this area, can you reduce the pelvis first? Because it is locked. So in this case, you have to, this is exception, you have to fix the pelvis, acetabulum first, then you go for the pelvis. Like in this case, we have fixed it with supraacetabular and posterior screws, and then we have to fix the pelvis. Another case, anterior column with posterior hemitransverse. Again, plan, you can see, you have to fix the posterior also. You can note the sacral fracture is also there. So in this case, posterior fixation, anterior fixation, and pelvic fixation. All three are being done by two approaches basically. And this is the follow-up, 8-month follow-up. 2 days back, patient came to us and doing fine at present. So both injuries has been taken care of. Another patient, history of fall from height. This is anterior column with posterior hemitransverse with sacral fracture. Now you have to fix both. These 2D and 3D CTs are must basically for if you are planning for this, because sometimes you fix the pelvis and then you are unable to fix the acetabulum. See what is the pattern of the fracture, where the fracture is coming, and this we have fixed the pelvis, and by intrapelvic approach, anterior interpelvic approach, anterior column has been fixed like this. Another case, polytrauma, because it's associated with fracture neck of femur now. So we have one fracture neck of femur, acetabulum fracture, and pelvis. It's associated both column fracture, LC type 2. So you have to see what to fix first. So identification of the fractures, all the fractures. And neck of femur was fixed first. Then we have fixed the pelvis. And we have fixed the acetabulum from anterior and posterior side, and these are the results. Another case, From X-rays looks, all fractures are undisplaced. But if you go for CT, your diagnosis is bilateral posterior pelvic ring injuries. There's a fracture on the left side, left crest fracture is there. Sacrum fracture is there, you can see fracture here. There's a segmental fracture of the anterior column is there, and there's a tilt is there. You can see here. So you have to, there are multiple injuries. You have to plan it. And what you do is, first you try to fix it, SI joints, try to fix the crescent fracture, left iliac wing, segmental AC, and bilateral pubic rami you do with the posterior tension band plate. And this is the post-op results. You are able to fix each and everything in a single stage, but definitely you have to change the positions, because if you are doing a tension band, it has to be in prone position. So combined pelvic asteroid injury costs you 2 injuries, and both should be scored separately, as there are no outcome measurements for a combined pelvic asteroid. So measurement, if you see the outcomes, you have to score pelvis extra differently and asteroid differently. Among the 2 injuries, patient outcome is more closely related to accurate reduction of the acetabular component of the injury than to the management of pelvic ring injuries. Panel et al. Reported worse outcome in these injuries as compared to pure pelvic or acetabular fractures. In his series, he says the reasons poor outcome was that there was a poor acetabular reduction sometimes. Because of high energy trauma, there is severe chances of hypertrophic ossification. There may be a sciatic nerve palsy, again because of high trauma, and chances of infection because duration of surgeries in this case are sometimes on a higher side. So take home message that one should understand the mechanism of injury, see the X-ray properly. Don't see only that there's an acetabular fracture. Up to 15% can be a combined injuries. Once you have diagnosed it, do appropriate preoperative planning. Call your friend, discuss it, and do the surgery with the aim to have a stable pelvic rim and anatomically reduced acetabulum. And you have to explain to the patient that outcomes may be relatively poor as compared to pure acetabulum or pelvic injuries. Thank you.
Thank you, Samir, for showing us such complex injuries of pelvis and acetabulum and showing how to solve these problems. In this age of MIS and percutaneous surgery, how can pelvic fractures remain behind? And for telling us that, how to manage these fractures with the percutaneous techniques, Dr. John is going to enlighten us with his talk.
Thanks so much. Those are some beautiful cases. So we're going to talk a little bit about percutaneous fixation here. We're going to go through this a little bit quickly in the interest of time. I'm not going to talk a lot about SI screws, sacroiliac screws. I'm going to assume that most of you who are fixing these cases are fairly familiar with SI screws. Really what we're talking about here is minimally invasive techniques that we can use to stabilize the pelvis. These are largely columnar screws. You have to have good fluoroscopic guidance here. If you don't have good imaging, if you don't have a nice high quality C-arm, if your tube is starting to wear out or your equipment is bad, you really can't do these things. This is the kind of thing that we're looking at, stabilizing the pelvis without, opening this up. This was originally sort of thought to be controversial, but now is really, standard of care. One of the problems I have with these techniques is that although they're relatively easy to perform and, they can provide you with some stability in the pelvis. Sometimes I think on these cases that I'm fixing patients that don't really need to be fixed. If they're not that badly displaced, they're amenable to having percutaneous screws put in. And I sometimes wonder whether we're doing this because we can do it rather than because we should do it. So just be aware of that and make sure that you're, choosing the right patients for this. Most of our older patients really can wait. 2 weeks before they mobilize is not terrible. And mobilizing them on day 2 instead of day 16 may not really confer that much benefit to them. You know, on the pro side, on the positive side of why we fix these things, you know, this is quick, not a lot of bleeding, you don't need to make big incisions, it's relatively safe if you're careful with your imaging. On the downside, there are limited numbers of fractures that you can fix for this. It works best in patients who don't need a lot of reduction, which sort of begs the question of, you know, whether or not these patients even need to be fixed. You have to get familiar with the C-arm, and there's a bit of a curve on this. So, you know, be careful. Once you get good at it, then you'll start thinking everybody needs it, and that may not be the case. For our younger patients, what we're really looking at is minimally displaced fractures that we can reduce and get fixation across. Where ORIF is not possible for whatever reason, either poor soft tissues or patients who are not you know, amenable to large open approaches, patients with head injuries or whatever. Just be careful with this. You know, a fool with a tool is still a fool. So make sure you're doing the right patients. My main indications really, I see a tremendous number of frail elderly patients. And for those patients, sometimes they really have difficulty mobilizing. You'll see patients with sacral insufficiency fractures who've been, you know, struggling for weeks or even months to get around. Patients who can have a less than perfect reduction. Maybe you're trying to stabilize them to stop any protrusio deformity, you know, prior to them getting a hip replacement. You know, hip replacements work great for some of these acetabular fractures, but it may be, you know, more than some of our frail older patients need, and giving them a nice stable pelvis, even if their hip joint's a little bit incongruent, may be enough for them to, you know, be comfortable and mobilize well. You know, really in these patients, what you're trying to do is get them moving as quickly as you can. And it does provide some degree of pain control. You have to be a little careful about looking them on, you know, day 2, day 3, day 4 after their injury. Of course, it's going to be painful. I'm more worried about patients who show up at clinic at 2 weeks, 3 weeks, 4 weeks, and whose, you know, family or daughter is telling me that they really can't get out of the wheelchair at all. You know, leaving patients at bed rest is certainly not in anybody's best interest. So if they get to the 2 weeks, 3 weeks, and they really can't get up and get on a walker, then some of these patients are good candidates for this. For instruments, fairly straightforward. All you really need is a cannulated screw set and some guide wires. Make sure you have long guide wires, and you have to really think these things through ahead of time. If you're just, you know, setting out on this journey and you're just learning how to do it, there's lots of nice technique articles, and there's some great videos on the Orthopedic Trauma Association website, as well as through AO, on how to perform these things. So I would, you know, spend some time, you know, learning the C-arm views and what ones you're going to need, and if you need to, draw some directional lines in order to facilitate this for you. It's particularly important to be thinking about guide wires and how they reflect on the X-ray. If you have if you're working on the convex side of the fracture, then, you know, either one of these is in the joint, but if you have one good view that shows it outside of the joint, then you know that your screws are outside of the joint. You just need one good reduction. Conversely, if you're working on the inside of the curve, on the concave side of the surface, then, you know, there's infinite numbers of wires that you need to make sure that you're clear. Any one wire that crosses over the surface is going to be you know, one wire too many. So just, you know, be thinking through the difference between the, you know, working on the convex side and working on the concave side of the joint. All right, so getting into the nuts and bolts of this, quite literally, superior rami fractures, anterior column screws. Of course, you can go either way, right? You can go from posterior column down to the anterior column. You can go from the anterior column in retrograde fashion out to the posterior column. If you are doing a transverse fracture through a posterior approach, it's pretty nice to be able to put a posterior to anterior column screw down. If you are dealing simply with anterior pelvic ring instability, doing a retrograde screw is actually quite easy. This is a 18-year-old who was at a party and was doing some kind of psychedelic mushroom drugs and managed to fall 5 stories. Had an odontoid fracture, exposed crest through an open wound. But, you know, this is not a terribly, you know, badly displaced fracture. Fortunately, I think he bounced on the way down and didn't do too badly. get familiar with your views. This is an obturator outlet view, so you're swinging the C-arm into an obturator view, and then you're tipping it down towards the foot to give you an obturator outlet view, and that's going to give you a nice view, again, on the concave side of that fracture. You have to start these wires pretty low and pretty anterior in order to get the angle. Right? Something else to be aware of in an 18-year-old young man is that this does put the spermatocord at risk. So make sure when you're putting these screws in that you are really down on the bone, that if you've made a big enough incision so that you can make sure you're cleaning off all the soft tissues before you put this in. The last thing you want to do is go injuring the spermatocord on a patient like this. So just be careful about that. You're going to be fairly low and fairly anterior. To check your opposite view, you're going to be looking at an inlet or at least an iliac inlet view where, sometimes tipping this thing back over into a little bit of an inlet view can be helpful as well. But you're, largely going to be, an iliac view, you're largely going to be looking at an inlet view. And then you can run the wire across. I would say that one helpful technique for this is to run your guide wire in 4, 5, 6 centimeters and then run your drill over the guide wire. So you're just in this proximal segment here, and run your guide wire up to about here, and then you can remove your drill if you need to. And that difference between the 2/8 guide wire and the 5/0 drill will allow you some wiggle room of that wire in order to steer it in the direction that you need. Alternatively, in this case, you can see I've left the drill bit in here because, sorry, let me back up a little bit. Leaving the drill bit in there makes this whole thing stiffer. That 2/8 guide wire from the cannulated screw set can be a little bit too flexible sometimes, and if you need to make it a little bit stiffer, you can leave the drill bit on it and use the drill bit to help you, orient that thing in the direction that you need in order to sneak it across that transverse fracture line. Here we are putting the screw across and tightening that thing down with a nice partially threaded screw, and we got a nice reduction on that. For posterior column fractures, again, you can go either way on any of these. You can go from antegrade or you can go retrograde. I will acknowledge that my tendency is to go antegrade and not retrograde on these things. You certainly can flex up the hip. We had a nice picture from the last lecture showing exactly that, of flexing the hip out of the way, which gives you access to the ischium, and then you can go straight up the ischium and get yourself a nice posterior column screw in that fashion. My tendency is to open up the lateral window of the ilioinguinal. I feel a little bit more comfortable doing that. So for my own personal take when I'm doing these, I will go ahead and open up the lateral window. I think that's relatively easy access, relatively low morbidity of opening up that lateral window, and I always feel a little bit better about that. Putting a column screw down first, putting a rami screw down first and then adding a column screw can really stiffen up the pelvis. This was a 15-year-old young girl who got hit by a car and then dragged. She had a lot of abrasions all over her side and front. We really didn't want to make any incisions on her if we didn't have to. She was initially dislocated and underwent a closed reduction and had this femur fracture as well. Went ahead and fixed the femur fracture early. Her growth plates were still open, so I didn't want to mess around too much with the soft tissue. She had a lot of abrasions up around the hip area, so went ahead and did an open repair of the femur fracture with a plate rather than get into her soft tissues, and wanted to stabilize this acetabular fracture. You can see on the 3D reconstructions, there's her displacement, and there's through the posterior column, we're actually pretty well aligned. This is just lining up the angle that we're going to be putting our screw in. So this wire is just laying on top of the skin, and then we're going to make our incision. And again, I use the drill bit, which helps me orient this. Opening the top window of the ilioinguinal allows me to slide this Cobb elevator down, and you can push on that rami and really get that thing, reduced if you're careful with that, which allows you to sort of sneak that wire across. And again, this is really quite a tight little spot. You can see, in order to get this angle, how low we've started down here, right? So just be aware that when you're doing this, you're really going to be fairly anterior and fairly low in order to sneak this screw across. Okay, but we were able to get that across, and it looks nice. Here she is on the opposite view. And again, I've already opened up the top window of the ilioinguinal here in order to get the rami reduced. and that allows me to go, from above to get that column screw in. And you can see we're nicely lined up here on the column screw, and then bringing that across. That's also relatively straightforward through the top window of the ilioinguinal. The last screw I'm going to really talk about here are these sort of straight front to back screws. These are really super acetabular screws. They're inserted through the AAOS. This is a great way to put an external fixator on quickly. So if you have a patient, we talked earlier about hemodynamic instability. If you need to get an external fixator on there quickly, putting these screws in is quite easy. This is an 85-year-old household ambulator, had this acetabular fracture. And it lines up pretty nicely, and it's pretty amenable to front to back screws. If you bring your x-ray machine down into your obturator outlet, you can find that column that you're going to put that front to back screw in. It's quite easy to find, and it's quite large actually. You'll see in this case here, we run that wire across, and you can move the x-ray beam into the opposite view in order to make sure that you're staying away from the sciatic notch. And you can run that directly across, run a screw in. Pretty poor bone quality here, so we're not getting a lot of compression on that screw. But the column is big enough that you can supplement that by putting a second screw in there. So you really do have a pretty big corridor front to back in order to get those screws in. So you can see there's our 2 screws front to back. And then again, we're going to reinforce this with a screw up the anterior column. Standard getting that across. You have to kind of tease that back into place a little bit. I'm not too worried about getting a perfect reduction here. We're just trying to stabilize things. And you can see here we are sneaking that across with a nice long screw across. I would say this is sort of a B- reduction. In a younger patient, I wouldn't be accepting this kind of a reduction. But again, these patients, lower demand, less likely to have problems. And here's the patient, I believe, at about 6 months. There you go. So in conclusion, percutaneous fixation, really standard of care for these. If you're going to be doing these on a regular basis, really make sure you spend some time thinking ahead of time about how your C-arm is going to be positioned. And, plenty of good videos out there for you on both the AO and the OTA sites on how to perform these things. They're nice, but again, recognize that they work best when patients don't really need much of a reduction. And in that case, sort of begs the question of whether they need fixation at all. Thank you.
Thank you, Dr. John. And this session is open for questions. Please, we have enough time to answer these questions. Okay, just to, for all the panelists, now in case if these bones, or you are dealing with some 60-year-old or 70-year-old, and there is the osteoporosis along with these fractures, pelvic and acetabular. Does your fixation protocol change? Do you have anything else to add on to this? And the second question is that, do you also supplement this with the medical management of giving anti-osteoporotic treatment?
Yeah, so my techniques don't change on any of these with older patients. You just have to accept that you're going to get kind of crap fixation with these screws. I think we have, myself and my partners have different thresholds for who we will do this in, and I tend to let patients sit for 2 or 3 weeks first. I'm not very aggressive about putting these in immediately after their injury. Many patients will settle down and have much less pain and be able to mobilize without these screws. As far as treating their osteoporosis, we're fortunate to have lots of resources, and I have a geriatrician who works on my orthopedic service. So we've hired her into the orthopedic department, and her entire job is to help us manage our elderly patients. So she does our pre-op optimization for all our hip fracture patients, and then post-operatively she manages all our osteoporotic issues. It's helpful to have somebody who has really that sort of medical experience and training and interest in taking care of the geriatric patients. And we've been able to shorten our length of stay, and patients are quite happy having the geriatrician involved in their care right at the beginning. So I don't get involved with it myself, but we've hired somebody to help us with that.
How long do you follow up these patients? 2 years, 3 years, 4 years?
Yeah, I mean, we'll see them at 6 weeks and make sure they're doing okay, and then we typically tell the families, if grandma's having problems, bring her back in. We're happy to see her, but you know, oftentimes they have many doctor's appointments. The last thing they need is one more doctor, and you know, I have kind of a crappy personality anyway, so the old ladies don't really want to see me. So
Vivek, do you want to say something about?
No, in the screws or even in the plate fixation, the one thing which we need to understand is in an osteoporotic patient, your stability has to be much more. You can augment your screws if you have those with cement, especially in these long corridors, the sciatic buttress, the LC2 corridor. And some places you can use pedicular screws and fixations which are much more sturdier and robust than just the screws. So in some of the posterior pelvic injuries, we might go in for a spinopelvic or something like that, or use pedicular screws. Or if you are using one screw, you put in the bone cement also along with that in the iliosacrals, because if you are really putting them in fragility fractures, many of them will just come out. They don't have any hold in that. So the same way as you do for proximal femur, you do for its sacrum as well.
you know, just you know, I couldn't agree with you more on that. Particularly these older patients, trying to put screws into the sacrum can be very unsatisfying. And I will almost always try to run them all the way through and run them to the other side. So I'm just really treating that less as a screw and more as, you know, rebar in the cement. And I'll try and run that screw all the way across from one side to the other, just really trying to stabilize that by length of the screw rather than quality of the screw.
And the one comment I would make about geriatric acetabular fractures, it was mentioned that probably the most common pattern is anterior column, posterior transverse, and that's what we see as well. And not uncommonly, I feel, I will see patients who the posterior column is almost an incomplete fracture, and actually it's the quadrilateral plate that is disrupted. And I would just mention that you can't use a screw, in my experience, to hold the quadrilateral plate. That requires a buttressing plate from an intrapelvic approach to keep the femoral head where it needs to stay.
Yeah, I agree entirely. If you have some degree of protrusio, you cannot pull that head out, put a screw in, and expect the head to stay out. It will just fall right back in again. That being said, doing a stop approach with, you know, a quadrilateral plate to buttress that thing in is a really nice way to hold that thing reduced. Even if you don't have a great reduction, you have a nice, and we had a series, I think we published with you actually on acetabular fractures in the very elderly, where we've basically, without really making much of an attempt at a reduction, just used a protrusio plate to push that quadrilateral plate back down, and it does a nice job of keeping the head from subluxating, you know, towards the midline.
We have to remember that these geriatric patients, there's no partial weight bearing. Whenever you allow them, they will put full weight bear. So you have to be very particular when that your fixation is very secure, and just like cementing, anything you have to put a second plate or sometimes 2 screws. It has to be very secure because these patients don't know what you mean by partial weight bearing.
Yeah, thank you. Dr. Oswal wants to ask some question. Directed to whom?
Yeah, Dr. Agarwal.
Yeah.
How do you manage sacral fractures vertical going to the foramina is one. And second, when you put these percutaneous screws for SI joint,
yes,
how many times you have encountered injury to the vessels or nerves? And how many times you need to open the SI joint and then go into it? Or would you prefer doing a bridge plating instead of percutaneous screws? Then some tips and tricks, yeah.
In fresh cases, I always go for fully threaded screws basically. Because the reduction in fresh cases is not a big problem. But older patient, definitely you have to do the prone position and you have to expose it and do the reduction. And in these cases, I go for the bridge plating.
Yeah. Any tips to get the screw inside when you see the lateral image of the spine? Percutaneous screw going from the ilium
so it
to the
should be in the
sacrum.
center basically. It should be center. You see the line, ilial line, and window you have to finalize first.
And have you encountered any injuries to the vessels or nerves while doing all this? Have you
Vessel,
heard of it?
No, vessel definitely not, but some nerve once we have to take out the screws basically. The post-op patient has a lot of irritation and pain, acute pain, then we have to take it out.
And how do you manage vertical fractures of the sacrum going to the foramina, and what are the indications for open or close or conservative? Yeah.
So fresh cases, I always go for then tension band plating in these cases when we have sacral fracture basically through the foramina.
Vertical sacral fractures meaning going through the foramina, S1, S2, S3, S4, S5.
Yes.
Yeah.
I go for the plating.
Yeah. Yeah. Thank you very much. If there are, okay, one more question. Yeah.
This is for Dr. Toogood and perhaps Dr. Trikha. In a hemodynamically unstable patient with a shattered iliac bone, have you had any experience with bilateral internal iliac ligation? Any experience of doing it yourself or any papers that you might have come across?
You're talking about embolization?
Ligation of the internal iliac.
Bilateral iliac, internal
you
iliac
mean
ligation.
direct surgical ligation? No, I personally do not have any experience with that. For us, it's basically always done with interventional radiology.
Yeah, if I'll talk about the Indian settings, I think that many a times that might be a life-saving thing, because many a times, I don't know if anybody will be having a 24/7 radiologist who is going to embolize it round the clock in any of the hospitals in India. Even in our hospital, one of the best level 1 trauma center, we don't have that. So we have a huge series of 200 patients which we have published from our surgeons, surgical friends, and the team in constrained environment when you really have to work in patients who are hemodynamically in extremis, and all your facilities have been taken care. You have started everything. You have done what all is written in the books. The best thing right at that time is we take them inside the OR, do the bilateral, not the bilateral, or depending upon it, what the situation is, bilateral internal artery ligation takes just 5 minutes or 10 minutes maximum. But I would say that it was abundant in 1970s, and if you see the literature in 1970s and 80s, it was abundant because there was a lot of gluteal, internal gluteal, and the gluteal muscle necrosis, which was there leading to sepsis after 10 days or 15 days, and then the patient used to die of septic shocks. We had our cases, but I think that when you don't have any other alternatives, in our settings, especially when the patient, in spite of all the efforts, and you don't have embolization or is not recovering or so, we have used it to the best of our ability, and we have been able to save around about 70% of our patients like that. I wouldn't say that it should be the first way of doing it. The first way of doing it will be the way which Paul told us, that you follow the ATLS principle, blood, MTPs, massive blood transfusions, protocols which you have. You do a pre-peritoneal packing before, and before that do the stabilization of pelvis. If you have embolization facilities, use that. But however, in spite of all these efforts, if you're not able to save him, that might be a thing which you might use in the end.
Yeah, so thank you. One more last question.
My question is to Dr. Vivek Trikha. Dr. Vivek, first of all, congratulations for the excellent depiction of the impacted fracture that you mentioned. My question is, which approach will you find it better? Iliofemoral or slow pass for the anterior and superior middle part?
Thank you, sir. If you saw the presentation, I'd showed you all the 3 approaches, how to go about and disimpact the marginal impaction. Actually, you need to look at your 2D scans in a proper way, to look at the coronal scans to understand whether it is anteromedial fracture fragment which you are going to disimpact or the posteromedial part. And then based on that, look at where the quadrilateral plate is also broken. If your quadrilateral plate is broken just near to that, which is usually the area where the sciatic buttress is finishing and your quadrilateral plate starts, there you may exaggerate the fracture and then put in your clamp or your Cobb's elevator and reduce that impaction properly through intrapelvic approach. However, if those impactions are slightly more laterally and posteriorly directed, it may not be so well possible through the STOPA approach or the intrapelvic approaches. And that's where the limitation of intrapelvic approaches came about. If you see, the only limitations which have been described as these fragments which are not been able to amenable for disimpaction. Those are the ones where I go in for an iliofemoral, which we normally use in our country, the Smith-Peterson with an ASIS osteotomy, and we make a cortical window and make sure that we are able to do that. So you nearly look in the 2D scans, understand where exactly that impaction is, and then decide accordingly. Majority of times, an intrapelvic approach will help you. However, if it is not amenable through intrapelvic, you may go through the lateral approaches like the iliofemoral or the ilioinguinal for that matter.
So, thank you very much for excellent talks. And we have, the good news is that we have been able to finish on time, exactly at 4. So can I ask the photographer to take the photos of this session?
Doctor,
John.
10 minutes.
Good afternoon, those who are present and those who will be coming inside also. It has been a wonderful day, and I always compliment Insignia, ALKEM, and Dr. Tarun to keep me in the hall from morning till evening. This is the best way to make a person chairman for the first session and the last session. So I have to stick around. Christina, you have delivered wonderful lectures. Can we have you again for talking to all the delegates and the faculty about proximal humerus fractures, right from fixation to replacement. But that doesn't mean that there is no role for conservative treatment. Let it be well understood, and may I have your slides, please?
Hear me? Oh, there we go. All right, let's talk about proximal humerus fracture. So before we start, give me like just a quick show of hands, a quick vote. Just say we've decided to fix the proximal humerus fracture. How many of you are doing ORAF as a first choice? How many are doing hemi-arthroplasty? And how many are doing reverse total shoulder? So ORAF as a first choice is me, always. And then hemi-arthroplasty, anybody? Yep, couple. And then reverse total shoulder as an acute? Okay. All right. Some people are rogue. I like it. So let's chit-chat a little bit. So we have this proximal humerus fracture. You look at it, you're like, oh, it looks okay. They're pretty common, right? About 10% of elderly fractures are the proximal humerus. So we deal with these all the time. And I think most people either love the proximal humerus or hate the proximal humerus. I don't think there's a lot of middle ground. And so I personally love the proximal humerus, but I used to hate it. And so there's little consensus on treatment. I think a lot of you would look at this and say, this is going to be great with non-operative treatment. And then the only thing I would tell you is that this is you. This is me. This is a 50-year-old orthopedic surgeon status post-fall. This is your shoulder or my shoulder. And so does it change what you would recommend? Does it change your gut instinct into what you would do to treat this? And so what would you do? Would you do non-operative treatment, ORIF? Would you put a nail? Anyone put a nail in this? No nails. No one wants to put a nail in. And then hemiarthroplasty or reverse. And I did hear some conservative treatments up there. And so in this particular case, we did decide to fix the patient, but we'll talk a little bit more about other options. So this is just a couple quick slides on some reduction techniques. So this is just a baby Homan placed into the fracture, and this can be useful whether you have a valgus fracture or a varus fracture to help change the position of the shaft relative to the head or the head relative to the shaft. So this is a little baby Homan put in there. If you put it in and then twist it, you can actually kind of like lever up that posterior part of the head and change the angulation and then put a couple K-wires in to hold it. Generally, I'll put the K-wires from sort of like obliquely, anterior to posterior, as you can see right there, and try to cheat them out of the way of my future hardware. Now, it's not shown on here, and I think you guys would all do the same thing, but I usually put gigantic sutures in the cuff. I personally put 2 sutures in anterior cuff, 2 sutures in superior cuff, 2 sutures in posterior cuff, and then plus or minus an extra suture if I feel like it. So I put a lot of sutures in the cuff, a lot. And I usually use number 5 at the bond. So I usually use quite a big suture. And I'll bring those through the plate. And then in this case, we'll sort of use the plate to help the reduction, like that. And then place our screws. And overall, I think a pretty good reduction for the patient. But just sort of take a look at it and think to yourself, what do you think of that hardware? If you were to give yourself a grade, is it A+ hardware placement, or is there something that you would improve? And so I personally would improve this. And what I mean by that is that your calcar screws are, I think, your most important part of, one of the most important parts of this construct. And to me, when I look at that, those calcar screws are 1 millimeter or 2 low. They're missing the calcar, right? So they're actually still in the shaft portion of the fracture. They haven't actually captured any portion of the head or the lower portion of the calcar. So I would air up just a tiny bit in general for this. And so this is a different patient. but almost an identical fracture, right? So instead of being a 50-year-old surgeon, this person is a 76-year-old female who just fell in her kitchen. And so almost identical fracture, but treated very differently. So we just treated this non-operatively in a cuff and collar. And it certainly looks uglier, right? But she looks great. So she can use her arm really well. And almost notices no deficits. You can see she can't quite get it as high as the other side, but she can still reach things from a cupboard and pull them down, and she doesn't notice real limitations. And so she has done just as well as our friend who had an ORIF. And actually, if you look at the literature, this is a recent Cochrane review, so kind of combining as many of the studies out there that are high quality evidence, published in 2022, and they evaluated 47 trials. And the things that they could actually say with high or moderate certainty evidence is really surgery is no better, has no better outcomes, even in displaced 3- and 4-part fractures, than non-operative treatment. And so across the board, kind of all comers, especially elderly patients, we really don't have great evidence that surgery is any better than no surgery. There's low certainty evidence, or at least no real published evidence to support the idea that ORIF is better than a nail or vice versa. And there's really low certainty evidence or no real evidence to support that quality of life or functional outcomes is different between reverse total shoulder and hemiarthroplasty. So that actually was surprising to me, because if you talk to anybody who puts in reverse total shoulders regularly in the United States, hemiarthroplasties don't work at all, and reverse total shoulders are perfect. And so that's obviously not the case, but it's pretty skewed in the US right now in terms of what you would do. Almost nobody would do a hemi anymore, but there's very little evidence to support that perspective. So for me, what I do with the proximal humerus and how I do it has a lot more to do with who the patient is than what the fracture is. So this is a 41-year-old laborer who has a proximal humerus fracture, multiple parts, really not terribly aligned, but anyone who's younger than me gets a benefit of the doubt in terms of their treatment plan. So he gets to have an ORIF, and I talked to him about it. And there's a couple different things that I usually will do. If I'm having trouble stabilizing the head or holding the angle of the head, even with K-wires as joysticks, I will often pin the head at the position that I want. I'll pin it into the glenoid, which we were doing here. He was a very muscular guy, and so we were having a little trouble with our retractors not moving things. And so I did pin the head into the glenoid in this case, and then put in those screws. And I will really try to focus on getting those bottom 2 screws, those 2 lockers into the calcar, getting both of those into the very base of my humeral head, and also making those my longest screws. So there is obviously a problem with screws protruding in proximal humerus, but those particular screws, even if they do protrude, are not interfering with the cartilage as much as the higher screws. So he actually did really well. He healed nicely. He didn't have any shift in alignment. Here's another example, a little bit of a different fracture, maybe not somebody that you could make an argument for non-operative treatment in. And so a 51-year-old deep sea fisherman, it's his non-dominant hand, but he's, dislocated, so we have to do something about that. So we got the head out, an hour later, and this is what the fracture looks like in that first picture. And maybe the saving grace for him is he actually had quite a long calcar. So especially posteriorly, he had quite a long calcar that had some preserved soft tissue attachment to it. I did use, and I often use, a little anterior mini frag or small frag reduction plate to help hold that alignment while I put the rest of the plates and screws in. So that, to me, frees up my hands and makes the number of moving parts a little bit less. So he did really well. No pain, excellent forward flexion, not great abduction, but he doesn't care. And then pretty good external rotation and internal rotation. Here's another fracture that is very similar to his, but in a different patient, right? So 60-year-old female with osteoporosis who is status post-fall. This one is her dominant arm, and she was dislocated, so we did have to do something. We tried to close reduce her in the ER, but I personally find that a lot of these are almost kind of trapped in a soft tissue area that is quite difficult to reduce. So I think it's worth trying, but I don't think it's worth trying, 10 times in the emergency room. So she had no deficits, but we were planning to take her to surgery. And so for me, if a patient does not have neurologic or pulse changes, to me this can wait until the next morning, and it usually does. And so same kind of idea. I use that, in this case, a small fragment anterior reduction plate, right at kind of the inferior spike of the proximal segment, to keep that held in place while I put my plate on and figure out exactly where I want my plate to be. And that top corner picture, that's me determining that I like where the plate is, right? So I always make sure that my top screw is not too high, and I always make sure that that calcar screw, the bottom of the calcar screws, is going to go exactly where I want. So I do that by putting the guides in and putting the wires in those locations. And if I like where the plate is, with respect to those two main screws, I almost don't care where the other screws go in the head. Those are the two that I care about the most in terms of plate placement. You can also see there in the bottom picture that I have a clamp on the trochanters. So if people have relatively large greater and lesser trochanter fragments, I will often clamp them together until the plate is on and the sutures are secured, and then I will take off that clamp. That, I think, helps prevent especially the posterior, so the greater, it sort of prevents that from escaping out the back as you bring your plate down. And so she also did very well. She didn't have any issues with AVN. She has great shoulder motion. She healed really well. And so that's all well and good, right? I'm sure we can all show examples of ones that went great, but that doesn't always tell us much. So I think let's look at some that didn't go great and figure out what we could have changed, maybe to change their outcome. So this fracture, as it spins around, you can kind of get a sense of sort of how big the head piece is, how big the greater tuberosity piece is, and where the fragments are. So 73-year-old osteoporotic status post-fall. And so this patient was treated operatively, and there's their construct. And if we look at this, I would say the reduction looks really nice, actually. And then when I look at it, obviously in hindsight, I try to look at the hardware and think what could be different about the hardware. And the reason I look back at that is because this is what she looked like first post-op visit. So you can see she's already starting to fail. And this is what she looks like 6-week post-op. So she's sort of having escape of the proximal fragments away from the locking screws in the plate. And so what is it about the way we put the hardware in that could have changed that? It may just be that her bone is so terrible nothing would have held her, but is it possible that we could have put our hardware in a little bit better so that she didn't have that same outcome? So what I look at when I look at these x-rays is I would say there's a couple things. Your screws are clustered pretty kind of asymmetrically in the head. I like to try to get the screws to have a pretty good spread anterior, pretty good spread posterior, and also have a pretty good spread superior, pretty good spread inferior. So she does have a good calcar reduction. She does have good calcar screws. One thing in the literature that has also been linked to failure is cross-threading your screws. So essentially putting the screws in a way that they're cross-threaded in the plate and have maybe less grip, and that I think was also done in this case. So you could argue she just failed because her bone was of not great quality, and she did go on to have a reverse, but maybe we could have done a little bit better with our screw placement as well. Here's just one more that didn't do well. In the operating room, they actually looked pretty good. They've augmented with a fibular strut as well. And we'll talk about this in a second, but they come back to clinic 6 weeks. The status post-fall is her original injury. She has not fallen since, but she's already having loss of fixation, and you can see that whole head fragment is sort of rotated off. And so what is it about her fixation that we maybe could have done differently? And when I look at this, I'm just worried that essentially they sort of overstuffed that allograft and that the head is too far away from the shaft. Does that make sense? So when I look at it, the head, the sort of cartilage of the head to the plate, that distance is too long. And so I think that didn't give it, that sort of made it inherently unstable through that area. And she went on to reverse, but also keep in mind, that reverse is not without issues, right? So this is actually her. She dislocated and she got infected. And once you have a dislocated, infected reverse, you don't have a ton of salvage options, right? There's not a lot of places you can go from here. And so she is almost at the end of the line of her options. She was actually revised and is staying in for now, but it's not a perfect solution. So what are predictors of failure of ORIF? So decreased cortical thickness, meaning osteoporosis, meaning terrible bone, and that's obvious. You guys all know that. Failure to restore the medial calcar, no calcar screw fixation, and then possibly cross-threading of the screws. And so let's just look at a couple other quick pieces of literature and then we'll wrap up. So there's a couple different studies I want to talk about, one of which is that if we look at reverse shoulders done for salvage of ORIF or hemiarthroplasty, the outcomes are better when you're salvaging an ORIF than you are when salvaging a hemiarthroplasty. And so our shoulder colleagues who are going to do that revision, or you if you're going to do that revision, may prefer to do it after an ORIF than a hemi. Also, when you compare reverses to hemis, it looks like there may be some more reproducible functional outcomes, but not a lot of other difference. And that may just be because obviously your hemi is dependent on the healing of the tuberosities, whereas your reverse is not. And then looking at if you do an acute reverse, it's essentially equal to doing a salvage reverse for non-operative treatment. So basically, if you fail non-operative treatment and you do the reverse, their outcomes are as good as if you did the reverse to start with. But if you do a reverse to salvage a failed hemi or a failed ORIF, then your outcomes are not as good as if you had just done the reverse right off the bat. So sort of the take-home message there, we will get to kind of at the bottom of this list, but operative and non-operative treatment yields acceptable results. We saw that in the first two cases, almost identical outcomes with surgery or no surgery. It doesn't seem like there's any one specific treatment that's better than the other treatments. Reverse total shoulder is a good salvage if you fail your ORIF or your hemi, but your reverse outcomes tend to be better if you do them acutely as opposed to if you do them as a salvage. So my take-home point at the bottom is I would still try very hard to treat somebody non-operatively unless I had a compelling reason in terms of their function and age to treat them surgically. If I do treat them surgically, if that patient is at high risk to fail their ORIF or their hemi, that's the person you want to really consider for an acute reverse shoulder, because if you do the reverse shoulder acutely, they will do better than if you do their ORIF and they fail, or if you do their hemi and they fail. And so that's sort of the algorithm that I use to determine who gets what. And we'll wrap it up there.
That was wonderful explanation about a difficult fracture which can be treated conservatively till the final situation whereby we do reverse shoulder arthroplasty also. Questions will be at the end of it, although all the topics are different. But let Dr. John talk to us about delayed fixation of humeral non-unions.
Thanks very much. So, you know, when I'm faced with these non-unions, I frequently wonder, you know, why are we waiting so long? And I think also this is one of those, you know, humeral non-union surgery in general, I think this is one of those funny situations where we treat our patients differently than we might treat ourselves. So this patient was sent to me 9 months after injury. And the surgeon told this patient that it might take a year to heal. Who's going to wait 9 months on their humeral non-union? Please, well, try and raise your hand. That doesn't work, right, if you have a humeral non-union. Like, none of us would wait 9 months on a humeral non-union, right? Let me just ask a quick question. If you had this injury, who would get it fixed acutely? Who would just call their best friend and say, like, almost all of us would. But who would fix this woman acutely? Not too many, less anyway. So the way we treat our patients sometimes is how, you know, differently than way we would treat ourselves. Now, this woman was in her mid-80s, right? So, you know, she gets fixed in the standard fashion for non-union surgery. Nothing terribly complicated here. But the point I would make with her is that if you take an old patient, and this woman's, 85, and you lock up their shoulder for 8 or 9 months, that shoulder's gone, right? They are not going to recover from that. And this is her about 6 months after her injury, never got her shoulder function back again because she sat there for 8 or 9 months not using her shoulder, and that was enough to throw whatever muscle function she had left in that shoulder right out the window. So be careful about letting people sit too long. The one thing we know about humeral shaft fractures for sure is that when they fail early. This is one of my favorite papers. I'm always harassing my residents to make sure they understand this. This was a simple study where they looked at patients at 6 weeks and saw how mobile they were and whether or not being mobile predicted surgery. They had 73 patients here. Only one of the patients who was mobile at 6 weeks eventually went on to union. Everybody else got surgery. So motion at 6 weeks with 82% sensitivity and 99% specificity predicted surgery. So if you have motion at 6 weeks, you need surgery, right? If you have motion at 6 weeks, you need surgery. Your likelihood of healing is extremely small. So don't wait, because non-unions get established early. They are a failure of endochondral ossification, and that motion is predictable in the humerus at 6 weeks. It's predictable in other bones as well. And I think we probably are waiting too long on most of our non-unions. This is a study that was recently reported. These guys were at the OTA, and then the paper came out in Injury. It's a very interesting study. This is in sheep here, but they've done it in humans as well. They basically put a very low load on the leg and get a very small amount of motion, and they have some very sensitive antennas that broadcast just an antenna wave, just a regular frequency wave into the leg. And very small amounts of displacement change the frequency of the antenna, the resonant frequency of the antennas. And they can predict quite reliably what's going on with fractures at a really early time point. So they made some non-unions here on the right-hand side, and you can see that even in this early time points, sorry, yeah, there we go. So here at our early time points, we're getting nowhere here. Even here at 2 weeks, right? This is only 2 weeks after surgery. You can see this rapid drop in the amount of motion that you can generate at the fracture site. And here in the non-unions, really, even at these early time points, 2 weeks, 3 weeks, no drop. So these fractures are really easy to predict early on. And if you have motion at the fracture early on, you've got a non-union. And they never correct. This never gets better. So once you've got an established non-union by motion at a 6 week, at an 8 week time point, like that ship has sailed. And waiting for 6 months or 9 months or 12 months is kind of crazy. So, here's, I showed this case earlier today, the first one there on the left, that's a patient at 8 months. This patient, for lots of odd social reasons, waited 2.5 years for this one. This patient was referred to me again at 6 months, and here at 5 months, again 8 months on these humeral non-unions. 6 weeks, you get 6 weeks to heal your humerus. If you've got gross motion at 6 weeks, certainly by 8 weeks, then you should go ahead and have surgery. So I know this is a talk on what to do with long-standing humeral non-unions, but we really shouldn't have long-standing humeral non-unions, right? If the patient hasn't healed by 8 weeks, they should go ahead and get surgery. This patient got wrapped up in COVID. She was very worried about coming to the hospital, so she had this humeral fracture. It was really a comminuted mess. She got put into a humeral fracture brace, and quite a lot of it actually healed, nicely. This is quite common with non-unions, right? We've all seen this where the motion gets concentrated in one plane. There's not much motion everywhere else. So everywhere else heals, and she's left with this motion. And then the question becomes, how do you deal with this? In general, I won't take down these malunited proximal segments. People don't have to have a perfectly straight arm to be perfectly functional. So in this case, I think the most important thing that you can do with these well-established non-unions is turn it back into an acute fracture, right? Turn it back into the fracture that it was when it started. And for me, that means opening up the canals and cleaning out those canals and making sure that we're turning this back into a cylindrical bone, right? Oftentimes the canal will have healed over with a bony pedestal, and you have to really get in there. In this case, I got a drill bit in here to get this all cleaned out, and then I'll make sure that I've got nice, bleeding bone as far up as I can reach with my curette on both sides. And then what I need is good, solid cortical contact, right? If you want these bones to heal, endochondral ossification's out the window. We're here to put rigid fixation on them. These patients all in my practice are all getting lag screws. So if I can't get a clamp across that with good solid bone to put a lag screw across, I'm not done, right? And I've got to keep working this problem until I can get that back together. So here I'm just putting lag screw fixation across that, and then I'm going to back it up with a good plate. I have a very low threshold for putting a second plate on these. Particularly in something that's a little bit of an odd, in this case, this is an oddball situation, right? This is not lined up very well. A secondary plate on this is going to just give me, a little bit more stability and a little bit more peace of mind. So on these, wacky, long-standing humeral non-unions, I'm frequently using 2 plates on these. I am always using lag screws, right? So you won't see any of these cases here that don't have lag screw fixation. If you get the canals opened up, if you reestablish this as a circular tube, if you get clamped in a nice stable position that you can put lag screws across, these will heal almost uniformly, right? They don't require a lot of bone grafting. They don't require a lot of adjuncts short of a good, solid, well-executed reduction. So in this case here, we'll go on to the next case. Similar situation, this is a 58-year-old guy who was frustrated because he worked a desk job, but he was having trouble still running his keyboard. And he came to see me at 8 months. Again, surgeon told him he should wait for a full year. That's crazy, right? You should wait 8 weeks, not 8 months. So we had a long conversation about this. One's a little bit tricky because it's so long and we don't have a lot of distal fixation to work with. These are not complicated. This gets a standard posterior approach, right? Anything in the bottom quarter of the humerus definitely needs a posterior approach. You've got to find the radial nerve. You've got to get it out of the way. You've got to reestablish the canals, and you've got to get this thing clamped in a mechanically stable position so that I can get a lag screw across it. Now, in this case, I shortened him a little bit in order to get good bone apposition here. I shortened this down a little bit so I could get a nice clamp across it. And this big butterfly fragment's not going to fit anymore perfectly because I've shortened it down a little bit. I don't feel necessary to chase after those butterfly fragments if I get good bone contact on my reduction, right? So if I have an incomplete tube, but I have a nice stable reduction with my clamps and my lag screw, then I'm okay with leaving the butterfly fragment alone. Sometimes you can actually use the butterfly fragment to augment your fixation. So in this case, we sort of freed up that butterfly fragment and then screwed it into place to use the butterfly fragment as a secondary plate on this. Again, we have nice solid fixation all the way down, distally and well proximally. You're definitely going to have to find your radial nerve and make sure that that thing is well protected. Handle that radial nerve with a little bit of grace. And here he is at 6 months. This always looked a little bit odd to me, so I called him actually before, as I was getting this talk together, just to see how he was doing, because it had been a couple of years. And he told me I interrupted his basketball game. He needed to get back to his basketball game. He didn't want to talk. So he's doing just fine playing basketball. This is the last case that we'll show on this. Again, this is a shorter duration. This has only been 4 months, but the patient has his radial nerve out, and that's going to be a fairly common occurrence. By 4 months, most radial nerves have recovered, right? If you're seeing the radial nerve out at 4 months, that for me is going to be, I'm leaning towards exploring these things because by 4 months, you ought to be starting to see some recovery of that radial nerve. Here's his radial nerve. I'm not sure how well this projects, but there's the radial nerve right there. This is anterior, and this is posterior. Your radial nerve should not be anterior of the humeral shaft, right? It should never be anterior like that. This little close-up here shows it a little bit better. You can see how kind of beat up this radial nerve is here. But again, here's the distal segment, here's the proximal segment, and the distal segment has wrapped around, the radial nerve has wrapped itself into the non-union site, wrapped itself right around here. So make sure you are finding your radial nerve. It's super easy to find, right? After you do, 6 or 8, 10 non-unions, you're not gonna have any trouble finding your radial nerve. Just find it, be careful to it, be nice to it, pat it nicely, and then go away from it and don't go back to it, right? Find it and then stay away from it. In this case, we had to unwind the nerve. And then once we've unwound the nerve, this is, again, fairly straightforward situation. I am definitely using lag screws. You can see I've got these 2 lag screws across here, stable fixation, and then a nice long plate to back up my lag screws. The last point I would make, this is a Herder Brothers table. This was made in 1880. The Herder Brothers were 2 German immigrants to the United States who came in the mid-1860s and started up a design build firm. They really were master carpenters. This is in the Metropolitan Museum of Art in New York. This is just beautiful craftsmanship, right? This is in a museum for a reason. This is just a gorgeous piece of work. And now 140 years later, we're still celebrating the Herder Brothers craftsmanship. And I would say these humeral non-unions, this is an opportunity for us as surgeons to appreciate our craftsmanship, right? These are ones where you take apart the non-union carefully and you protect that radial nerve carefully and you bolt that bone back together in a nice stable configuration. And if you're a little bit of a craftsman here and you don't trash the bone, these are going to heal with great regularity. And really, you don't need bone graft. You just need good, careful skills. And these are really an opportunity for us to be craftsmen. And I would encourage you to celebrate that aspect of our profession. That's one of the joys of being an orthopedic surgeon is to be a craftsman. So these are opportunities for that. And these are kind of my favorite cases to put together because patients are happy, low complication rates. You can generally get a good result. And, it gives me an opportunity to try and, hone my skills on being a craftsman. So in conclusion, don't fix chronic non-unions of the humerus. Don't even make chronic non-unions of the humerus. If they get to 6 or 8 weeks, just fix them. They fail early on, and we know this from lots of good biomechanical data as well as good clinical data. Motion at 6 weeks, predictive of non-union, just fix the thing. So don't fix chronic non-unions. Stop them before they get to be chronic non-unions. In this case, use lag screws. Luke is supposed to use the force. In this case, I would tell him use lag screws. Put a long plate on there, often 2 plates. And also, take some pride in your work as a craftsman to get these things back together where they belong. Thank you very much.
That was an excellent presentation about the difficult situations of... Sir, please come here. Dr. John. And I'm really surprised in your part of the world, the patients can wait for 7 months and the surgeons can say that wait for 1 year. It's very surprising, but then that's the fate. Now, I'll take 1 minute because Dr. Robert has been waiting since morning to get his lecture. So let me introduce you in a short while. Dr. Robert David Golden is a member of Midstar Orthopedic Institute and currently serves as a Chief of Orthopedic Trauma and Midstar Washington Hospital Center. He has completed his residency from Brigham and Women's Hospital and fellowship from the R. Adams Cowley Shock Trauma Center at the University of Maryland Medical Center. Dr. Robert is an active member of the Orthopedic Trauma Association and a clinical professor at George Washington University, as well as the academic staff at MedStar Georgetown University. He also received the 2017 Nurses' Choice Collaboration Award as a recognition of the outstanding work he is performing. But it's not only nurses, even doctors appreciate him. Thank you very much. And let's have a talk about clavicle fractures, how the pendulum has been swinging and where it is now so far.
right, well, thank you for having me. Hopefully everybody's still hanging in there. It's getting late in the day, and post-lunch it's tough. But we're going to talk about clavicle fractures, pretty common injuries. Used to never do anything with them. Now there's a lot of controversy about them. I don't have any.
Sorry for interruption. Can somebody adjust his mic, please?
Is that better? Got to get it off of Wickstead height. So again, these are pretty common injuries. About 2.6% of all fractures, middle third making up the vast majority of them. So that's what we're going to mainly focus on, especially because that's pretty much where all the controversy is with all these. Traditionally treated non-operatively, even when substantially displaced. This was actually the first thing I ever learned in orthopedics is day one as a resident. George Dyer, who some of you may have known or may know, he writes a lot as a hand surgeon, was taking me around the ER and said, here's your first lesson. You never need to operate on these. We saw a patient with a clavicle fracture. He said, now you know what to do with this. Now you just got to learn the rest of ortho. And this was all based on a couple classic articles. So Neer and Rowe both reported on these, and basically they had a 0% issue with them. They said they all healed, everybody did great, and they actually suggested that if you treated them with surgery that you may actually cause some non-unions. They talked about malunion just being something you saw on radiographs, didn't really matter. Just as a review, this is why you get some of the deforming forces. You could see the sternocleidomastoid up there, pulling it up. The deltoid pulls it down and towards the front, and the pec helps it angulate. People started to challenge this, though, in early 2000s and looked at some different things and said, well, actually, these all don't heal. Maybe 20% of them don't heal, and other studies showed a much higher non-union rate if you let them just go non-operatively versus plate fixation. And so people started to question this a bit. Other studies then looked at it and said, well, not only are they not healing, but a lot of people are unsatisfied. That 30% of them say that they're not happy with this. So then we started to question, well, what do we do about them then? And in 2007, basically everything changed. This was like, there's very few papers that sort of come out that really have a huge impact. I think this is probably one of the ones that had the biggest impact, certainly since I've been practicing ortho. And most of you are probably familiar with it, but we'll spend a little bit of time on it because a lot of people sort of kind of know a little bit about it, but maybe not have looked at all the details. But this was out of the Canadian Orthopedic Trauma Society. Big study, made a lot of news. Couple different study centers, lots of patients, and they randomized people basically to fix them or not fix them. These were all mid-shaft. They were all completely displaced is how they described them, which basically meant 100% shifting. And they were mostly just looking at dash scores, but they did have some secondary outcomes, which ended up being kind of important. They included a lot of patients and big age range from 16 to 60. But the big thing was all the fractures had to at least be amenable to plate fixation with 3 screws, proximal, 3 distal. And they were plating all of these on the superior part. They excluded a bunch of things that didn't really matter. Mostly the longer term ones are people with lots of other injuries. The non-op group, basically they just put in a sling for 6 weeks, but most of the patients didn't stay in the sling for 6 weeks because they started moving as soon as it started feeling okay. They started some PT once it felt a little better. On the operative side, like we said, all of these were fixed with superior plates. And again, if you look at sort of the breakdown, this may be a little bit different, certainly from how we treat them in the US now, but just a range of small fragment plates. Very few pre-contoured plates, which I would say most of the plates probably being put in the US now are pre-contoured. And basically that just describes how they fix them. Superior plates, they tried to put lag screws in, kept them in a sling, then let them start moving. Followed them up, mostly looking for dash scores and constant scores, did radiographs, and they followed them for a year. They did report on some adverse events with non-unions, malunions, or anything else that needed to go back to the OR or any other treatment. This was an intention to treat study, so there were a bunch of people who switched groups, but they kept them in the original group, and 62 in the operative and 49 non-operative. And this is the big result that essentially came out of it. the constant score. So they had predetermined that a constant score of 10 would be clinically significant. And when they plotted out their results, as you could see, basically it was greater than 10 the whole way around. But if you kind of look at the graphs, it's bigger towards the 6 week, and as time goes on, those graphs are converging a bit. If you look at the dash scores, it's essentially the same thing. In the beginning, pretty big spread, they get a little bit closer. Again, same thing, they had determined that 10 points on a dash score was clinically significant, so they said, well, that's what it is. They asked a couple other questions, just are you satisfied with it? And more people said yes if they had it fixed. Interestingly, the range of motion was the same in both groups, which was kind of important. They did note that the fracture union was quicker, and people basically thought the appearance was better. So the strengths of this, it's a big study, lots of different centers, lots of different surgeons, so it lends it to some generalizability. The weaknesses, though, it's only plate fixation, it's only superior plate fixation. A lot of people in the non-op group were lost to follow-up. And the biggest weakness, I think, of this is what is 10-point difference in a dash or a constant score? I don't have any idea. They had sort of defined this in the beginning, that that's what's significant, and people kind of say, okay, that's a significant result. But I have no idea what that actually means. So we're basing a lot of this on sort of people saying that this is what's important on this outcome score. And because of this, people changed their practice. I think it was probably one of the biggest practice-changing things that ever came out. This is a patient who came in, fall from scooter. That initially would be a non-op. They came back a couple weeks later. They fell again, same side. So now this is exactly the fracture they're discussing. It's displaced, it's shortened. So they get fixed, and there's an anatomic plate, and we're happy. And I think that's happened now a lot since this study has come out. And there's been several studies now since that demonstrating that that there's been a big increase in surgical management of these. The study that's mentioned up here looked at management of all locations of clavicle fractures and found about 12% of them are getting operated on, but 17% of the midshaft ones, so basically the ones like this. And importantly, if you look at the time of this, in 2015 it was 7.5. By 2020 they were almost to 14%. So there's definitely this trend of getting more and more surgery for these. Prior to that study ever coming out, people had already looked at some of the non-op treatments. This was a study back in '97, so way before the Canadian study that looked at, these are all non-op people, displaced midshaft. And again, they started seeing this non-union and these unsatisfactory outcomes. They had already described sort of this correlation between the shortening and worse outcomes. After the study, people looked at it again. Here's more non-op people. These are 92 people, all displaced midshaft, non-operative treatment. Same sort of thing, big non-union rate. But they actually reported a very high sort of unsatisfaction rate, with 53% of the people at over 2.5 years saying it still hurt. And again, correlated things with 100% displacement had worse outcomes. That being said, I think we've all had patients that would fulfill that criteria who you just don't see that in. So here's a 73-year-old guy, big displacement, fairly comminuted. He didn't really move his shoulder at all at that point. There's lots of reasons he couldn't have surgery and didn't want surgery, and we didn't really want to operate on him because of a lot of those. Here he is at 5 weeks, right? Doesn't look like much is healing, but his motion's pretty good right now. He's got a little bit of pain at the extremes of motion, but otherwise feels okay. 11 weeks, sort of the same thing, not much healing, but feels relatively okay. And at 24 weeks, again, nothing looks like it's healed. It doesn't move at all when you push on him. It doesn't hurt him at all. He's got a full range of motion. Says the only problem with it is it interferes with his suspenders that he wears because it pushes him off the side a little bit. This is another guy. This is a segmental clavicle fracture, maybe a little hard to see. The laser's not really, there you go, not working so well. But you can see there's this medial piece here down to here, and then the distal part, fairly displaced. This guy had a lot of injuries, so he was not a candidate for surgery. This is him 5 months post-op, and you can see he did form bone here and there, and he felt fine and moved, and his only issue, again, was that he felt the bump, but it didn't really bother him. So people have been looking at, is this study real? Since that time, here's a meta-analysis that came out in 2019 that looked at this, looking at 9 randomized controlled studies, all looking at plates versus non-op, and they found statistically better with surgery in terms of non-union, malunion, and appearance, consistent with everything we've seen, but no difference found in the DASH score. And they did mention that ORAF had many more complications. Another study, probably even a better one, in 2017, was another multi-centered prospective randomized controlled trial, very similar setup to the original one. This was 18 to 60 years, so almost the same population. Again, displaced mid-shaft clavicle fractures. Their primary outcome was non-union, but many of their secondary outcomes were the same as what the other studies had looked at. And they found that the non-union rate was higher in the non-op group. Again, not a surprise at this point, 23%. That's in line with many of the other studies. Because of that, the secondary plate fixation in the non-union group was higher, not surprising since that's the group that had the non-unions. But secondary operations were really high in the operative group. Almost 28% of the people who had had surgery had another surgery, and almost 17% of them to get the plate removed. And they found no difference in the DASH scores or the constant scores. So their conclusion has a very different tone from a lot of the other studies. And as you can see there, basically the end result was that if they're displaced by one shaft width, the plate fixation improves the chances that the bone will heal, but the rate of patients who need a second operation is considerable, and the procedure does not improve shoulder function or general symptoms, and it doesn't decrease limitations compared with non-operative treatment in a sling. So that's a very different tone. They're basically saying, well, you can make it heal, but it doesn't matter. Again, here's a 21-year-old. He was a polytrauma. That looks pretty good when he first comes in. He's got a lot of injuries, burns, a head injury, a tibia, open tibia, he had a femur fracture. People sometimes would use that as an indication to help him get up and mobilize. He was in the ICU for a long time. We did not operate on him. He did displace a bit, but at 8 weeks, you can see he's forming tons of bone, had pretty much full range of motion at that point. And by 12 weeks, he's got mature bone and had no pain or anything. Interestingly, this is the only fracture he's healed. He hasn't healed his tibia or his femur at all. So if we know that the plates are maybe the issue, what's going on with the plates? So there's been studies even before the 2017 study that we looked at that was already identifying issues with the ORAF. This one looked at patients who were all fixed. Again, mid-shaft clavicle ORAFs, these were all pretty much superior plates as well. And within 2 years, about 25% of the people had another operation. So pretty big. That's a big chunk of them. If you look at a lot of there's other studies that have shown this as well. Most of them also show that females are predisposed to have it removed. Patients with a low body mass index are at higher risk for removal at all. That being said, this was a young, thin female. She was recently treated. Originally we were going to go non-op with this. She was fine with that. She came back. This was 3 weeks later. It looks like it's probably shortening a little bit, more angulated. She didn't like the bump that she could feel. It was interfering with where her bra strap came over and had almost no range of motion in her shoulder. She wouldn't move it because it hurt. So we ended up fixing it. The lag screw, there's the anatomic plate. Those have also been shown to maybe reduce the risk of needing the plates removed. And then this was her 6 weeks later. She's already healed most of it. She has a full range of motion, no pain whatsoever, and was pretty happy with that. Some other things to consider, we won't get into these too much with this just because of the scope of time that we have, but people have proposed, well, maybe you put anterior plates on, dual plates, maybe intramedullary devices. All of these, as they first came out, were sort of a big flourish of, we'll just put it anteriorly. That won't bother people. It turns out, if you look at most of the studies, it's almost the same rate of removal of them. So they do still bother people. Dual plates is sort of the new in vogue thing now in the U.S. with using smaller plates with the hope that they'll not need to come out. But again, that doesn't seem to be the case. Intramedullary devices, it's the same thing. Maybe they don't come out as much, but they're not good for some fractures, especially some comminuted ones. So I would pose this question to everybody, that if the rate of non-union is still relatively low and the rate of reoperation after ORAF is pretty high, should we just resist fixing so many of these and only treat the ones that are symptomatic non-unions or, that are really symptomatic for patients. People will say, well, if you try to do it later, then maybe you're going to have a worse result. Somebody's already looked at this. This was back in 2007. This actually came out just a little bit before the Canadian study. And there was 15 patients, not a huge study, who had ORF and 15 who had delayed reconstruction. They were looking at shoulder strength and basically found no difference. So the shoulder flexion, these were people who were fixed later, delayed reconstruction. Their strength was the same as if you fixed them acutely in terms of flexion, abduction, internal and external rotation. There was a slight difference in endurance in terms of flexion, and a 6-point constant score, which if we believe 10 is the magic number, then 6 is basically meaningless, and no difference in dash scores. So in theory, we could do this and it would be fine. The AAOS put out a clinical practice guideline in 2022 where they looked at lots of these, so you'd say, well, maybe here's the answer. But when you look at all the recommendations and they rate these with the quality of evidence and then a strength of a recommendation, most of the recommendations in it are moderate or low in terms of the strength of recommendations. Some of them are just consensus opinions. This is the only one that reaches the 4-star strong evidence, strength of recommendation. And basically it says, yeah, if you treat them, that you'll get a higher union rate and better early outcomes. But you can do anything, you can do either, because in the long run, it's going to be the same. So I think that's sort of the take-home point, is that there's a lot of wiggle room in these. I think we are fixing tons of them. If you look at some of the data and the ones that get fixed in the US, it does skew towards patients that have sort of better insurance, which could be problematic, that maybe that's why some of these are getting fixed. So personally, I sort of fix the ones that I think I can actually make a difference on, where there's a compelling reason to do something for that. This was one of these guys. This was a 25-year-old guy, right? Initially, this looks totally fine, 100% non-op. But he comes back in 2 weeks, and he's shifted into this Z deformity with this little spike there. And that's what he looks like with his skin tenting. He was still resistant to have surgery. He couldn't move his shoulder at all. It hurt. It looked like it was blanching the skin. So we kind of emphasized to him this would probably be a good idea to have it. He eventually decided he did want to have it. We reduced it with this little mini plate to sort of hold it at first, and then put the anatomic plate onto the top. And this was him 6 weeks out. 6 weeks out, he had no pain, was pretty much moving it completely. And by 16 weeks, he's already forming mature bone. See if the video will work. And this was his motion. He's super happy. He actually works as a does stuff with bicycles, so he rides his bike around all the time and lifts bikes around and does all sorts of stuff. So I think if you have a good indication, it's a good surgery. Patients do seem to do better early, but by no means do we need to fix all the ones that I think we're fixing.
Thank you very much, Robert, sir. And it is like question by Shakespeare, to be or not to be. But then the pendulum has swung, and you have to judiciously decide when to operate. After having heard this, I think the more you become senior and rather not senile, you try when not to operate. Can we have next speaker, Jay Shankar, sir? And it was a sheer coincidence that he reminded me that we have worked together in Germany, Tübingen, some 3 centuries ago. He's going to talk to us about C3 types of distal humeral fractures and fixation about it. Over to you, sir.
Thank you, Dilip. Unlike the previous speaker, the clavicle fracture, here 99% you have to operate. So this is a place where you have to operate. So this is very focused on C3 distal humeral fracture. And the complex, looking at this picture, you can see the complexity of the distal humerus. Unlike the proximal humerus or distal radius, look at that configuration, it's very complex. Imagine when this complex configuration of the distal humerus breaks into multiple pieces in C3 type fractures, it is really a difficult situation to fix it. So the lateral column is teardrop and the medial column is triangular. So this is the kind of anatomy you're looking at. Usual clinical assessment before you undertake surgical stabilization is almost 99% you have to operate these fractures if you want to have a good outcome. And there is a 1 or 2% where you don't operate as well and leave your bag of bones in elderly osteoporotic fractures. Surgical options, and we have 180-degree plating and also 90-90 perpendicular plating. Most of you are very familiar with this plating technique. If you want to have a good visualization of C3 type fractures, you have to see there are various approaches: paratricipital, tricipital, and olecranon osteotomy. This picture clearly shows the yellow one is how you visualize the distal humeral fractures. You can see only by olecranon osteotomy, you can actually see the entire distal humerus very well. So it is very, very important you treat all the C3 type fractures with a olecranon osteotomy to have a very good look at the fragments. And this is a chevron osteotomy, the workhorse of the distal humeral fracture exposure. And so where do you do the olecranon osteotomy? And that is, as it's shown in the picture, there's a width of bare area available there in the olecranon. That's where you do perform a olecranon osteotomy. So that is, once the osteotomy is done through the bare area, that's the exposure and where you see the multifragmentary distal humeral fracture. The comparison between the 90-90 versus 180-degree plating, parallel plating, the same functional outcomes. 90-90 orthogonal is very quick recovery, very quick surgery, and parallel is very quicker union. Parallel better for very distal fractures, and variable angle LCP make parallel more easier with multiple variable angle screws. And absolute stability at the articular block, it's better once we have reduced it and fixed it with KOS, if you can fix the articular back, the absolute stability with the intra-articular lag screw. And then you have a point reduction forceps to compress, or you can put a K-wire till you fix the columns and come back. There are all various surgical steps. Once you reduce with K-wires and the point reduction forceps, temporary stabilization with the K-wire and reduction forceps. And then you go and fix and lock, fix the lock plates by first fixing the anatomical plate to the proximal fragment and with the cortical screw, and then lock distally. You can go select a column which is easier to fix to start with, not necessarily one column over the other. And this is how the various steps of the operation shown diagrammatically. Once you have the one column fixed, go to the other column, difficult column, and then fix the proximal screws and fire the screws from the distal articular block. So that is a parallel plating. And for further compression, you can, as shown in the picture, you can still apply compression and releasing one of those cortical screws and then compress the distal fragment as it's shown, and you can get a further compression and increase the stability of your fixation. So that is proximally cortical or locking screws is 3.5, distally 2.7 or 2.4, and variable angle LCP plates are available, which are very you have a freedom to use your angle and go into the distal fragment. So that's again the parallel plating, 90-degree orthogonal plating. Ideal to get at least 3 screws in the distal fragment. This is all diagrammatic fixation, representation of the fixing the lateral column first and firing the screws and then going to the medial column. And once it's fixed, you can also add a lag screw whenever there is a metaphyseal fragment, which is, you can use a lag screw also. See that there is no screw inside any joint. It's very, very important. It's very easy to get into the olecranon fossa, and then so it's very, very important to see that this mistake doesn't happen, because if you just overlook that, you will have very poor function of the elbow. So always see that parallel or orthogonal fixation, always see different length of plates, as it is seen to avoid stress riser. And again, there is a olecranon osteotomy, various ways of fixing it. Circlage and compression wiring is a routine time-tested fixation. You can also do an intramedullary fixation and a plate fixation if there is a comminuted fracture of the olecranon. So, depending on the method of osteotomy fixation, you can actually pre-drill for the later fixation, and then that is very useful when you complete the procedure. You can actually stabilize the olecranon osteotomy much easier. So some examples, 59-year-old female, RTA, that's the X-ray picture, and that's exposure of the olecranon osteotomy, C3 type fracture with a lot of intra-articular comminution, and identify the ulnar nerve, see that protected all throughout the surgery. And that will be the first step to do actually in this exposure, and that's the fixation of the lateral column. KY is holding the intra-articular reduction, and lateral column fixed first, making C-type fracture to B-type fracture, and that's introp picture of the fixing the medial column, and then you come to the, you're still maintaining the KYF for the distal block, and then fixing the interfragmentary distal articular block. So once medial column is also fixed, see that ulnar nerve is safe, and osteotomy close with the tension band wiring of the olecranon, and that's the post-op picture of both medial lateral column olecranon fixation, and there's another distal humeral fracture. Looked like, only when you do a CT scan, you can see the comminution and the intra-articular component and comminution at the intra-articular block, making it actually a C3 type fracture. Lateral condyle with capitulum and medial condyle with trachea. So I would stress on this point, the CT is a must on all this intra-articular fracture, not only with the elbow, in all the intra-articular fracture, CT is a mandatory now to understand the fracture fragments and to plan fixation. So that's the after fixation of the lateral and medial column, and ulnar nerve being protected, and you need to continuously monitor, see that ulnar nerve is safely kept away from the instrumentation. There are some intra-articular pieces of the articular cartilage, loose fragments are taken out, otherwise they become a loose body, and it will be a problem later. So remove it, otherwise they will become a loose body. So very important to remove all the small. There's sometimes tendency to keep all those loose fragments. I think it's important to remove that, otherwise they'll become loose bodies. And this is the immediate post-op of that patient with stable fixation. After removal of the comminuted pieces, 75% of the articular surface was intact, so it was lagged with the lag screw, lateral column plating, and the medial column plating. And look at the length of the plates. The length should always be little longer, one plate must be little longer to avoid the stress riser. And that is 6 weeks post-op. And that is 6 months post-op. And that is at the end of 6 months. And look at the complete function, total function of the elbow, flexion, extension, rotation, and all that. When you fix a C3 type fractures and achieve this kind of a result at the end, you feel really very glad about it. That should be the function. That should be the stability of your fixation, and then you start mobilizing from day one. And another 52-year-old male, diabetic, RTA, and looks like C1 initially. And once you do a CT scan, you can see a intra-articular comminution, large medial column, and very distal lateral column fracture. So that's again the articular block locked with locking screws, and that's a 2-column fixation. And 4 years follow-up with excellent function of the elbow. So that is after a good stable fixation of the intra-articular block on both columns and immediate post-operative rehabilitation with the elbow movement, and that's the result. So you should never leave this patient. You should have some plan and in your institute to follow up this patient on a long term. Only these long-term follow-ups will show you all your whether you are doing a good work or there are complications. It's very, very important to lure them and get them back for a follow-up. That's another 38-year-old male, RTA, intra-articular comminution. Yeah. I think here I used the variable angle plate after initially exposing and fixing it with K-wires, multiple K-wires initially, and then the lateral column fixation first. And there's a variable angle, and then that allows us to put your screws in various directions. You can actually, it gives you the freedom to apply your lock screws. Here actually I applied the compression clamp, all the pointed reduction clamp, applied the lateral column and then the medial column, and kept the intra-articular block with the K-wire, and finally I put locking screws which came across the articular block. So that's the sequence of fixation. But you need to keep maintaining the intra-articular fragment compression by at least reduction point, reduction forceps, and the K-wire fixation. Instead of following the intra-articular block, I fixed the lateral column first and the medial column first, and finally came and put lock screws, variable angle lock screws on the distal block. That's the final picture. That's the post-op, immediate post-op. So drawbacks, oligrenal non-union, only thing of concern here. The ulnar nerve damage, a proper dissection and protection is very important. There is other midline approaches as well, but nothing like a oligrenal osteotomy for a C3 type fracture. So whatever be the approach and surgery, post-op rehabilitation is very, very important if you want to achieve a very good function of the elbow. Reduction is paramount for intra-articular fractures. Good visualization and good reduction and oligrenal osteotomy is the best in complex fractures. Choose stable fixation that allows early mobilization. Rehabilitation is as important as surgery. Thank you.
What an excellent exposition of the distal humeral fractures, C3 type, most difficult. And I must compliment you, your olecranon osteotomies were fixed so well. The wires piercing the anterior cortex, the wires like umbrella hook and hammered into the bone. If you do it that way, I think you don't need any other system, but we'll discuss about that. And normally ladies are first, but this lady is going to be the last speaker, and she's going to talk to us, Christina, on complex proximal ulna fractures and dislocations.
And apparently also intertroch still. So it is 5:30, and we are about to start complex proximal ulna / elbow fracture dislocation. And so that basically translates to me to be the worst day ever, to be starting a case like that now. So let's fly through this case. So complex proximal ulna fracture dislocations, or elbow fracture dislocations, whatever you would like to call them, can be really, really challenging. I mean, they can be really terrible injuries that are really hard to put back together, especially if the bone is not good. And they can have a radial neck or head fracture, coronoid fracture, ligament injuries. There can also be distal humerus fractures, and then on top of all those things, there's the complex proximal ulna fracture. And so to me, this is proof that things can always get worse, right? So we talked about terrible triad injuries yesterday. We just talked about complex distal humerus. So if we have all those things together, and then we also have to fix a comminuted, ugly proximal ulna, it's a bad day. So elbow stability, though, is reliant on the ulna. And so the ulna humeral articulation is one of our primary stabilizers. It really matters how we put the ulna back together, and that's going to have a long-term effect on the stability of the elbow. And so if we take a quick look, just a little refresher on where everything lies on the lateral elbow and on the medial elbow, we want to sort of think about where some of the common fracture lines are. We'll put in the ligaments first, and then we'll look at some of the common fractures in a second. So here's some common fracture lines that you often see through the proximal ulna, and those will disrupt essentially not just the bony stability itself, but essentially the attachment of everything important. And so there's some debate, and some people feel very strongly about this, so I apologize if I offend anyone who does, about whether we classify things as transolecranons or Montesia variants or anterior fracture dislocations or posterior fracture dislocations. And I would argue that it doesn't matter what you call it, as long as you're able to understand all the pieces of the injury that help you understand how to treat it. So both a classic transolecranon and a classic posterior fracture dislocation or a Montesia variant can have the radial head fracture, the coronoid, the ligament injury, and can have joint impaction. And so to me, I usually tell my residents, don't call it something, just understand what it actually is. And part of the reason for that is I think it's a huge spectrum, right? So if we're going to put things into little boxes or buckets, then what are these? How do these fall into those buckets? They don't, right? And then here's a whole bunch of other ones on a spectrum of injuries. So I think, complex proximal forum or elbow fracture dislocations is a whole spectrum of different injuries, and some can be really ugly and some can be really friendly. And so I think the pre-op imaging is key. I don't request CT scans usually for my distal humerus fractures, sometimes not even for my proximal humerus fractures, but I always like to see a CT scan for the proximal ulna. And I think it can really tell me a lot about what the injury is, because I think sometimes a plain film like this will not look that exciting. And then when you get the CT scan and you really get a sense of what all the pieces are, how small those pieces are, what may be attached to each piece, and how they all interact, then I think it really helps you understand how to treat it. So when I look at this injury, I sort of look at the coronoid tip separate from the anterior ulna and the coronoid base fragments. Those are sort of three different areas. I look at the lateral wall blowout as well as the segmental ulna fracture, and then the radial head and neck fractures. So this is a comparison to a different type of injury that you may classify as the same injury, but it has a very different combination of pieces that's going to make the fixation significantly more straightforward. So this has one large coronoid fragment. There's a comminuted olecranon on tip, which may make things more challenging at the end, but may make the start of the case a little easier. And then there's really no radial head involvement in this second fracture, so that changes the game a little bit too. So when you're making your surgical plan, I like to think about positioning, approach, fixation order, the construct I'm going to use as my final construct, and then different augmentations. So this is nothing new to any of you, but for me, OR positioning, some of these I will do supine, and some of them I will do from a posterior approach, usually in the lateral position. So the ones I do supine are the ones that I think have complex radial head and neck, ones that look or feel a little bit more like a terrible triad, or ones that I know that I'm going to go medial for. The ones that I tend to do from a posterior approach are usually the ones that have the worst proximal ulna fractures. And then the order of fixation, we did talk a little bit about this last night in the case for those of you who were there, but very similar to a terrible triad, right? You work deep to superficial, you work distal to proximal. And each step I usually try to ask myself, is what I'm doing going to make the next step easier or harder? So am I getting in my own way, which I think is something that's very easy to do in a complex fracture dislocation around the elbow. So I often will start with the coronoid tip, and there are definitely people out there that think the coronoid tip doesn't ever need to be fixed, or needs to be fixed in some cases, but not other cases. Typically what I will do is as was described last night, I will lasso it, just the anterior capsule with a suture, in case I need it later, basically, because it's very hard to go back at the end of the case and lasso that. You really have to do it at the start. That's when you have access to it. So I will put the suture lasso, usually for me a number 2 Ethibond or a fiber wire, into the anterior capsule, and unless the piece is big, I will ignore the piece itself. And so what that looks like is this. This diagram obviously doesn't have a proximal ulna fracture, but it just sort of gives you the idea of what the lasso looks like. So I do it first, and then I work through the ulna fracture, usually to access it. And then I think the key thing you want to think about is, where are those suture lines going to go? Are they going to go through drill tunnels in your ulna when you've got it reconstructed, or are they going to go around the edges and tie over a plate or tie over the bone? Then I usually move on to the radial head or neck, and there was some talk last night about, do we fix the radial head, do we replace it, do we excise it? For me, in an unstable fracture pattern like this, I would never excise it because the elbow is already very unstable. So I would never leave it out. And so if the neck is involved for most people, then I will replace it completely. If the neck is intact and it's a portion of the head, I usually will try to reconstruct the head. That's not necessarily right or wrong, that's just the way that I approach it. And so I would usually address radial head next. And so here's an example, kind of looking in through the fracture at what you have is olecranon on the side, ulnar shaft at the top, and those fractures are gapped open. They're not addressed at all. And then you can see that thing that looks a little bit like a kidney bean is your radial head sticking out, and then your distal humerus. So this is essentially the elbow is flexed up like this, and you're looking right down onto the fracture. And so I usually will try to work through the rent that the radial head or the radius created when it dislocated. So I almost never will go in and have a plan to make one specific surgical approach to the radial head. I will look and see where the radial head itself poked out through the muscle and kind of develop that interval. I'll usually fix it and reduce it, or prepare and trial the radial head. And then I confirm the radial head sizing once the ulna is reduced. So I don't often put the final radial head size in until I have at least clamped the ulna or pinned the ulna and brought it out to length to make sure that I'm happy with the size. Because I usually will compare the contour of the proximal ulna with the contour of the radial head in place, usually with the elbow and extension on the x-rays. And so here's just an example of a head in there, and then just a little traction will pop it right back into place. The final radial head is now in place, and the final fixation is on the ulna there. So for the radial head, there's, like I just talked about, there's either fixing or replacing. And for me, the key point is how involved is the neck. Essentially, am I trying to reconnect a floating radial head or an almost non-existent radial head? I usually won't waste the time to do that because the outcomes functionally with the radial head replacement are very good, even in a young patient. And so oftentimes when I'm doing my approach, I have to ask myself, am I going to address every single part of what's going on here through one big, long posterior incision, or am I going to make a separate, smaller lateral incision through the fascia to work on my radial head? And I only do that if there's no place where the radial head dislocated and tore through the fascia, or if the radial head fragments are stuck anterior where I can't get them. So I've sort of like gapped open the fracture. I've tried to get them, but they're stuck up in the anterior aspect of the arm, and I just can't access them any other way, and I at least want to get them out of there. Or if I have an anterior dislocation. And then I move on to coronoid base, ulnar metaphysis, and the areas of impaction. And that's the fun part. So if there's a larger coronoid fragment, I typically will reduce that under direct visualization. It's maybe the only time you get to stare right at the coronoid and right at that articulation. And then I usually will put small screws in, as you can see in this diagram, and those often are just, once you close the rest of the fracture down, they're just intraosseous. You'll never see them again. And so we hope they don't get infected. And then I think we can move on from here. This is often what I use my little dental pick to hold that fragment down as I put wires in, because obviously if you just put wires in, you just, push the fragment away from you. So here's just an example of that. We have the coronoid fixed, and now we're sort of trying to fix the coronoid, we have the coronoid identified, and we're trying to fix it back to the shaft or the metaphysis. And then I will often raft some areas of joint impaction. We've heard that talked about several times today in all the different fractures. They do the exact same thing in the elbow. And there's that little, you can see that one little fragment piece right there that we're going to raft up with that 1K wire. And then I'll complete the rest of the fixation for the one fixation, or what I consider sort of putting the very top, very proximal part of the ulna back to the rest of it. And there's lots of different ways to do this. Sometimes I will do it with an intermedullary screw. In fact, probably more often than not, that first construct is the construct that I would use. That's just a 6'5" non-cannulated screw from the large frag set with a washer and around some mini fragment plates. Sometimes I will use a plate, but it has to be very comminuted in lots of different planes for me to use the plate, partly because I think those plates are always symptomatic, and I prefer the hardware to be away from the soft tissues as much as possible. And so just to recap our fixation construct, we have rafting K-wires, I have a little medial and or lateral mini frag reduction plate on, which I use a lot. There's the intraosseous coronoid lag screws, and then I either do a plate or an intermedullary screw for fixation. I very often will augment with suture up into the triceps as well in anybody who has bad bone, and that's just really to like offset the pull, the distracting force of the triceps by tying that into the plate or through drill holes into the bone. And so now we're on to check stability and plus minus repair additional ligaments. So in a lot of these fractures, when you repair the fracture, you restore the ligament attachments because they are attached to the fracture fragments, but that is not always the case. So just like as was described last night for the terrible triad injuries, I do this drop arm test where I just literally have the elbow bent, I have it up on a bump, and I just kind of violently actually just let the arm go and see what happens to it under fluoro. And if I can't just drop it and let it go and have it stay in place, then I don't think the patient will have it stay in place post-operatively. So if I see that there's some residual instability present, then sometimes I do feel like we need to go and correct that. So if you can see this first picture, you can actually see that the joint is gapping and that there's a good amount of laxity still in there. And this particular patient had a little avulsion fracture off the condyle of the distal humerus that needed to be fixed to completely restore the ligaments. And so this EUA was mostly just to prove that we needed to do that. But we needed to kind of restore it circumferentially. So from start to finish, even though we have kind of talked about all of these things, just to recap, I try to look at the CT scan to truly understand the pieces and the elements that I have. And then I tend to work from deep to superficial, from distal to proximal. And I often will use K-wires, as you see there, intraosseous lag screws into the coronoid fragment if it's big enough. I will also have my suture loops in the anterior capsule brought down. A lot of times you actually don't need those, but I put them there just in case, and I will often just tie them loosely over the plate or over the bone at the end. And so, hopefully, now we're able to look at our injury pattern, forget what it's called, but describe the components of it, and decide how to fix each of those components in order so that each step you make makes the next step easier, not makes the next step harder. That's it.
That was a wonderful knowledge imparted for a difficult situation of proximal ulnar fractures. A jigsaw puzzle well solved. We have around 15 minutes for question and answer, but if there are less questions, we may abbreviate that. So may I have Dr. Jayesh from Mumbai? Yeah, come to mic number 1, please. Please address the person to whom you want to ask question.
So this is for Dr. Jayashankar. You sometimes in a distal humerus fracture, especially on the coronoid part, in an osteoporotic bone, we have a bag of bones, and it has a coronal split also of the coronoid. This is very difficult to approach from the posterior aspect, and again, that entire column to be fixed becomes very, very difficult. And there is a bone loss also sometimes where you can see that there is a gap. So how do you tackle these situations?
Just can you come again on this?
So in an osteoporotic bone, sometimes on the lateral column, there is a coronoid, the capitulum is split in the coronal plane, and there is a bag of bones with, sometimes there is a gap in the column because of the compression forces. Now when you try and restore it, you see that there is a gap in the column, which might be needed to, you have to put a tricotyl graft or so. So
I think
how do you tackle all this?
Osteoporosis on the gap in the column, you can put on a graft. I think you need to plan it in advance so that you put an iliocrest graft so that make it more stable.
And if there's a bag of bones which is very difficult to reconstruct when you have that lateral column?
In the young, I think even the bag of bones, you have lot of small headless screws. You need to take time to fix all those things. You need to understand much better doing a CT scan, and then a lot of preoperative planning and a lot of instrumentation during the intraoperative period, small screws, headless screws, K-wires. You can leave those K-wires, cut them and all that. So reconstruct all those fragments and then put a column fixation. So it's going to be. In elderly people, I've also left without fixing the bag of bones in very extremely osteoporotic fractures, and I just immobilized for about 2 weeks and then started mobilizing. I mean, in very elderly osteoporotic, where I'm very scared to fix anything. That might invite a lot of complications than leaving it alone.
Thank you, Dr. Jayesh, and may I request Dr. Khandaka from Jaipur to ask his question.
My question is to Christina. So when there is combination of the proximal ulna and you are operating them in a prone or a lateral position, so how do you hold the fragments? Do you sometimes use a kind of mini external fixator to hold the fragments? So what is your strategy to hold them together, particularly in a comminuted fracture of proximal ulna?
So sorry, is your question, how do I put them together, or when we're lateral, how do we put them together? Is it about the patient positioning?
For a kind of temporary
yeah.
fixation.
Yeah. Yeah. Yeah, so so partly that's what I use those little mini fragment reduction plates for, but almost always in the lateral position I will have the Mayo stand padded and then extend the elbow so that it's not distracting the fracture. I think that helps a lot. But I'll usually use that little mini frag plate on the medial side, little mini frag plate on the lateral side if needed. and that will hold sort of like little 2O screws, will hold many of those tiny little fragments in order to put the final plate or long screw in.
Because the weight of the arm keeps them apart. The gravity or weight of the arm, so it's very difficult to bring them together in a comminuted situation.
You mean like with the elbow bent?
I think you have answered it. Thank you.
Yeah, okay.
May I ask Dr. Robert, have you tried anterior plating or intramedullary flexible wires or so for clavicle fractures?
So I've not done the intramedullary because most of the time I think if I'm going to fix them, I want to make sure it's reduced and opened and all that. I'll put anterior ones on some patients if it looks like the fracture pattern is more advantageous for that. But most of the time, I think the superior plate sort of is in the right spot and it's resisting sort of the force that you're having. So it makes more sense for me to put it on top and push that piece back down because that's what you're trying to prevent.
Over there, sir. Please introduce yourself and ask to whom you are asking.
Humerus fractures. So do you use bone graft while operating on, because you have been using interfragmentary screws, so do you believe in bone grafting such cases?
I haven't bone grafted one of these in more than 10 years. If you get a good reduction, you don't need a bone graft. If you have gaps, you need to keep working on your reduction. You're not done yet. So these are, the bone is all there, and it can be pieced together. It just takes time and effort and
So
care.
regardless of the duration of the non-union, you do not use the bone grafting in
No,
routine?
I haven't used bone graft in this in more than 10 years.
My question to Dr. Jaishankar. I'm Dr. Iqbal from Amritsar. So, in case of dual plating, what should be the minimum difference between that two plates to avoid that stress rise, sir?
The length of the plates?
Yeah, length of the minimum.
It's nothing like minimum. It must be little longer, say, for example, 3 screws above. Between the two plates, if you put 1, 2 or 3 plates above. So it should not be at the same level. That's the whole thing.
Means minimum 3 holes.
3 holes above, the longer plate.
Hello. Yes, please. My question to Dr. David. How we will manage a displaced lateral third clavicle fracture, recent fracture in a 65-year-old person? Displaced lateral third shaft clavicle fracture, whether to fix or how to manage it?
A lot of those I'll still fix especially if they're sort of floating away. Some of them I don't think you need to. So some of it I'll just see what their function's like, and if they're moving their arm around okay and it's not bothering them, I think you can leave them. I have used hook plates a fair amount in the past. I don't love the little hook plates. Then you usually have to take it out. It bothers people, and you'll tend to take them out after 3 or 4 months. A lot of the new plates with all the pre-contoured and there's tons of the little locking options very distally, so you can get those in fairly well. If it looks like it's a pure ligamentous one, or mostly ligamentous, then sometimes I'll give it to one of the sports guys who does a CC ligament reconstruction to pull it down just to make it sort of more functional. Probably not in an older person, but in some of the young people with the very lateral ones, we'll do that.
Another question, in a segmental fracture of the clavicle, whether you would like to plating or an intramedullary fixation, which will be the better option for that?
So I don't do any of intramedullary with clavicles. I just don't have experience with that, so I always just plate them. And again, you can get the pre-contoured ones come pretty long. You can span almost everything. Sometimes they don't. So then that's sometimes where you'll end up doing a dual plate, where one of them will be anterior, one of them will be superior, so you can overlap them and get the whole thing.
Yes, sir, you can come over.
Good evening to everyone. Excellent lectures, thank you very much. I wanted to ask to Christina ma'am, what is the non-operative protocol for the proximal humerus in the elderly? what do you apply? You use U-cast, use slabs, or just braces, or do you use a bolster in the shoulder to counter the medial shift of the shaft?
For my closed treatment, is that what you're saying?
For the non-operative
Yeah.
treatment.
I mean, I literally just put him in a cuff and collar. That is all I do. I put them in a cuff and collar, and then I talk to them to make sure they really understand how that works, so they really understand that the weight of the arm and the elbow is supposed to be pulling down, because I think that's counterintuitive to the patient and the family. They think, oh, we need to support the elbow, it's hurting them. But I really try to explain that that the point of the cuff and collar is to straighten it out. I haven't had a lot of issues where we need the bolster. That may just be luck or body habitus in the American population, who knows? But I haven't put bolsters or anything under there, anything more sophisticated than a cuff and collar.
Thank you, ma'am.
Can I ask you, Jai Shankar sir, we had anatomical plates in 1990, whereby rather than having one screw, which makes the distal fragment into one piece, they have tangential screws. Are you still doing those tangential screws, or you're using one medial to lateral or lateral to medial screw to make the distal humeral end into one piece?
No, I think I showed many times I fixed the articular block so that you get your interfragmentary screw there, and then see that your articular block is well fixed. And then you go ahead and fix and put as many screws as possible across the articular block. That's what the question you asked?
Yeah, we used to use that PCD, pointing and compression device.
I don't think, yeah, that's right.
Yeah, PCD.
Even there's a compression device in the AO where you compress.
Positioning and compression device.
Putting the articular block screw, you can actually fire screws after putting the compression device, yes.
That's wonderful, and I must appreciate all the delegates who were present till the last moment. This kind of enthusiasm is much less. So thank you very much. Good things always end. But there is one more question over there. I see your spirit very nicely. Dr. Tarun, allow last question, please.
So for clavicle fractures, if the patient is a young sports person who needs a lot of good shoulder function for his sports, young, active sports person, will you change your indications for surgery in an acute setting?
Yeah, some of them I think so some of them it depends on what they need to do. And some of it I think is also not just the sports people, but some of the guys who are super active just with work and that sort of stuff. I think there is a difference, and again, this is pure anecdotal. I mean, there's some evidence that he showed that there's a bigger spread initially. A lot of data, a lot of the other studies don't really show that. If you really dig into them, it kind of gets lost in the wash. But I think there is a much bigger improvement early on these. Most of these guys, when they come back for their 2-week post-op, their motion's almost great at that point, and the pain's much better. So the young guys, especially if they're somewhat competitive athletes, I have one guy who's a semi-pro cyclist who's broken his clavicle, I don't know, 5 or 6 times at this point from crashes. But he gets fixed and he goes back to racing probably way too early, but he does. And I think it's the same sort of thing with some of these sports guys that are, that's part of their definition of their life. So I think it's legitimate to do that for them.
For floating shoulders, having humerus fracture as well as clavicle fracture, or polytrauma, is it prudent to fix them so that they can be mobilized?
Well, you can't. So floating shoulder used to certainly be, quote unquote, an absolute indication. I think the more recent stuff has shown that's not necessarily the case. We will tend to lean towards fixing more of them in some of the polytrauma people if they have lower extremity injuries as well, to help them just weight bear on them early. But again, that's sort of more, that's kind of what we were always told to do. And if you look at a lot of the literature, I'm not sure it's actually supported, but it's certainly something that we consider and often will do.
Okay, thank you.
Can I just add 1 second? Can I just add for your first question? My colleague, who is a spine surgeon, young surgeon, he does cycling every day, goes for a cross-country marathon. He sustained a undisplaced clavicle fracture. He was adamant on fixing it. I said, I won't do it. He got it done by another surgeon.
That is another indication.
Yeah, that's what I'm telling. Yeah.
Hello. Yeah, in distal humerus fractures, if there is a very low transverse
Never-ending story, huh? So let this be the last question.
Yeah,
of
last
the day.
question of the day. Distal humerus fractures, lateral column comminuted, and if the medial column is simple low transverse fracture, you have any experience of putting medial columnar screw only, lateral plate, posterolateral plate, and medially?
You start with the, you said the medial column is undisplaced, right?
And, no, it's a fracture.
Lateral column is comminuted, right?
Lateral is comminuted.
So start with the medial side, fix everything, articular block, and then bridge the comminution on the lateral side.
No, sir. I'm asking whether medial column, only columnar screw is enough.
I don't think so. You need to fix the both columns. If you want to, your fixation stable and mobilize early.
Fix with the plate and screw. How about putting only the screw?
For the other side.
Hello?
2 plates. Put 2 plates on it. Just put 2 plates on it. Because if
Yeah,
it falls
yeah,
apart, then if it falls apart, then you'll think like, oh, why didn't I put 2 plates
A
on
little
it?
hypothetical, I'm not able to understand. Probably if you show the picture, I will be able to see.
Sir, in such situation, is it okay if we fix the lateral column with a plate plus medial column with only the screw?
Only the screw.
Columnar screw.
Where it is not the
comminuted.
Not comminuted.
Yeah.
You can, yes. If you get a stable screws on the...
Yeah.
Yes.
Okay, thank you.
Little
Positively, the
hypothetical-
last question of the day, and may I request the photographer for this session, you can take photograph of all of us. And Dr. Tarun, your housekeeping announcements also are important, so let everyone know what's happening tonight.
Thanks to all the faculty and chairperson for this session. I would like to thank all the audience. You have been an amazing audience, and I'm seeing good amount of people sitting till now, and I can understand the quest of learning through these various discussions which are happening. So I would like to thank everyone for today. We'll be ending our day 1 today, and tomorrow morning, 10 o'clock, we will be starting, where we are having very, very interesting sessions. Particularly, we have a session completely on controversies in orthopedics. So I would request everyone to be part of this. Tonight at 8 p.m., we have a gala dinner here with a music band coming, and they will be performing live. Enjoy your dinner and drinks, and see you tomorrow at sharp 10 a.m. Thank you.